Hello.
Hello, testing. Hello, test. Hello,
Hello. Check. Hello. Hello. Hello.
hello. Check.
Check. Hello.
Good morning, respected faculty, distinguished speakers, and dear colleagues. It gives me immense pleasure to welcome you all to the CME Nurture 2025 in Obstetrics and Gynecology. CME platforms like this remind us that learning in medicine never ends. With science advancing at rapid pace and clinical challenges becoming increasingly complex, it is vital that we update, exchange, and refine our knowledge. Today's program has been thoughtfully designed to highlight both common and critical issues in our field, with sessions that combine evidence based updates, practical insights, and interactive discussions. Whether it is high risk obstetrics, or evolving concepts in gynecology, or advances in fetal medicine, our aim is to bridge gap between research and practice. On behalf of Aster Ramesh Hospitals, I extend a warm welcome to each one of you. Let us make today's CME Nurture 2025 not just a day of knowledge sharing, but also a collaboration and inspiration as we continue our journey to provide the best possible care for women and their families. Apurva, take over the first session.
Good morning, everyone. Moving forward with the session, Navigating Infertility Together, I request all chairpersons to come forward and mentor the session. Dr. Padmaja ma'am. Ma'am was president of Vijayawada Obstetrics and Gynecology Society. Ma'am has actively participated in various state and national conferences and has many awards to her credit. Dr. Uma Shankar sir. Sir is chief consultant and laparoscopic surgeon at Ahalya Fertility Center. He has presented several papers on infertility in many international conferences. Sir was first person to introduce the concept of budget IVF to suburban cities in India. Dr. Sujata ma'am. Ma'am was secretary of Vijayawada Obstetrics and Gynecology Society. She is a chief consultant at Oasis with over 25 years of experience. Dr. Aruna ma'am. Ma'am is prominent gynecologist and infertility specialist in Guntur. Dr. Anita ma'am. Ma'am is senior consultant and gynecologist at Pragati Hospital, Guntur. I now invite the speakers. Dr. Anuradha ma'am. Ma'am is director of Anu Test Baby Center, Hyderabad. She is fellow of RCOG, London, UK. She worked as consultant. I now request Dr. Anuradha ma'am to come on stage, please. She's director of Anu Test Tube Baby Center, Hyderabad. She's fellow of RCOG, London, UK. She also worked as consultant Midland Fertility Services, UK. Ma'am established IVF unit in Hyderabad in 1994. She delivered the first IVF baby of combined Andhra Pradesh in 1995. I request Dr. Swapna ma'am to come on stage. She's director and clinical head at Komli Infertility Center, Ramesh Hospital, Guntur. She has gold medal in MS OBG. She has 14 publications in index journals. She's faculty at various national and international conferences. She has Best IVF Center Award 2021 from MedLife Asia Healthcare Groups.
Good morning, everyone. I think one of the what we call things that we can't get back in life is time. If you lose money, we get back. You can't get back a relationship that is broken. You can't get back the time that is wasted. So let's not waste any time. And since we have Dr. Anuradha with us, it will be nice because Madam was the first fertility specialist in Andhra Pradesh, one of the first persons in South India. And Madam was trained with Bon Hall, which is the seat of where IVF started. So Madam has been seeing all the changes that have happened in this field, and she is a living witness of where we started and where we are now. So I wanted to ask Madam, I mean, we never had time for conversation, and we are going to use this now. When you started, how and what were the type of clients who used to come, and what is the change in the scenario of the couples who are coming for fertility issues over the decades that you noticed?
Actually, when I started, I wanted to do infertility before I come back to India because we always wanted to come back after 3.5 years of stay in UK. So I thought I should learn something a little different so that I can go and not just do the regular obstetrics. With lot of difficulty, I had a chance to go into an infertility clinic because even at that time, there were only few units in NHS in UK. So in a private clinic with a lot of difficulty, every weekend, whenever I had time, I had to travel by bus for 2 hours and then go to an IVF clinic. And then he would say, no, I won't allow you, or I mean, with lot of hesitance. But then I continued to go for a couple of days, and then he realized how interested I am. Then he let me come in. Then I started looking at the scans. Then he said, okay, on a weekend, why don't you write down the follicle diameters? And then afterwards, he realized that, okay, I'm really interested. He let me come in, and I started observing. So the day came when I had to come back. The day when I was going to come back, he called me, Dr. Peter Bromwich. He said, I'll give you a partnership. Why don't you come back and join us? I said, but tomorrow I'm leaving. I can't just stay now. So let me go back, and then if you're okay, I'll come back. So he took 1 year to get a post for me in his unit, and then I went back and started. So when I was there for those few months, every minute was so precious. I mean, I had to write down even on a tissue paper, I used to write down what kind, even a slide, everything, so that I don't forget what I need. So when we came back, I mean, it was not easy, like finances and the equipment, the instruments, culture media. So when the Dr. Peter Bromwich came to visit us, he brought 7x solution to us, and then at the customs they asked, what is this solution? Why are you taking 10-liter can? Oh, because I am allergic and this is the only thing which I can use for my bath, so that is the reason I am taking. So every solution also we had to get it by hand, even the needles and everything. So now things are so easier, so much more accessible. So definitely it's good for our community so that we can serve more people with more ease and more precision. Those days when I started, it was the age group what we saw initially was almost like 38, 40s, because people knew that, okay, my time is running out. So that was the kind of crowd I had in the beginning. Then later younger people came. And now again, I see more people who are around after 35 only. So if I see 3 or 4 patients in a day, I can see everybody has a low AMH. Everybody is more than 37 and already had lots of cycles IVF outside. So all the, difficult patients we're seeing. So the changes what we're seeing is, one thing is pregnancy rates have gone up, but definitely again, we can see all difficult situations where you see more of advanced stage, and then you can see diminished ovarian disease, which was much lesser in the earlier days. This was the, the change I could see in the last so many years now. And there's so much of advancements now. We can do PGT, there is an AI, time lapse. So there is a lot of advancement, and I think this will go on, and we have to be update with what is happening. Every day there is a change. Every day there is a new thing coming up. So now I feel that maybe it's difficult to catch up with what is going on now.
Yeah, that's so true. And I think with the completion of the Human Genome Project, we started understanding that life doesn't mean just getting 23 chromosomes from the oocyte and 23 from the sperm and just putting them together and then we will have a life. There is so much more intricacy in that, and we, as we learn more, we understand how complex life is, and with so many things that can go wrong, it's a wonder that so many of us are there on this earth. I always keep feeling astonished about how many things can go wrong, but still how nature has managed to give us life in spite of so many mishaps that happen. True. We'll start with Madam. That's what I wanted to do. Okay, we'll have Dr. Anuradha with us to walk us through her experience with fertility. Madam, please. Yes, it's really nice.
No, arrow pointer. So good morning, friends. I think we already started with the introduction. Dr. Padmaja raised a question saying that, okay, if you could have a chance to go back in time, what is it that you would like to get back? Obviously, she gave the answer. She said age. I think that's what is also my opinion. I would like to go back to the age of at least maybe 30, 35, when you are more settled, you are more mature, and you have not so much of financial constraints. When you are a child, you want to grow up. And when you're growing up, then you dream for, I don't know about you, but then in our ages, I'm sure my friend Lakshmi will say yes to that, we will dream for a Prince Charming to come on a horse and pick us up. And then we also would like to have babies, not knowing how they come and when it happens, how it happens, we don't know that. But this is what our dreams were in our generation. But I think the society has changed. In the modern era, I think women are on par with men. They are in the managerial posts, they are actually highly educated, professionalism, and I mean, there's not enough time to give a time for a family also. And now they're not waiting for Prince Charming, but they're waiting for a gentleman in a sports car. So that takes time, it's not so easy, isn't it? So the main age of marriage has increased from 23, which was earlier days, to almost 31. And the peak fertility period for a woman is 24 to 27. So by that time, your actually reproductive age is getting lesser and lesser. This is all because we are giving more importance to the education, career progression, and also finding a difficulty in finding a right partner. Not that we had a right partner, we adjusted with the left one, but still now the generation is not going to be adjusted with that. So these are all the reasons why there is a delay in marriages or delay in having a baby. And when there is a problem, it comes out as a blow to them because this is not what is expected. And we can see that in India also, the fertility rate has come down much more than what we have expected. Obviously because of the lifestyle changes, delayed childbearing, and even advanced paternal age. Even this also matters. Like men over 40 will have reduced sperm counts, fertilization rates are low, and there is an increased risk of autism and other neurological development anomalies also. So it has become a medical concern. A fertility and delay in having a baby has become a medical concern. A lot of infertility couples are approaching ART treatments, and we know that IVF, the first IVF baby was born in 1978, has given us a lot of hope. And in fact, we are actually giving rest of the couples, like all doctors, that with ART you are going to get a good number of pregnancies, and okay, IVF is the ultimate and you can have a pregnancy at any time when you walk in. And now we can see there is a mushrooming of IVF clinics because there is so much of demand. And obviously, why not? Because we are doing IVF now for every reason or no reason also. So there are a lot of women who are having a baby after the age of 30, and this has increased to 6-fold now. And what happens at the age of 40? Nearly 60% of women are remaining childless. Even if they go for IVF also, the pregnancy rates are going to be low. So we understand that age is a very, very important factor. And even in IVF, the pregnancy rates are 40% below the age of 35, whereas it comes up to 10% above the age of 40. So the pregnancy rates fall down so much, and with age also there is an increased risk of miscarriage, increased risk of aneuploidies also, and we can see that the age of 40, nearly 60% of embryos are abnormal when you do PGTA testing. So age is a very important factor in having a pregnancy and a healthy baby. So with age, there is a biological decline in the fertility. If you have around 1 to 2 million eggs at the time of birth, they come up to almost 25,000 by the age of 40 years. By that time, though you have 25,000 eggs, the quality of the eggs actually become much, much lesser. So is there a difference between the egg number and the egg quality? So they actually, they are related, but they are not the same. They are different aspects. So quantity of eggs is ovarian reserve, whatever is remaining in the ovary. And if you talk in context of IVF, it actually explains the ease of stimulation. Like suppose you stimulate the patient, and depends on how many eggs you get, it explains their response and the reserve. So the egg quality, whereas it is a likelihood of egg getting fertilized and resulting in a live birth. That is, they are the same, but they are not the same terms, but they actually denote the chance of a pregnancy. So at birth, nearly 100% of the eggs are normal, but at the age of 35, nearly 50% are abnormal. And at the age of 40, it's almost 20% which are abnormal. So the number of eggs which are going to be normal reduce with time and with age also. So that means if a woman of 35 years age group goes for IVF and she gets 10 eggs, only 5 of them are going to be normal. But if she gets 4 eggs, then only 2 eggs are normal. And in case a woman of 42 years goes for an IVF at the age of, and gets 10 eggs, then only 1 out of 10 is going to be normal. But if she gets 4 eggs, then it's only 0.4. So getting eggs is not enough. You need to have a good quality, which actually reduces with age. We know age is important, but then what we don't really understand is that in the same age group, the woman can have a different kind of a reserve. Some may have a good reserve, some may have a low reserve. This is what not many women are aware of, that there is a large heterogeneity. And when this happens, this is called a premature ovarian aging. It is interesting to know that there is an accelerated decline in the fertility. Suppose a woman is destined to have menopause at the age of 50, then the decline actually starts at the age of 37.5. That means it starts 13.5 years before the actual onset of menopause. And if a woman is destined to have menopause at the age of 40, that means already the decline has started at the age of 27.5, which is so young in fact. And this is what we are seeing more often now. So to defy this age problem, oocyte freezing, which is a fertility preservation, has come to help us to overcome the hurdles of age-related fertility and whoever want to have a pregnancy at a later date. So it helps us to make reproductive choices and opportunity to decide with whom and when you want to have a child, and so that they can be used at a later date. So oocyte cryopreservation is an innovation which was developed in 1980s for fertility preservation, but with the advent of vitrification technique which came into 2000, it has actually increased the pregnancy rates because oocyte was the most difficult cell to freeze. And then after vitrification, it helped in oocyte freezing and the pregnancy rates improved. So in 2012, the experimental label which was given for egg freezing has been lifted, and it has now become a very established procedure. And we could see on the magazines, on the front pages, and that the celebrities were going for egg freezing, the athletics are going for egg freezing. So all that was a lot of hype also given by media, which started from 2014. And even the companies like Apple, Meta, and Google, they started giving insurances and encouraged their women to go for egg freezing. Because if they apply leave, they have to take 6 months, they have to pay 6 months maternity leave. Whereas here you're only paying for the egg freezing and a loss of 1 month. So it's because of their personal interests also, this was encouraged all the more. So it's not for just the sake of social freezing. It is done for other situations also in young cancer patients prior to chemotherapy, radiotherapy, or prior to the surgeries also. And in patients who have other medical conditions, or diminished ovarian reserve. So these are the other reasons also when one can go for egg freezing. So the question is, how is it done? What are the tests which need to be done? What age is best to freeze? How many eggs you need? How many cycles? And how long can it be stored? So it is also very important that you try to maintain the lifestyle before you plan for ovarian stimulation. So if they have time for a couple of months, you should actually advocate them to maintain a healthy diet, healthy exercise. And most of the patients have actually diminished ovarian reserve. And in those situations, supplementation of antioxidants and DHA prior to egg freezing might help in getting at least maybe extra 1 or 2 more eggs, which might improve the pregnancy chances. So the steps of egg freezing are almost the same as in IVF. You stimulate the ovaries, get the eggs, vitrification, and then you pause. Afterwards, when you want to plan, you thaw those eggs and you can plan for the embryo transfer. So nowadays the protocols have become more friendly and the risks also have reduced, which was like hyperstimulation. And you go for most often you go for antagonist protocols, and which reduces the risk. So you can see that the number of follicles which will be developed once they are mature, then one plans for egg retrieval. And most of the times the process is done transvaginally. It is a routine procedure for IVF. But one need to assess the feasibility, because you don't know these patients who are coming for egg freezing, not everyone. Most women are sexually active even before they come for egg freezing, but there are some who are virgins and they don't want to go through a transvaginal procedure. Then if in case you have to go for a transvaginal procedure, you need to definitely have a special consent for that. And in those situations where you can't go for a transvaginal procedure for whatever reason, one may need to think of a transabdominal recovery, which is a little specialized procedure and needs an expertise. So once you get the eggs, you get the cumulus oocyte complex, denude the oocytes and then freeze the oocyte and keep them in liquid nitrogen at minus 196 degrees centigrade for whatever length of time you want to keep. So once the eggs are frozen, whenever you want to go for an embryo transfer, then you need to thaw them, prepare the endometrium and do an embryo transfer. So what are the tests which are required? So we know that ovarian reserve is very important for stimulation, and you need to know or need to explain the prognosis to the patient regarding how many eggs you might get so that they are mentally prepared, and how many cycles. So if you do an AMH test, a blood test, that will help us to understand how she might respond. So the normal is about 3 to 5, and if it is anything less than 3, then we know that the number of eggs what we're going to get are going to be low. So even looking at the scan, when you do a scan, even the patient also starts counting along with us. Look, I have one more extra here. I mean, they count along with us when we do a scan to look for the antral follicles. So why do we really need to have so many eggs? Because when you get eggs, suppose you get 10 eggs, then most of they are all not mature. You have only few of them which are mature M2 oocytes. And once you thaw them, suppose you have 10 eggs which you have thawed, and only 8 to 9 might survive. And again, 4 to 5 may get fertilized after surviving. And from 10 eggs, you may get only 1 to 3 blastocysts, which are good enough to be transferred. So according to this, you need lots of eggs for egg freezing. So the general recommendations are that less than 35, you need to have 10 to 15 eggs, and around the age of 35 to 37, you need 15 to 20 eggs, and around the age of 40, 20 to 30. And over 40, 30 eggs, you can't even imagine or expect that you're going to get so many. Getting 3 at the age of 40 is going to be very tough. We have a patient who is going through an egg freezing right now. She's, planned for recovery tomorrow. She's 42, her AMH is 0.03, and we had 1 follicle. So, but you can't help it, we know, and she's been told that her chances in having pregnancy is futile, that is less than 5%. But that actually gave her more confidence that, okay, she at least has 1 egg and to be frozen, and she might come back for other cycles. So there is no magic number. Whatever number you get, you may have to freeze. But if you have 8 to 10, that gives us a fair chance of a pregnancy. But you don't know how many of them are going to come back at all for the treatment. So how many cycles do we need to carry on? You may have to do more number of cycles even to have 1 euploid blastocyst, especially in patients with advancing age, which is more than 37, low AMH levels or high BMI, and in case they have a low response to drugs. Sometimes they have good reserve, but they don't respond well. We consider it to be low response if they have less than 3x, suboptimal if it is 4 to 9, and a good response if they get 10 to 15x. So how many come back? usually the studies have shown that only 10% of women come back for a treatment again. And what is seen that those women who are older at the time of freezing, they usually tend to come back rather than who are younger. Maybe because the younger women might have already conceived naturally, or they are still unmarried, they don't want to go for having a single woman, being a single woman and raising a child, and lack of suitable partner. These are the few things which may actually stop them to continue the treatment. But most mentally felt secure of their future, and they were more confident and positive also. So what are the side effects? The side effects are the same as with IVF. The risk of hyperstimulation has become lesser with the safer protocols. And sometimes it might even give a false sense of security, saying that, okay, I have lots of eggs there, so I'll come back for a treatment later. There's no hurry for me to conceive. So sometimes it may give a false sense of security also. So it is considered to be safe, and there have been lots of studies which have shown that long-term freezing of eggs does not really increase the risk of congenital anomalies, or it does not increase the risk of physical or mental abnormalities also. So it is considered to be quite safe as IVF. And nowadays there is another approach called one and done approach. There are a lot of people who want to actually freeze eggs or embryos for a second baby. You're not only thinking of one baby. Even recently we had one patient who her AMH is less than 1 and she got only 3 eggs, and she says, no, I want to go for more and more cycles and freeze eggs because I know I want to have 2 babies. So by the end of another 2 years, I lose more eggs, so I want to freeze as many as possible and then start the treatment. So now the couples are considering having more embryos so that they think about having a second baby also. So, I mean, the concept of treatments have changed a lot in the recent times. And we were thinking that it's all happening in Western countries, but there is a lot of raise in awareness in India also, and there are a lot of egg freezings which are being growing, continuing, and it is emerging as a gradually accepted practice also. And nowadays, even on the autos advertisements, you can see IUI, IVF, egg freezing. So now there are a lot of people who are aware that this procedure is available and that can be utilized. But in Indian women, the difference is that if they have a good AFC in comparison to the Western women, because in the Western women, if they have low AMH and low AFC, they respond quite well and their pregnancy rates are better. But somehow in Indian women, you need to really have a good reserve to have a better pregnancy rates. And we've seen that the Indian women usually have a low AMH. And cost also is something which need to be considered, and it depends on the individual clinic. So ERT Regulation Act has come in 2021, which has established a framework, and all the clinics and the banks have to be registered before they go for egg freezing. There need to be a proper return and, if possible, a video consent before going for these procedures. And you need to maintain these records at least for 10 years, and most often we need to continue to maintain them for 20 years also. And you need to practice ethical and a safe practice. And a woman should be over 21 before going for egg freezing. Recently, I had a patient who has actually, she's only 20, and she had 2 cycles of donor IUI outside. That was also through husband's brother's sperm. But we know, according to the ART, you cannot start a treatment before 21, and you cannot go for a sperm donor from somebody who is a relative or a known person. So we need to be very careful and follow the ART laws with whatever fertility treatment we are actually doing. So in India, we can freeze eggs for about 10 years. And if you want to freeze for more than 10 years, you need an extension from the registration board also. So at the end of 10 years, what do? You have to take a consent prior that after the 10 years, you either donate to the research or allow to perish them. But we know that the time is not a limiting factor. You can actually freeze them for a longer period of time also. So we know that at between 20 to 30, early freezing helps in increasing the pregnancy rates. At the age of 40, the chances are very low, and those people may actually require more number of IVF cycles. And if you freeze at 37, you have a fair chance of 60% accumulative pregnancy rate. At 39, the pregnancy chances come down to 50%. So definitely the chances depend on the woman's age, and there are a lot of unrealistic expectations. We know only 1 in 4 thaw cycles result in a birth, and success rate is higher when the woman is young. And as the woman grows older, the pregnancy rates come down because of other medical reasons also. So there is a lot of hype, but it actually gives a hope for women who want to have a pregnancy at a later date. So in future, we may even have lab-grown gametes also. As we have lab-grown diamonds now, we can have lab-grown gametes from the skin or the blood cells. Then you don't even need to go for egg freezing. So all those frozen eggs which are there stored in the liquid nitrogen cylinder, we don't know what to do with them. So coming to the conclusion, if you have more than 20 eggs, less than 38 years, you have a better chances. So the best time is before 35 years. And that means that young women need to be aware of this egg freezing programs, and they need to have a proper, balanced, accurate information from their physician before they go for it, so that they don't have a disappointment at a later date. It is always best for a woman to know that the best time to have a baby is young age and best way is naturally. This is all required only if they think they cannot have a baby now and they want to really have it at a future sometime later, then maybe this actually gives some freedom of choice. I had a patient, actually I went for a conference 4 or 5 years ago in New York, and when I was just looking at abstracts outside, a lady came to me and she spoke to me and said that, okay, are you attending this? Yes, I said yes. She said, I'm 42 and I have embryos, which I had gone through several embryo transfers. I have 4 more embryos which are left. We are planning for frozen embryo transfer. But I have around 6 embryos frozen in a different clinic, and they were frozen 2 years ago. But problem is that was a different partner, and now it's a different partner. So can I take out the sperm from that embryo and go for a new partner, and can I use them now? Because I was 2 years younger than that. So now the society has changed so much. So I said, I really am not sure, but there are some British scientists, go and talk to her. Go and talk to them. I just slowly slipped away from there. So I mean, now the concepts are changing. Maybe it's good that you freeze some eggs rather than just fertilizing all of them. You never know. Many a times you come across with the situations where there are divorces or there are some disputes and they want to still have a baby at a later date. So these eggs can be used at a later time. So social egg freezing is a concept which can be used whenever there is a need. Thank you so much.
Thank you, Dr. Anuradha, for that wonderful talk. Sometimes we think we know a lot, and then we have someone come up with really innovative questions that make us rethink our priorities in life. And if you have any questions for Madam.
Every egg, you don't freeze every egg, but then you do an egg retrieval. Normally, every clinic has its own rates. In our clinic, it costs 1,50,000 for egg retrieval and freezing embryos, freezing eggs. That will be maintained for 1 year. Every year, you need to maintain by paying 10,000 more. Every year, it's a 10,000. But I know other clinics where they charge almost 30 to 60,000 or maybe more than that. But this is what happens in our clinic. 1.5 plus 10,000 every year.
So basically it is not, the cost is not just of freezing the egg. What we have to remember is, those eggs need to be thawed. They should have a good male partner to make good embryos. By then she should not have something like big fibroids, adenomyosis or something like that for her to implant. And the purpose is to have a live birth. So how far that target will be achieved is something very difficult to say. Like it's like you have a diamond in your locker which you never ever wear it, so it still is of no use. So we have to look at the holistic approach. So many people don't, I feel they don't think through the whole issue. Like something like this comes like freeze your eggs, preserve your fertility. If it's a catchy headline and sufficient number of people see that, they think that is good enough.
Actually, we had a patient who was being married for 4 years, but she didn't want to have a baby for another 2 years. But by that time, her AMH was less than 1. She said, why don't you have a baby now? Why do you want to freeze eggs now or embryos now and have a baby later? Because I have to build a house, I want to settle in there and then stay with my husband and enjoy the place for 2 years and then. Said, no, this is not the way you need to think about. If you have to have a baby, have now. And then she conceived after 2 months. So she was so grateful that we at least, so I think we have to give them a proper advice before you plan for egg freezing, depending on the situation.
So we'll go on to the next topic, and we have Dr. Swapna talking about the immunological aspects of infertility evaluation and management. Till we started doing PGTA, we assumed that a chromosomally normal embryo at the right time of putting it into the window of implantation will lead to a pregnancy. But when that didn't happen, it happens only 50% of the time. That means half the time it doesn't work out. That we really woke up to the reality of implantation being a much more complex process, not just the raw material being there. So let's have Swapna delve into this.
So good morning everyone. So as madam said, now PGT, there are many advances in IVF to get a good euploid embryo. In spite of putting a euploid embryo, there are implantation failures and there are pregnancy losses. So there is something gray area which we have to know. In spite of transferring a good euploid embryo and a excellent uterus without any fibroids or adenomyosis, still there are chances of implantation failure and pregnancy losses. So that gray area today we are going to discuss. Basically it is the immunology part. So there is something called recurrent reproductive failure. So this RPL and RIF both are included in a broader term called recurrent reproductive failure. So RIF, we all know the definition, more than 3 failed embryo transfers, it is considered as recurrent implantation failure. So basically, we should not directly jump and evaluate all immunological causes. First thing is we have to rule out the basic causes, like what is a male factor, high sperm DNA fragmentation, uterine factors like any septum or any uterine anomalies, thrombophilias. Definitely, yes, we do all APLA, ANA antibody test if there is any RPL or RIF. And genetic, karyotyping definitely you will do. And embryonic factors, so we do PGT to rule out any embryonic aneuploidies. And lifestyle factors also do affect, which can cause implantation failure. After correcting all these things, still there is implantation failure, there comes the role of immunology. So this is what? Anatomical factors, receptivity factors, thrombophilias, all are being ruled out. And from the embryo also genetic factors have been ruled out. Still my implantation is not happening, then I will think about immunological causes. So RPL definition, I think you all know this, more than 2 pregnancy losses as per the ESHRE and ASRM. And as the WHO, it is more than 3 pregnancy losses. So actually, the recurrent pregnancy loss, before the first trimester itself, up to 70% of the conceptions will be lost before the end of the first trimester. 85% of the pregnancy losses happen before the clinical diagnosis itself. If you see the picture, almost 60% of the miscarriages will happen in the implantation failure only. So that preclinical losses. Clinical losses we see is only around 15%. So what is the immunological abnormality? Why will this implantation failure and the pregnancy loss happens? So this picture, I would just brief it out. At the end of this lecture, I think we should have a basic brief knowledge. I don't want you to dump everything about immunology, a basic brief knowledge. See, 3 cells are very important. Natural killer cells, Th1, Th2 cells, and T regulatory cells, apart from the B cells, that is autoantibodies. So basically, we all know in the pregnancy, once the implantation happens, the uterine profile should change from Th1 to Th2 cells, because Th1 cells are pro-inflammatory, whereas Th2 cells are anti-inflammatory and helps in embryo implantation. So there should be a change in the Th1 to Th2. And thing is Th17 and T regulatory cells. So Th17 is bad. T regulatory cells are good. So T regulatory cells should be good enough to support the embryo implantation. and NK cells. So there are two types, peripheral blood NK cells and uterine NK cells. So uterine NK cells will be CD56 positive, whereas peripheral blood cells will be CD16. So uterine NK cells also plays a major role in implantation and the pregnancy progress. So these three cells, T cells, T regulatory cells, Th1, Th2 and the uterine NK cells. Next comes the antibodies, which is one of the very favorite test what we do for majority of us will do, APLAR screening, antibody screening. So here I would like to say that there is a role of anti-TPO antibodies also. So basically we all do karyotyping and APLA. APLA, that is anticardiolipin, lupus anticoagulant and beta-2 glycoprotein. Very few of us will do anti-TPO antibodies. So there is a study that even the TSH will be normal, so like subclinical hypothyroidism, but TPO antibody positive, landing up in miscarriages, they should be supplemented with thyronome, like 25 to 50 based on the body weight. So anti-TPO antibody checking also is equally important in patients with recurrent implantation failure and RPL. So we all know these antibodies will cause thrombosis, affect the implantation and trophoblastic invasion, and it causes. Here I would like to say the immunology is totally different in pregnancy. For a suppose transplant, we are doing a transplant, there we need immunosuppression to accept the outside recipient object. But in pregnancy it is an immunotolerance. Here the immune system should be activated to accept the embryo. We should not suppress it. So there is a difference between the pregnancy immune system from the transplant thing. So why RF happens? So there is a decrease in the Th2 cells with increase in the Th1 cells. Microbiome, difference in the microbiome. This is a new upcoming era about uterine microbiome. We all know now we are supplementing the patients with oral lactobacillus, because again uterine microbiome also plays in the role for trophoblastic invasion. So these are the few causes for RIF and RPL. And the new concept, when I read this for this presentation, I came through know many things. So three things you should remember: HLA matching and KIR. This is not complicated, I will tell you very simple. HLA thing, there are two types, class 1 and class 2 antigens. Class 1 antigen is ABC, HLA. Class 2 antigen is DP, DQ and DR. Okay. So HLA will be present from the trophoblastic cells. So the fetus will present the HLA. So the maternal uterine NK cells, they will have the receptors called KIR receptors. So these KIR receptors and the HLA, they interact during this implantation period. So what KIR phenotype and what HLA gene is there matters a lot here. So that is a basic concept behind this. So KIR, there are three types, A, AB and BB. So AA is very dangerous. It is inhibitory. So KIR AA with HLA, HLA C. In that C again C1, C2. C2 is the culprit. So if the fetus presents HLA C2 and KIR AA phenotype, there is a high chance of implantation failure and patient will land up in impaired placentation, preeclampsia, IUGR. So we can predict the future of the pregnancy also with the mapping of KIR and HLA mapping. So if KIR B phenotype from the uterine NK cells is positive, it will support the pregnancy. So simple to remember, KIR A is inhibitory receptor, so it will not support the pregnancy, whereas KIR B is more activating receptors and helpful for the pregnancy. Same thing with HLA, C2 is dangerous. So these are the combinations. If you see the maternal uterine NK cells present KIR and the fetus is presenting C2, it is a very deadly combo. The patient will land up in miscarriages. So whereas HLA C1, KIR AA, it is neutralizing, so intermediate risk only. If it is KIR B and HLA C2, low risk. So we have to see whether fetus is C1 or C2 and the uterine NK cells whether they are KIR A or B phenotype. That decides the prognosis of our pregnancy. So just remember, KIR AA is dangerous and fetal C2, HLA C2 combination is dangerous. This is not very, not experimental. Now we are doing it. We started doing it. So Anderson, few labs like LifeCell, Anderson, they are giving us, it is the blood test, peripheral venous blood test, like how you do karyotyping. This is how the report comes. If you can see there, HLA sharing between the parents they'll give. See, now we have couples, consanguineous, like they want to go for a marriage. That lady's baba anamata. So she came for the counseling, preconceptional counseling, to know whether is it safe to marry his mother's brother only. Like, so there we can do HLA matching. This is the future. So if the matching between the two is more, like more than 50%, definitely the chances of the prognosis of pregnancy will be bad. So better we can tell them that your matching of HLA is high, better cancel this marriage. So preconceptional counseling for consanguineous marriages definitely helps a role. And patients with RIF and RPL, if you do this HLA matching, it will help us to know what is the similarity of HLA between the mother and father. And again, it will give us maternal HLA C type. You can see whether C2 or C1. So we can predict the prognosis of the pregnancy. This is how the report looks. So HLA sharing matters a lot. If there is more than 30%, definitely there is a risk of pregnancy failure. More than 55%, definitely yes. So these are the most common problems like uterine NK cell abnormality, Th1, Th2 ratio abnormality, HLA sharing. These are the few common causes for recurrent implantation failure and RPL. So how do we evaluate this? This looks some hi-fi tests and all. How do we evaluate? Routinely, you all do karyotyping, and routinely we do APLA screening. Now anti-TPO antibody screening, vitamin D, definitely yes, you do. Next comes the now recent things like TNF alpha, HLA sharing, KIR genotype, and NK cell, uterine NK cell. Like how do we do endometrial biopsy? We can do this uterine NK cell. So if the uterine NK cell percentage is more than 30%, then definitely it is alarming. So NK cell cytotoxicity. So we have to treat this patient. So these are the few tests which we should do to know the immunological cause. So endometrial profiling for uterine NK cells, peripheral blood for HLA and KIR genotype matching. So what are the drugs we have in the market? There are a lot of drugs like aspirin, heparin, steroids, HCQ. So which one to give is the question next. Our favorite heparin and aspirin, definitely we will start if the patient is having a previous history of recurrent pregnancy loss. In spite of being whether APLA positive or APLA negative, but as per the books and evidence, only if it is APLA positive, definitely aspirin and heparin has a role. You all know heparin 40 units. Even for IVF cases, we do regularly give heparin because it has a role in the implantation also, because it acts on the key proteins like metalloproteinases and helps in improving the blastocyst adhesion and implantation. So we do give after the embryo transfer for all the patients aspirin and heparin routinely to improve the implantation. But in RPL cases who are positive for APLA, definitely yes. And aspirin, we all know our favorite drug, definitely we give this because it is anti-inflammatory and anti-thrombotic. The Cochrane review also says that combination of heparin and aspirin improves the live birth rates in patients with APLA and thrombophilias. So combination therapy is more effective than aspirin alone. So please remember, you put the patient both on aspirin and heparin. Heparin 40 units subcutaneous daily. Next comes the steroids. As a fertility specialist, we do give steroids as well. So steroids, either prednisolone 5 mg to 10 mg. 10 mg is what regularly we give. So again, which patients we should give steroids? Yes, definitely if there is altered Th1 to Th2 ratio or increased NK cell cytotoxicity, definitely steroid has a role. So combination therapy, like suppose your patient came to you, in the previous pregnancy, she has been given aspirin and heparin, but in spite of that, she had a pregnancy loss. Now she came to you with the pregnancy. So add steroid, because combination of prednisolone, aspirin and heparin is helpful compared to like in a refractory cases, those who are not responding to aspirin and heparin, add steroid. So steroids, again prednisolone 5 to 10 mg is what is recommended. Coming to the IVIG, intravenous immunoglobulins. This is again a costly treatment. IVIG intravenous, it costs around 25,000 rupees, I think. So it reduces again NK cell cytotoxicity and Th1, Th2 balance, improves the complement mediated actions, improves the maternal fetal tolerance. So again there is a study, IVIG in combination with prednisolone and TNF alpha inhibitors. So these are all in refractory cases. So as I mentioned previously, like HLA matching, KIR genotype abnormalities, these kind of patients with a high NK cell cytotoxicity, definitely IVIG will help. So how to give 0.4 grams per kg monthly? Started preconception. Definitely it has to be given preconception because it will improve the uterine environment so that it will help in implantation or in early pregnancy. So 5 days before ET we definitely give and can be given at UPT positive and to be continued every 3 to 4 weeks till 12 to 20 weeks of gestation, because it modulates the NK cell cytotoxicity. Some studies have tried GCSF also because it improves the endometrial receptivity and enhances the implantation. Next, intralipid. This is my favorite, though the evidence does not support intralipid, but compared to IVIG, intralipids are cheaper. So I use intralipids in my routine practice. So intralipids, 100 ml intralipid in 500 ml of normal saline. We give it over 2 hours on the day of starting progesterone. That means 5 days before the embryo transfer. And once the pregnancy is confirmed, we can continue that till 12 to 20 weeks of gestation. Again, the mechanism of action is same. It modulates the NK cell activity and improves the Th1, Th2 cytokine balance. It can also be used in KR and HLA related RPL also. Next, the other most common now recent drug is tacrolimus. Any conference if I go now, people are talking about LIT therapy and tacrolimus. So what is this tacrolimus? It has to be given only under the supervision of a transplant physician. Don't give it individually. Tacrolimus, the minimum dosage is 1 milligram per day. It is a calcineurin inhibitor. Again, it causes Th1, Th2 imbalance will be corrected, and it improves the KLA and HLA signaling pathway. So because its side effects like nephrotoxicity and maternal hypertension, we have to keep in mind and continue it only up to 12 to 14 weeks. Again, I am telling you, these are all drugs only when the patient is having a normal uterus with a euploid embryo and patient wants to go for self gametes. If the patient is willing to go for donor gametes, there is no role for LIT, there is no role for IVIG, nothing. So whether the patient wants to, see, actually patients will come frustrated, 3 times IVF failure, I am planning to go for donor gametes. Then there is no role for immunology therapy. Only if the patient wants to go for self gametes, then comes the role of HLA matching, KIR genotyping and all this immunomodulator treatment. So next thing is TNF alpha inhibitors like etanercept and adalimumab. These are still experimental, not routinely used, but again they can be used in elevated TNF alpha. Now there is a blood test which will tell TNF alpha. If it is elevated TNF alpha, straight away these cases can benefit from TNF alpha inhibitors. Next, HCQ. HCQ is also one of my favorite drug because we can give safely throughout the pregnancy also. So especially in RIF cases, we start it 2 months prior to the embryo transfer itself. It has to be given at least 2 months prior. Then HCQ, again, it is it has autoantibody, reduces the autoantibody activation, useful in high NK cells, useful in refractory cases of APLA also. So along with your aspirin and heparin, we can use HCQ safely. 200 milligram twice a day is the recommended dose. Next is LIT. So any conference, if you go now, fertility conference, they talk about LIT. What is this LIT? It is a lymphocyte immunotherapy. So basically what happens is when the mother, this embryo is a semi-allogenic graft because 50% of the genes will be from the father. So mother has to recognize these antigens and it will form the blocking antibodies. So if the mother is deficient in these blocking antibodies, the chance of rejection of the embryo will be high. So there is something called CDC testing. You know, CDC testing is cross-matching. So whether the mother is positive for blocking antibodies or not, there is a test. So if the mother is negative for blocking antibodies, that means it didn't recognize the paternal antigens. Then comes the role of LIT. So you give the lymphocyte immunization therapy of the paternal antigens. Then mother will start forming the blocking antibodies. The chance of pregnancy acceptance will be better. So every patient does not need LIT therapy. Only those who are blocking antibody negative, those kind of patients, LIT will help. LIT, again, it is prepared from the father's blood. 80 ml of blood will be taken and it will be centrifuged. Only the lymphocytes will be injected either intradermal or subcutaneous. And now other favorite drug, I think many of you might be knowing thymosin alpha. Thymosin alpha, the evidence of thymosin alpha in RIF is there, but it's still in RPL, still more studies are to be yet to come. So thymosin alpha in RIF cases, they are recommending it like from day 0, every alternate days till 2 days before the embryo transfer we are giving. Once the test is positive, we can still continue it twice weekly dosing for the 3 months, that is up to 12 weeks. So thymosin alpha is the new drug again in the market. There are a few studies which have positively supported this in RIF cases. In RPL cases, still we have to get more information. So after all these things, which immunomodulators? Now you are confused which immunomodulator I should use, either aspirin, heparin, steroid, LIT, IVIG. So yeah, see, if it is autoimmune cause, definitely aspirin, heparin, HCQ, steroids. Don't put all these things in first straight away. If the patient does not respond to your aspirin and heparin, in the next pregnancy, definitely you add HCQ or steroid. Definitely it will helpful. KIR and HLA signaling. As I said previously that we will get the report which is HLA C1 or C2 and KIR. These kind of cases will benefit from IVIG, tacrolimus and intralipids. consider intralipids because it is cheaper. If still the patient is having recurrent pregnancy or recurrent implantation, then add IVIG or tacrolimus. So I told you LIT should be considered only when the CDC cross-match test. If it is positive, there is no role for LIT. That means already the mother is positive for blocking antibodies. So there is a test called CDC cross-match test. Okay, so I would like just conclude my slides with two scenarios which we have managed. This is a lady who is anti-Rho antibody positive. So she is already under regular care with a rheumatologist. She came to me for IVF. So then we have continued the HCQ and low dose steroid. After the pickup, once the pregnancy was positive, only on HCQ we could drag it, and every early TIFA scan, fetal echo was done to rule out the heart blocks. By God's grace, she was under completely control. So live healthy girl baby was, she delivered a healthy baby. Throughout the pregnancy, we have given only aspirin and heparin and HCQ. Steroids were given prior to the pregnancy. Just because the steroid was, pregnancy was positive, the steroid dose was tapered and there was no flare-up. Another patient, now patient is undergoing surrogacy. Actually, she is a SLE lupus nephritis positive. She is hypertensive, obese, previous history of 2 abortions, 5th month, preeclampsia. So the nephrologist said that there is a chance of flare-up, so better not to carry the pregnancy. So we counsel her for surrogacy, and then now we are going ahead with surrogacy. So here I would like to say, in the future what is going to happen is sperm donors also we might select based on the HLA. If he is HLA C2 positive, we won't take them as a donor because we want HLA C1. Even in the surrogates also in future, maybe we will do KIR matching. If the KIR is AA, she is not eligible to act as a surrogate. So in future, these are the immunological tests which are going to come up. But again, I conclude my talk telling that these are all fancy things in the market. First thing is rule out the normal causes for implantation failure, like any sperm DFI, lifestyle factors, euploid embryos, genetic factors. After all this correction only, then comes the role of immunology. So immunology will not take away the entire thing. First thing is normal things have to be ruled out. So normal pelvis, suppose if she is having grade 3 stage 4 endometriosis and adenomyosis, that is the cause for implantation failure. There is no role for LIT in that kind of patients. So first thing is we have to rule out the other causes, then comes the role of immunology. Thank you so much.
I'm not sure how many of you have clarity, but we know there is a lot of confusion. So you need to go back and, you have any questions, madam? No? Oh, you're clear. That's fine. That's great. Yeah.
Great presentation, Dr. Swapna. Finally, we need a good embryo and good endometrium and a great cross-talk between the two.
Thank you so much, ma'am. It was a very informative session. Now I request Dr. Padmaja ma'am and Dr. Anita ma'am to please felicitate Dr. Swapna ma'am and Dr. Anuradha ma'am. now request Dr. Padmaja ma'am to felicitate Dr. Swapna ma'am. Thank you so much, all the speakers and chairpersons. Now we'll move forward with the next session. Second session, placental puzzle, placenta accreta spectrum. I request all the chairpersons to please come forward on stage and mentor the session. Dr. Venkateshwar Rao sir. Sir is professor and HOD of Department of OBGY at Katuri Medical College. He is current president of Guntur Obstetrics and Gynecology Society. Sir has contributed to many publications and he is academically very passionate. Dr. Chandrasekhar Rao sir. Sir is senior consultant OBGYN. He is past HOD of Guntur Government Hospital. Dr. Sridevi ma'am. Ma'am is past president of Vijayawada Obstetrics and Gynecology Society. She is highly experienced senior consultant OBS and Gynec. Dr. Hanmantrao sir. Sir is senior consultant obstetrics and gynecology. Sir is coordinator and treasurer of Guntur Government Medical College Association with North America. Dr. Tripura Sundari ma'am. Ma'am is HOD and unit head of OBGY at Ashram Medical College. She is current president of Vijayawada Obstetric and Gynecology Society. Dr. Ramesh Babu sir. Sir is senior consultant from Chilkuliripeta. Speakers for this session, Dr. Anuradha ma'am. She is a senior consultant high-risk pregnancy and fetal medicine at Aster Ramesh Hospital, Guntur. She is secretary of Society of Fetal Medicine AP chapter. She is faculty in various national and state conferences. Dr. Deepa ma'am. She is senior consultant at Aster Ramesh Hospital, Ongole. She is one of the leading women's health specialists at Aster Ramesh Hospital, Ongole. Dr. Mahesh sir. Sir is consultant interventional radiologist at Aster Ramesh Hospital, Guntur. He has worked as assistant professor at St. John's Hospital, Bangalore, and has actively been involved in vascular, non-vascular, hepatobiliary, gastro, and neuro interventions.
So good morning everyone. After listening to the extensive session on infertility, now we will go to obstetrics, that is placenta accreta, which is a challenge for all the obstetricians to diagnose and manage. So I'll go through diagnosis of placenta accreta. So my presentation will be in the following headings. So first we'll see how the normal placenta looks. So normally placenta is uniformly echogenic structure along the uterine wall, and it should be homogeneous in appearance. There should be a deep hypoechoic band which separates it from the myometrium, which is called retroplacental zone. And this retroplacental zone is vital to rule out implantation disorders. So placenta accreta is not a clinical diagnosis, it is a clinico-pathological diagnosis. We can confirm only after pathology. examination of the placenta that we had an accreta. So placenta accreta spectrum is a abnormal trophoblast invasion into the myometrium and sometimes beyond serosa. So we have types like accreta, increta and percreta depending on the depth of invasion. So FIGO classification grade 1 they call it as creta, placenta creta, which means it touches the myometrium but doesn't invade the myometrium. Grade 2 is invasive placenta which enters into the myometrium, and percreta is depending again if it is limited to the serosa it is 3A, if there is a bladder invasion it is 3B, and invasion to the other pelvic tissues or organs it is 3C. So what is the pathogenesis of placenta accreta? Because during scar formation there will be uterine remodeling that leads to failure of normal decidualization and loss of subdecidual myometrial layers. So in the scar tissue the villi will be directly anchoring to the myometrium or perimetrium. So these extravillous trophoblasts also they transform into high volume and high velocity blood flow vessels. So vascularity will be high. So that leads to formation of the placental lacunae and fibrinoid deposition at the uteroplacental interface. So because there is no proper formation of Nitabux membrane, there will be detachment problems. So main risk factor for placenta accreta is you should have a placenta previa with previous caesarean section. So as the number of caesarean sections increases, the chances of accreta will be more. So with more than 3 previous caesareans and placenta previa, the chance of occurrence of accreta is 70%. So other risk factors other than previous caesarean section are any history of uterine surgery, like myomectomy if we are entering into the uterine cavity, and hysteroscopic removal of uterine adhesions, cornual resection of ectopic pregnancy, any DNCs and endometrial ablations, pelvic irradiation, postpartum endometritis, and there are studies that transfer of cryopreserved embryos also leads to placenta accreta. So what is the significance of placenta accreta spectrum? There is increased maternal morbidity 2 to 7% and mortality is 7 to 10%. And we know the complications like there will be severe maternal hemorrhage, need for blood transfusion, peripartum hysterectomy, damage to adjacent organs and postoperative complications and infections. So what is important? We need to diagnose antenatally and manage accordingly. So earlier prenatal identification is best through ultrasound, and they have come to the conclusion that the sensitivity of ultrasound is around 90% and specificity 96% in detection of placenta previa. So in the first trimester, that is what we can see is caesarean scar pregnancy, because caesarean scar pregnancy and placenta accreta share common histology. So first trimester is the caesarean scar pregnancy, and in the second and third trimester it leads into abnormally invasive placenta. And what is the incidence of caesarean scar pregnancy? It is 1 in 800 to 2500. So when we see a caesarean scar pregnancy in the first trimester, and if the woman want to continue the pregnancy, we should guard her about the risk of developing adherent placenta. So what is the criteria for caesarean scar pregnancy in the first trimester? So the gestational sac will be in the lower uterine segment, and the sac should be in the caesarean scar area, and you should see multiple vascular irregular spaces. So this is a crossover sign which tells us which caesarean scar pregnancy develops into placenta accreta. So this is the sagittal section of the uterus. We need to draw one line from the fundus to the internal os of the cervix, and a perpendicular line from this midline to the scar area. If our gestational sac is implanted in the figure like a B, completely upper to the sagittal line, then the chance of accreta will be more than in cos 2 minus. So they have told the risk of placenta percreta was significantly higher in pregnancies with cos 1 than in pregnancies with cos 2 and women with cos minus 2. So if we see a gestational sac implanted completely in the uterine scar, we need to guard her that she has chance of developing accreta if she continues the pregnancy. So in the second and third trimester, there are standard ultrasound descriptors to define abnormally invasive placenta. These criteria improve the reproducibility, increase diagnostic capabilities, and it facilitates international collaboration. So we need to check in the second trimester TIFA scan all these 11 features to justify placenta accreta. So 2D grayscale we should see, we'll go in detail each and every one. In the 2D, first is the loss of clear zone. So normally you will have a retroplacental hypoechoic piece. If that is lost, then we may suspect it accreta. So here you can see the hypoechoic plane, but here it's not there. And next is the lacuna. What are lacuna? They are hypoechoic vascular spaces, large and irregular. Feinberg has graded into 3 types. 0 is no lacuna, 1 is 1 to 3, 2 is 4 to 6, and 3 is 6 or more large irregular lacunae. If you have Feinberg grade 3, the sensitivity is 87%. Sorry, 100%, 87% for grade 1. So next comes to the bladder wall interruption. So you need to see there is a smooth line of bladder wall. If there is any interruptions, then we need to suspect accreta. And then coming the myometrial thinning. So normally myometrium will be measured at the level of the inferior uterine segment between the bladder wall and retroplacental vessels, visualized with use of color Doppler. Mean myometrial thickness was 4 mm. If it is less than 1 mm or undetectable, then we consider it as a myometrial thinning. Okay. Placental bulge. So here you can see clear line, and here there is a bulge in the placenta. And focal exophytic mass. So in one area there is interruption in the bladder wall. It indicates focal exophytic mass. So color Doppler we see 4 features like utrovesical hypervascularity, subplacental hypervascularity, bridging vessels, and placenta lacunar feeding vessels. So normally it will be in like B. So when you put color Doppler, it should be like that. If we see increased vascularity, then we need to suspect. This is subplacental hypervascularity. And this is a feeder vessel for the placenta lacuna. And that is bridging vessels we can see in the placento-uteroplacental interface. So this is 3D power Doppler where we can see intraplacental hypervascularity. So we need not see all these when we do a scan. But if these, so they have given a criteria. So number of previous cesarean deliveries. If it is more than 2, the score comes 2. Lacuna dimension, if it is more than 2 centimeters, then 2. So and number of lacuna less than 2 or greater than 2. And whether there is obliteration of uteroplacental demarcation. Placenta is anterior or posterior. Sorry, anterior or placenta previa. And Doppler assessment, how is the blood flow in the placenta lacuna and hypervascularity of placenta, bladder and or uteroplacental interface. So each criteria is given 1, 2 points, and based on that we category. If the points are 8 to 12, then there is high probability for morbidly adherent placenta. So this is a proforma where you need to tick all and see whether they are coming into high probability, intermediate probability and low probability. So now again a study has been done in 2023 where they have taken the opinion of all the experts, and it is given in 2023 journal Modified Delphi Study. According to this, they have reached to a consensus that prior history of one cesarean delivery, myomectomy, or previous history of placenta accreta spectrum, we should do a detailed TIFA to rule out placenta accreta. And they have come to the conclusion of out of 11, 7 are the main signs. So you should see whether there is clear zone or not, myometrial thinning, bladder wall interruption, placental bulge, utrovesical hypervascularity, placental lacunae, and bridging vessels. And they have come with the new thing, that is intracervical lakes, is a new ultrasound sign to be reported in patients with high risk for placenta accreta spectrum. So learning points from this Delphi study, we should do a transvaginal ultrasound in the mid-trimester scan, that is in the TIFA scan, to precise the position of the placenta and the anatomy of cervix. Anterior placenta previa or placenta previa with cervical involvement increases the probability of placenta accreta spectrum at birth. Loss of clear zone, bladder wall interruption, and the presence of placenta lacunae and placenta previa involving the cervix can predict surgical outcomes. So MRI mainly done for posterior placenta and obese mothers to assess the invasion of adjacent structures while planning for surgery. So this staging based on ultrasound they have given, and they have compared it with the outcome. So past 0 is you will have a placenta previa with no ultrasound signs of invasion, or if you see placenta lacunae but no evidence of abnormal uterus bladder interface, then it comes past 0. 1 is presence of at least 2 of the placenta lacunae, loss of clear zone, and bladder wall interruption. 2 is +1 plus utrovesical hypervascularity. Past 3 is increased vascularity in the inferior part of the lower uterine segment extending into parametrium. So as the ultrasound severity increases, the blood loss, operation time, length of hospital stay, surgical complications will increase. So management part will be discussed by Deepa ma'am. And final conclusion, so what is important is we need to see in the ultrasound placenta. Placenta evaluation is integral and vital part during anomaly scan. Important to exclude placenta accreta in high risk cases. We should go in a systematic and methodical assessment. And in TIFA scan, compulsory we should do a transvaginal ultrasound to confirm the position of placenta and the anatomy of cervix. Prenatal diagnosis plays a potential role to reduce maternal, fetal, and neonatal mortality and morbidity. Now I invite Deepa ma'am for management of placenta previa, accreta.
Good morning, everybody. So the management of placenta accreta spectrum begins from the time it is diagnosed. A definitive diagnosis of placenta accreta is usually made around the time of TIFA. And the single most critical, the most important step of placenta accreta spectrum management is counseling. So the counseling should never be taken as a simple thing. The counseling for these patients must be both practical and emotionally supportive. So during the counseling session, we need to discuss in detail about the concept of placenta accreta, its consequences on the mother and the fetus, and the management options during pregnancy. So this needs to be done as soon as placenta accreta is suspected, and we should not keep it for the later weeks of pregnancy. And the counseling also needs to be personalized. We need to talk to the patient according to the diagnosis, in the sense that counseling for a case of focal placenta accreta would be different from how you would counsel a case of diffuse placenta percreta with organ invasion. And during these counseling sessions, we also take into account the best estimate of risk. We also talk to them about the potential for morbidity, including a possible threat for future fertility. And a small but definitive risk of mortality also must be discussed, because in the era of modern obstetrics, the possibility of a woman dying during pregnancy and delivery is largely unexpected, but we have to talk to them about that also. Now, management of these cases involves a multidisciplinary care team, which consists of experienced obstetricians, urologists, interventional radiologists, obstetric anesthetists, critical care experts, and neonatologists. There has to be an access to a blood bank which is capable of employing massive blood transfusion protocols. And there also has to be a well-equipped ICU to optimize hemodynamic status, correct electrolyte imbalances, and minimize target organ damage. Studies have clearly shown that delivery of these patients in a center with a multidisciplinary team shows a significant risk reduction. There is almost a 50 to 80% risk reduction in the morbidity and mortality of these cases when they were performed in a center equipped for the same. Because the main risk in these patients is obstetric hemorrhage, we need to optimize their hemoglobin levels well before delivery. So starting from the early third trimester, we have to see that the hemoglobin levels are maintained at or above 11 grams per deciliter. And in case it is not so, we'd rely on IV ion formulations rather than oral iron. Now coming to hospitalization. We know that these patients are at high risk of preterm labor, pre-PROM, and recurrent bleeding episodes throughout pregnancy. So we have to consider inpatient management starting from the early third trimester. But again, this can be individualized based upon the proximity of the patient's residence from the hospital and availability of transport. But whatever it is, whether it is inpatient or outpatient management, effective communication between the patient and the team must be the priority. Now moving on to delivery. A scheduled delivery is always better than an unscheduled delivery in these patients, because unscheduled delivery is definitely associated with a higher risk of morbidity. Coming to the timing of delivery. Way back in 1996, O'Brien et al. In his study clearly showed that after 35 weeks of gestation, 93% of patients with placenta accreta experienced hemorrhage that was severe enough to necessitate emergency delivery. And another study also showed that planned delivery at 34 to 35 weeks of gestation in these patients did not increase neonatal morbidity. So taking this into consideration, guidelines advocate for delivery of these patients between 34 to 36 weeks of gestation with a corticosteroid cover. Now, because these patients are prone for hemorrhage, we have to prepare for massive blood transfusion in the pre-op period. The average blood loss in these patients is anything between 1.5 to 5 liters. So at the minimum, we have to keep 6 PRBC, 6 FFP, and 6 unit platelets ready before starting the case, with facility for more if needed. Coming to peri-op management, on the day of surgery, we need to obtain adequate IV access. At least 2 large bore IV cannulas must be placed. Use of direct invasive arterial monitoring will help in managing the fluid administration. And the presence of an anesthetist who is accustomed to managing obstetric hemorrhage, rapid large volume transfusion, and invasive hemodynamic monitoring is crucial for these cases. Use of thromboembolic deterrent stockings, padding and positioning to prevent nerve compression, avoidance and treatment of hypothermia are all integral part of peri-op management. The anesthesia preferred is general anesthesia because of the anticipated prolonged surgical times, and also that we have better hemodynamic control, and that is what the American Society of Anesthesiologists recommend, with an epidural catheter for post-op relief. Patient positioning depends upon the surgical approach, but usually the positioning should be such that it should allow for good surgical exposure for a large laparotomy, space for rapid intubation, and placement of multiple arterial and venous lines. A leftward tilt is placed till the fetus is delivered, and there also has to be access to the perineum so that we can periodically address blood flow from below. So for this, a dorsal lithotomy position with a left lateral tilt would be ideal. Coming to use of ureteric stents, performance of cystoscopy and placement of ureteric stents is usually done only when we are suspecting bladder invasion. That is in cases of percreta and not as a routine. Now moving on to surgical management. High quality comparative data to determine what is the best surgery for placenta accreta spectrum, still we are lacking. So because of this, dozens of approaches have been described, but broadly we can categorize it into 4 groups. So the first one is in situ caesarean hysterectomy. The second is conservative or expectant management, keeping the placenta in situ. Planned delayed hysterectomy weeks after in situ management. And partial myometrial resection and uterine reconstruction. The fifth method, which is the extirpative method, it used to be done once upon a time, where after delivery of the fetus, the placenta would be forcefully removed from the uterine wall. It's no longer being done because of the torrential hemorrhage and high degree of mortality with that procedure. So the first approach, the cesarean hysterectomy, is the most common approach, most appropriate approach, especially when the patient is hemodynamically unstable and actively hemorrhaging. It is the default backup plan when other strategies fail. However, cesarean hysterectomy performed in the technique of in the setting of placenta accreta spectrum is complex and hazardous, mainly because of the high degree of vascularity and also because of the altered anatomy. The lower uterine segment is very much distorted in these cases. The uterine vessels, ureters are all aberrantly located, and there's also a distorted bladder, plus the fact that these patients have had prior uterine surgeries. So there is a lot of additions. So all this makes the whole procedure very technically complex. So what are the techniques that we can adopt to minimize blood loss during these surgeries? The first one is to have a good midline incision so that we have a good exposure, and also for pelvic dissection, exposure is good. Then we try to make an incision well away from the placental site so as to avoid placental disruption, which will aggravate bleeding. Aggressive use of uterotonic agents, stepwise surgical devascularization or using of, even before the hysterectomy is begun, we can do a stepwise devascularization and place hemostatic sutures and then start. Or the use of pre-op balloon occlusions. The hysterectomy usually done in these cases is a total hysterectomy, especially when there is a placenta previa. In certain cases of focal placenta accreta in the upper uterine segment, we can consider a supracervical hysterectomy. In case there is bladder invasion, we do what is called a posterior retrograde hysterectomy. So here what we do is, after the baby has been delivered and the hysterotomy incision closed, the uterus is exteriorized, the round ligaments are clamped, cut and ligated, then the retroperitoneal space is opened and the ureters are dissected. After that, an assistant uses a sponge on stick and then pushes the posterior fornix from below, and the POD is opened from above. Then the vault is circumscribed all around, and then using a sponge holding forceps to hold the cervix, we begin the hysterectomy from below. That is the uterosacrals, the cardinals, then the uterine vessels. After this, the vesico-uterine space is opened. If there is a placenta percreta, the vessels are all ligated, and if there's obvious bladder invasion, then a cystotomy or a partial bladder wall resection can be done. So this is a procedure adopted when there is a bladder invasion. Any of these cases have the following complications. The median blood loss is about 1.5 to 3 liters, necessitating large volumes of blood transfusion, genitourinary tract and bowel injury, ICU admissions, thromboembolic complications, SSIs, reoperation, and the risk of maternal mortality. Second method, conservative in situ management. In this method, after delivery, the cord is tied off near the incision, the incision is closed, and if there's no bleeding, we close the abdomen and we wait for resorption of placental tissue on its own. The rationale behind this method is that following delivery, there's a progressive decrease in blood circulation to the uterus. This causes secondary necrosis of villus tissue, causing the placenta to either detach or resorb. And adjuvant methods like embolization, vessel ligation, internal iliac artery balloon occlusion, methotrexate, hysteroscopic resection of tissues, these have all been used to accelerate placental resorption. Among these, the methotrexate is no longer used because of both its lower efficacy as well as higher toxicity, even with a single dose. So generally, if we do this method, it takes almost 6 months for the placenta to get resorbed. So till then, for 2 months, we do weekly beta HCG monitoring, and as long as the levels are falling, it is reassuring. So after the initial 2 months, we switch over to monthly monitoring, and till complete resorption of the placenta. The advantage with this method is that it decreases the surgical morbidity and also the bleeding. Studies have shown that it is successful in almost 78 to 94% of cases. But the data available are from a very small group of people. And the concerns in these patients are the risk of emergency surgery due to life-threatening bleeding or uterine sepsis. Patients living far away will have logistic issues. Cost barriers again, because insurance will not cover additional care. Some may not be willing to accept the burden of prolonged follow-up and also the uncertainty around this kind of management. Moving on to planned delayed hysterectomy. This method was proposed as an approach to minimize risk associated with both immediate hysterectomy and the risk associated with prolonged conservative management. So what we do here is after opening the abdomen, we evaluate the uterus, bladder, adhesions, pelvic organ involvement, all that. And then if you think that a safe hysterectomy can be performed, you go ahead and do it. But if you feel that the hysterectomy might be risky and associated with a lot of bleeding, then we close the abdomen and do the hysterectomy a few weeks later when the bleeding risk is low. So studies have shown that this method is associated with a lower blood loss, fewer transfusions compared to an immediate hysterectomy. However, this requires 2 planned surgeries, so longer surgical times and longer post-op length of stay. Partial resection and uterine reconstruction. In selected cases, we just resect the placenta and attached myometrium, followed by repair and reconstruction of the remaining uterus. Factors favoring success of this method are that there must be sufficient viable tissue around the affected area. Depends upon the location and severity of pelvic adhesion. So we can do it in a few cases of selected focal placenta accreta. The ACOG states that this approach should be individualized. One such method is a triple P procedure, which was popularized by Sabaratnam Arulkumaran and Chandraharan. The 3 Ps are preoperative pelvic devascularization using intraarterial balloon catheters, periop localization of the placenta and incising above it. Then, without separation of the placenta, we go ahead, excise the myometrium and reconstruct the uterus. The TURIP procedure is another procedure. Here, a hysterectomy is done, baby is delivered. After that, we place a tourniquet around the uterine vessels and then give nitroglycerin, invert the uterus inside out, sharply dissect the placenta from the underlying myometrium, repair the myometrial defect, and then put back the uterus into its original position, remove the tourniquet, place a balloon tamponade, secure the angles and close the uterine incision. So this all has been tried within few cases. But we must remember that whenever you do such kind of uterine reconstruction, it's a badly scarred uterus. So there's a high risk of adverse pregnancy outcomes such as recurrent placenta accreta, uterine rupture and preterm birth. Now what do we do if we face a situation like this, an intrapartum diagnosis of placenta accreta? It depends on the center that you're working in. If you're equipped with adequate resources and expertise, you can deliver and then proceed with a hysterectomy. Otherwise, if the patient is stable, simply close the abdomen and refer the patient to a higher center. In case we encounter an adherent placenta following a cesarean section or following a vaginal delivery, then also it's the same thing. If the patient is stable and your center is not equipped, you close the abdomen, uterus and abdomen and shift. Otherwise, you manage in your center by doing an emergency hysterectomy. So I conclude by reiterating that cesarean hysterectomy is still the gold standard. In our hospital, in the last couple of years, after we had an interventional radiologist, we've used their services in 7 cases, and out of them, 4 has worked. So this is one such case. This is a small video, a 1-minute video. It's not playing, huh? Just read it. So in this case, we could manage without using a single unit of blood because they had cannulated the iliac vessels. Thank you all for your patient listening.
Thank you so much, ma'am. I now invite Dr. Mahesh sir to give the further talk.
Good morning, everyone. Deepa madam has given thorough introduction regarding the intervention part also. I will continue with that. So coming to the role of the interventional radiologist in placenta accreta spectrum, it is a part of multidisciplinary team where along with the obstetrician, urologist, anesthesia and blood banking services are required. So in patients with placenta accreta, we should prior planning is needed where we do the prophylactic procedure for decreasing the peripartum hemorrhage and as a part of uterine sparing surgery. So before going into the detailed description of the technique, first I will tell about the uterine blood supply. Normally the gravid uterus derives its blood supply from the uterine arteries, which are the branches of anterior division of the internal iliac artery. Along with that, it will also receive blood supply from the vaginal arteries, which are also branches of the internal iliac artery anterior divisions. And along with that, it can derive its blood supply from the median sacral artery, which arises from the aorta before its bifurcation. And sometimes the collaterals may arise from the lateral sacral and iliolumbar arteries, which are branches of posterior division of the internal iliac arteries. So before taking the patient to the OT, the patient will be shifted to the cath lab, where the prophylactic balloon occlusion catheters are placed within the internal iliac artery. And once we have placed, the patient will be again shifted to the operating theatre. And after delivery of the baby, we will inflate the balloons to prevent this postpartum hemorrhage. I will explain in detail later. These are the various techniques of prophylactic balloon occlusion. The balloon occlusion can be placed at the aorta level, that is just below the level of inferior mesenteric artery origin, or it can be placed within the internal iliac arteries, or within the uterine arteries also. So here we can see we have taken the bilateral common femoral arterial axis, and we have crossed over to the opposite sides, and we have placed the catheters within the internal iliac arteries. Here the balloons are also taken inside the internal iliac arteries, but they have not yet deployed. So this is how the patient is prepared before shifting to the operating theatre. Here we can see these are the markings with respect to the balloon. Once we inflate the balloon will be deployed across these markers. Here the femoral sheaths are sutured to the skin, and the balloon occlusion catheters are also tied to the patient's skin surface with an adhesive. Once the patient, and also during this placement of the balloon occlusion catheters, it is a fluoro-guided procedure. We should take, still the baby is inside, we should take adequate measures to decrease the radiation risk, such that we need to keep the eye away and the detector close to the patient body, and we should do intermittent fluoro. So once the baby is delivered, here we can see the balloon occlusion catheters are deployed within the internal iliac arteries. So these are the deployed balloon occlusion catheters in the internal iliac artery. But sometimes what happens is, because of the extensive uterine blood supply, even after the balloon occlusion catheters are deployed, there will be some sort of collateral flow and there will be ongoing hemorrhage. In such scenarios, there is no other option except for doing this uterine artery embolization. And in some scenarios, we have to go ahead with the extensive pelvic devascularization by carefully selecting the selective arteries which are bleeding. Here, after deployment of the catheter, still there is active hemorrhage. So here we can see the uterine blush coming from this uterine artery. Here, this is after embolization using gel foam, where the uterine artery branches and the blush is not at all seen. However, there are few untoward complications which can occur during this technique, because before delivery itself, we have placed this balloon occlusion catheters in these large vessels, so that because of prolonged stasis, there will be thrombotic complications also. Here we can see multiple filling defects across the external iliac artery. So for this, we need to do the some sort of aspiration thrombectomy to remove this thrombus and all. So coming to this, where in patients with the placenta accreta spectrum, where the severity is the percreta spectrum, where there is extensive extrauterine invasion, where there is extensive vascularization because of the collateral flow from the external iliac arteries, median sacral arteries, sometimes from the inferior mesenteric arteries also. So in such patients, we do resuscitative endovascular balloon occlusion of the abdominal aorta. Here we have seen this balloon is inflated in the infrarenal segment of the abdominal aorta. So technically it is quite simple compared to the crossover technique, because here we need to access a wire within the abdominal aorta and place a balloon over there. There is no need for crossing over to the opposite sides from both the femoral axes. Once we place the balloon here, we can't keep it continuously for 1 hour or 2 hours. It is advised to inflate with a 20 cc of saline and keep the balloon for 15 minutes. And we can do multiple times with 5 minutes of delay. So coming to the complication part, the complications of the procedure itself, it can be from the 2 to 5%. As we go more proximally, the complication rate decreases, because we will be able to address all the vessels supplying the pelvic vascularity. But as we go distally into the uterine arteries, the chances of complications are even higher, because of we are reaching the end arteries, and the chances of uterine necrosis is high. In such patients, the patients will eventually end up in hysterectomy. So some groin side complications will also occur, that is pseudoaneurysms and hematomas. Sometimes arterial thrombosis and dissection also can occur. Thank you.
Sir, any questions, sir? Any doubt in the diagnosis, management?
Everything past was nicely explained by both Dr. Anuradha and our parent. Deepa. Yeah.
Hello.
Nicely explained.
What is the time interval between the occlusion and the delivery time? You have done arterial occlusion.
Yes, sir.
And what is the material you are using?
Sir, occlusion is by just
You are
inflating
doing regular in your institute?
Yes, sir.
How many cases you have done?
In the past 1 year, I worked at St. John's, Bangalore, sir. We have done on an average monthly 1 to 2 cases.
That the frequency of pass is like that. One case in every month you are getting.
Reference center, sir.
Okay. So what is the material you are using for occlusion?
Sir, occlusion is just a balloon catheter. It is
Balloon
not
catheter you are keeping.
Yes, just
so what is
inflating
the time gap between your procedure and delivery time? Is there any effects on the baby before, if there is any time lag?
No, sir.
We do it as soon as the baby is delivered, sir. Immediately after baby delivery, we clamp the cord, then only they
So after delivery, you are occluding the vessel, and then you are, what is the next procedure you are following? What is the surgeon's obstetrician following? They are doing a placental removal with some uterine resection like that?
No, sir. It is like before the procedure, the cesarean section and delivery will take place in cath lab only. Once the patient reaches the cath lab, we will take bilateral femoral access, put one crossover balloons. We won't inflate it. Then the patient will be taken over by the obstetrician team. They will deliver the baby. If they see the hemorrhage, they will advise her to inflate the balloons.
They have removed the baby and they have also removed the placenta, or there's some dissection?
Conservative management or they are...
Prophylactically, they are placing the catheter.
Okay, I know. After that, baby is delivered. And what is the procedure the obstetrician taking? They are removing the placenta because it is adherent placenta. They are doing some placental by forceful removal or resection of the uterus.
Depends upon the type of...
No resection of the uterus.
Sir, in this, what we have done in our hospital, we've done 7 cases. All the cases we went for a hysterectomy, sir. We never attempted any myometrial reconstruction. No, sir.
So instead of that, you can deliver the baby above the placental level and then go for direct cesarean hysterectomy instead of that ballooning.
So, but we found that the blood loss that we have is much lesser. The blood loss is much lesser. So in fact, we've done cases without using a single unit of blood also. That is the advantage, sir.
What is the cost of balloon taping?
So we will charge around 60 to 70,000.
1 lakh.
1 lakh around.
So in addition to the surgical charges?
No, only balloon operation with the consumables. 1 lakh.
Here life is so poor people should lose their life. So my opinion is you can do in some cases where you deliver the baby above the placenta level, so that, and then you do cesarean hysterectomy with internal cord ligation. It is an easy procedure. Everybody is doing in institutions because of the help of urologist or some vascular surgeon who are doing internal cord ligation. And then go for cesarean hysterectomy.
Sir, this is like upcoming, sir. No blood loss. So we do everything prophylactically.
You can do
artery embolization.
Within 5 minutes, you can do internal cord ligation by urologist people in our institute.
Sir, in cases with extensive collateralization, where multiple vessels are there, it is difficult to trace every vessel, sir. In such scenario, it will help, sir.
Yeah, it requires a multidisciplinary team.
So
you can go for a classical cesarean anyway because you are doing a hysterectomy. You will not touch
so
the placenta
that is before doing cesarean section, immediately you have to do a scan report, and you know the upper edge of the placenta, then you will plan.
And then you will plan above the edge of the placenta, Or you can go for a classical also, there's no problem.
Dr. Paili's procedure of placing uterine tourniquet, even that is advantage. Before internal iliac artery ligation. With the advent of interventional radiology, all this is happening.
What I felt is, because of the internal cord, because of internal cord ligation, as a whole, the surgery has become relatively easy for me. In the Guntur Medical College, so many cases of PPH are managed internal cord ligation. Of course, it is the latest technology, ballooning. Okay.
No, nowadays so many workshops going on internally, artery ligation, I think. And most of the,
everybody
yeah,
is a
most of the
proprietor.
centers do have a urologist if necessary, and I think.
Suppose in the
That was
early
a-
pregnancy, regarding management of Dr. Deepika, if you have diagnosed a scar pregnancy in the first trimester, what is your advice to the patient? Are you advise her to go continue, or are you terminate the pregnancy at that level? And you, Dr. Anuradha, you told some scoring system. I have not seen that in our routine books.
Sir, what is it, sir?
What you told-
Crossover sign.
What is that sign?
Scoring, sir. See, sir, last 2-3 months, we came to the cases like only loss of clear zone. We can't diagnose it as placenta accreta, sir. We should have all the criteria. At least 8 criteria has to
That
be
is
fit.
reliable, madam? That is reliable? In
Yes.
which book it was given? That you what you told the scoring system?
Article also I documented, sir. It's ultrasound criteria in the second and third trimester.
I have recently gone to the recent advance.
Delphi consensus also, sir, 2023 they have published, sir. And they have told out of the 11, 7 signs should
That
be
is
there.
reliable? Reliable.
Yes, sir.
Yeah.
That's what I'm telling. Only one sign we see and we can't come to the diagnosis of placenta accreta. We should have all the 7 signs.
Yeah, of course, all the criteria should be
Criteria
there.
should be
So you have
properly
put it in a scoring system. That's
Yes,
all.
sir.
So
So who have
previously we
high
used to have
score,
that.
more chances of adherence.
Yeah.
And there we need to plan properly, pre-operatively.
So
and
what
then
is the next? What is the fate of a pregnancy? Next pregnancy after cesarean scar discontinued.
Repair.
That is, you have terminated the pregnancy by doing methotrexate or some procedure. And what is the fate of next pregnancy?
Definitely there is a,
I have two cases. I have two
Chances will
cases.
be high.
Present. I have two cases. I have done one evacuation of cesarean section scar. I have faced a lot of bleeding.
So
Then again,
until we should advise them not to become pregnant at least for 3 to 4 years until the scar completely
okay, okay.
reforms.
Even then they'll have a
There will be a
risk.
chance if there is a lower implantation.
I have two cases now. After 2 years, they have conceived. For their luck or my luck, they are continuing an intrauterine pregnancy in the upper uterine segment.
So that's
Two
what, sir.
cases
If the
now.
implantation is in the upper segment, no worries. If it is in the lower segment only,
What is the recurrence rate of recurrent cesarean section scar? Once the patient had one cesarean section pregnancy, what is the recurrence rate?
at least we have to study everybody.
The studies are
Luckily, I
there
had
only.
two cases upper uterine segment pregnancy.
Yeah, we should have more studies.
Thank you, sir.
We have rates following 1 cesarean, 2 cesarean and all, but we don't have.
So very nice
And it was a
presentation.
nice presentation. Nice, both of you have done a good job for the topic. Thank you, sir. Congratulations.
sir, Ramesh, sir, your experience, sir.
Actually, I have done up to 5 to 6 cesarean scar pregnancies with the placenta accreta and also involving the bladder. So anyhow, I could manage them without any complications. Of course, we don't have that facilities, higher-end facilities. Even then, with the support of a blood transfusion, I could manage that cases.
So we need a cath lab for
Every
this
case I did.
intervention. That is the main limiting factor.
No. Only cesarean hysterectomy I did.
Thank you, sir. Thank you. Sir. Sir, your experience.
I thank all chairperson and speakers for this interactive session. Moving forward to the next session.
Madam, inauguration. Madam, inauguration. Sir, ఉండండి inauguration. 1:30. లంచ్కి వచ్చేయండి మీరు
Next session, approach to incontinence, a gynecologist's perspective. I request all the chairpersons to come forward and mentor the session. Dr. Chari sir, sir is senior consultant, widely experienced urologist at Aster Ramesh Hospital, Guntur. He was past president of AP Society of Genitourinary Surgeons. Dr. Aruna ma'am is HOD Obstetrics and Gynecology at Guntur Hospital. Dr. Jhansi Vani ma'am is professor at GGH, senior obstetrician and consultant. Dr. Prabhadevi ma'am. Ma'am is senior consultant, highly experienced, active in women's health awareness, director of Prabha Nursing Home. Dr. Lata Madhavi ma'am, she is senior consultant, obstetrics and gynecology at Jubilee Hospital, Guntur. Dr. Nalini ma'am, ma'am has 32 years experience of specializing in women's reproductive health care from Guntur. Speaker for this session, Dr. Meera Raghavan ma'am. Ma'am is senior consultant, urogynecologist and robotic surgeon at Apollo Hospital, Chennai. She is director of Apollo Simulation Critical Obstetrics Team Training. She is also MRCOG examiner and trainer.
Good morning, everyone. And thank you for this lovely opportunity. Thanks to Dr. Vasanta for this. So the topic is approach to urinary incontinence, which is a really common but troublesome problem. And what do as a general gynecologist do with regards to approaching a patient with incontinence? So we all are aware that urinary incontinence is involuntary escape of urine and it's highly prevalent in women, much more commoner than in men, and has a serious impact on the quality of life and is considered a menace, especially with increasing aging population in the current scenario. And the need for early detection and intervention is mandatory to avoid the complications thereof. So if you take the urinary incontinence in a global perspective as well as in menopausal women, 30 to 50% of postmenopausal women do suffer from incontinence at some point in their lifetime, and it varies by the age and the race. And various factors influence prevalence, and it becomes a major health concern. We do not have increasing awareness programs relating to incontinence. Just like men reconcile to the fact that balding is due to aging, unfortunately, many women think they will leak if they age and become menopausal, which is not the correct thing. They do have difficulties and they do have problems thereof. Incontinence is not an integral part of aging. It has to be investigated and treated thoroughly. So within the Indian context, there is definitely a rural and urban difference between the incontinence, and the cultural factors affect reporting. And there is a significant impact on working women, and nowadays women are not confined to the four walls of the house and therefore come out and report it. But there are still barriers to seek help because they still maintain the fact that they do not know who to go to, and they find inhibiting factors to approach a male practitioner if they are faced with these kind of problem. And the epidemiological profile of women suffering from urinary incontinence residing in one of the cities of Western India also corroborated the fact that more than 50% of women suffering from urinary incontinence also had daily sleep reduction, diabetes, and chronic constipation. And only 7% of these women who had UI had ever consulted a doctor about this problem. So you can imagine how many of them are suffering in silence. So it is also prevalent in premenopausal women. In our own Apollo Tertiary Center, we conducted a study on the impact of urinary incontinence on quality of life in pre- and postmenopausal women. Though more number of postmenopausal women had incontinence, if incontinence were to be happening in premenopausal women, more than 76% reported severe quality of life impairment, sleep impairment in premenopausal age group, because of the frequency with which it happens, the fluctuating hormones, and the need for early intervention. We can have different types of incontinence, especially stress incontinence, where leakage happens with physical activity, and the common triggers being cough and sneezing. There is definitely a significant role of pelvic floor weakening and laxity, and this in turn worsens with menopause because of the estrogen decline and thereby integrity of the pelvic floor. And again, it has a significant impact on the quality of life, and majority of them can be debilitated by this, leading to social exclusion as well. When it is accompanied by a sudden urge to urinate, accompanied by the features of frequency and nocturia, this denotes a bladder overactivity rather than a pelvic floor laxity. And this also has a serious impact on social life. And a cross-sectional study of 433 menopausal women in an urban center also noted that there was a significant impact on the incontinence to the social quality of life as well. Mixed incontinence is a symptom complex where women experience both involuntary leakage due to urgency and bladder overactivity and activity related incontinence due to pelvic floor laxity. The important aspect is challenge in diagnosis. The best thing to ask is ask the woman which is more bothersome, and she'll invariably tell it's urge related incontinence because the amount of urine lost at that time is significantly high and happens without warning and has a serious impact, and that should be treated first. So always ask which type of incontinence is more bothersome, and that has to be treated effectively first. There are other types of incontinence, as we know, in elderly women due to stenosis of the urethral meatus due to lack of estrogen. They can have retention of urine and overflow incontinence, and very rarely functional incontinence, which can happen, which is transient in nature. Again, these poses significant diagnostic challenges, and we need to take a detailed history and assess the patient clearly and evaluate them accordingly. Why does menopause increase all this? That is because of an estrogen decline, effects on the urogenital tissue, so there's no coaptation of the mucosa of the urethra, the muscle loses its tone, there's vaginal dryness, and the bladder tone is impaired, and there is pelvic floor weakening, and these all contribute to various incontinence mechanisms, and thereby mixed incontinence or overactive bladder can further ensue. Urogenital atrophy is a significant issue which is often mistaken for recurrent urinary tract in symptoms, like infection-like symptoms. Patient typically complains of constant sensation to urinate. They will be going to the washroom but urinate very little. There will be severe burning. The burning is not while passing urine, it's present even otherwise, even when water comes into contact, even when they are sat down for a long time. And unfortunately, without local examination, they are dished out antibiotics on a recurrent basis, and the symptoms do not get better. This is classical of genitourinary syndrome of menopause, which also contributes to the incontinence issue. Unfortunately, it's still treated as recurrent urinary tract infection. If you look at the urine routine and culture, it will still be negative. There will be no pyuria. These patients should be receiving local estrogen application therapy rather than antibiotics. So do not injudicially use antibiotics for these kind of lower urinary tract symptoms. Pelvic floor weakness also contributes, and that's because of repeated childbirth, especially vaginal delivery, aging, and menopause. And the symptoms are invariably uterine or bladder descent along with leakage. And there is a significant impact on the daily quality of life. However, the menopausal women tend to get this aggravated. When I said multiparity and childbirth, it does not necessarily mean that cesarean section confers immunity against pelvic floor weakness or incontinence in the future. It's just that vaginal delivery has a higher risk as opposed to cesarean section, but just being pregnant itself can cause pelvic floor laxity and predispose to incontinence in the future. This we have already discussed. Aging population now, with the survival being 77 years for women, we're going to see more and more women coming through the door with symptoms of incontinence, because that's what age does to the pelvic floor and the bladder capacity. Obesity, again, a major risk factor because it has a significant impact on the pelvic floor. The epidemiological studies have suggested that overweight, obese women have a significantly higher urinary incontinence, and that has been proven both in middle-aged and older women. Very important to emphasize the role of diet and exercise and weight optimization. It has been known from all the guidelines, all the epidemiological studies, that even a 5% weight loss contributes to significant improvement in 70 to 80% of the symptoms of incontinence. So this has to be clearly emphasized while managing patients with incontinence. Smoking cessation is paramount for the treatment of incontinence, along with community education as well. UTI and urinary incontinence have an overlap connection, one because of estrogen decline, two, because of urinary incontinence, women voluntarily reduce the water intake, thereby predisposing themselves to dehydration and recurrent urinary tract infection. Treatment of urinary incontinence is not antibiotics. UTI can aggravate urinary incontinence. However, antibiotic therapy will not cure urinary incontinence. That's something like a take-home message we have to bear in mind and emphasize to our patients as well. And prolapse and incontinence coexist. Higher the degree of prolapse, the higher the chance of stress urinary incontinence. So it is mandatory for us to seek out, both in history taking and evaluation, to find out whether the patient has an overt stress urinary incontinence or an occult stress urinary incontinence. An overt stress urinary incontinence, patient will tell, in spite of the prolapse, that they are leaking when they're coughing, sneezing, or walking up the stairs. In the occult one, because of the prolapse being down, the angle between the urethra and the bladder is kinked, and the woman will not come out with the symptom of incontinence. In fact, during examination with the prolapse, you will not be able to demonstrate the incontinence. It is masking the incontinence. So we need to unmask the incontinence by repositing the prolapse, either with a sponge holding forceps or a ring pessary or a tampon, and see for unmasking of an occult stress urinary incontinence. The reason behind this particular evaluation is that if we go ahead and operate on the prolapse, this will unmask the occult urinary incontinence. Patient will come back saying, even when I get up, I'm leaking, and it is due to the surgery, when actually it is not the case. So mandatorily seek out occult urinary incontinence, counsel them whether you can do a concurrent continence surgery step alongside your prolapse repair at the same time, or do it as a staged procedure. Otherwise, unfortunately or unnecessarily, the surgery will be blamed for the causation of the incontinence when actually it was already present beforehand. Socioeconomic factors also lead to various causation of incontinence, especially manual laborers, nursing by profession, people who care for elderly, people who care for spastic children on their own, all develop pelvic floor laxity. So this gives an overall view of the prevalence of the different types of incontinence and the impact it can have both on the physical as well as the psychological domain. There are various validated questionnaires which we use, mainly the ICIQ short form questionnaire. It's a 5-point questionnaire which I think all of us can do very quickly in the outpatient setting. Patient themselves fill out. If the score is on the higher side, patient has to be evaluated further for the type of incontinence. So when do we need to seek help? According to our patient, or when do we need to refer in terms of seeking further intervention? Frequent leaks and pain associated, when it is causing a serious impact on life, when there is an importance for early intervention if they have mixed incontinence, and to empower patient or associated prolapse. Physical impact can be serious because of skin irritation, especially with the rising pandemic of diabetes and the anti-diabetic medication. They're prone for intertrigo, they're prone for ammoniacal dermatitis, especially if they are continuously leaking, and also diaper-related rashes and need for hygiene products and the long-term complication associated with this. This often causes a significant psychological impact, especially leading on to depression, embarrassment, social stigmatization, they have poor self-esteem, and they socially seclude themselves. And sometimes they even become suicidal because they do not know what to do about this incontinence. Especially elderly women, they do not like to become dependent on somebody. They feel embarrassed when they have these leaks in the night, when they are wetting themselves on the way to the washroom. They'll have to depend on somebody to clean. That puts in a lot of embarrassment and lead for social seclusion and depression. Travel limitations, especially now with working women traveling a lot. Many of our women are predisposed to recurrent UTI because they fear that public toilets are the cause for UTI. This is a myth. Public toilets do not cause urinary tract infection. Urinary tract infection is because of the overgrowth of abnormal bacteria which are already present in our body. So why does travel cause UTI? Only if you're dehydrated, because you do not want to use the washroom. You store the urine in the bladder for 6 to 8 hours, which itself becomes a culture media for the bacteria to grow. And because of the dehydration, you become constipated, wherein your bacterial load of your own gut system overpowers the natural bacteria. So these are the reasons why travel causes UTI, not the use of public toilets. And this has to be importantly educated amongst a community of women. Vaginal dryness and discomfort and sexual practices also worsens the incontinence, especially patients who do not use local estrogen therapy. They blame the sexual contact for the worsening of the symptoms. UTI is not a sexually transmitted disease. Fungal candidiasis, which vulvovaginitis, can be sexually transmitted, but UTI is not a sexually transmitted disease. It is due to the alteration of the pH of the vagina that overgrowth of bacteria happens. So encourage your patients to empty the bladder before and after intercourse and not practice overt hygiene. Excess perineal washing with antiseptic solutions which are commercially available wash off all the good bacteria, predisposing them to vaginal dryness, predisposing them to overgrowth of abnormal bacteria. So these are the myths we need to clarify with our women so they don't get into this cycle. So we also need questionnaires which look at the overall reduction in quality of life. That is a very good tool to see how our intervention or surgery has improved, not only subjectively, but objectively as well. So we need to have this duty for making sure our women are aware, come forward and report, breaking the cultural barriers, which is why educational programs, articles in vernacular, TV interviews, or community education among NGO groups is very, very essential. The more we educate women, the more we empower them as well. So what about lifestyle modification? Definitely weight management, dietary changes, avoiding excessive fruit juices. Fruits are better than fruit juices because fruits contain fiber. Take out the fiber, juice contains nothing but sugar. So discourage your patients to take fruit juices. And the myth that tea and coffee are hydrating. Tea and coffee are actual diuretics which can leave you dehydrated but cause overactive bladder. Smoking cessation, for that matter, tobacco cessation in any form is paramount for the maintenance of bladder health because tobacco usage is one of the risk factors for developing bladder carcinoma. Even passive smoking is a major risk factor for developing carcinoma of the bladder. Encourage all women for pelvic floor exercises. Postmenopause is too late to do pelvic floor exercises. All women from teenage should be encouraged to do pelvic floor exercises, especially starting with the first delivery itself. Then only they will know what muscles to contract, and when it becomes abnormal, they will be able to exercise better. So pelvic floor exercise is not a corrective therapy. It is actually a prophylactic intervention to prevent future prolapse, future incontinence. Proper hydration and proper bladder voiding habits. Majority of the schools, majority of the universities do not have proper washrooms, which is why many women or many girl children develop recurrent UTI because they hold on for 8 hours, 10 hours, and later on develop renal calculi and voiding difficulty. So encourage your women to empty the bladder every 3 hours, which is good bladder habit and prevention of future problems. Kegels exercise, do not just tell the patient, go on YouTube, see and do the Kegels. Majority of our women do not know pelvic anatomy, so take your time to give an assessment of where the pelvic floor is and teach them. Send them to a dedicated pelvic floor physiotherapist to do it under supervision for a maximum of 6 to 8 weeks. If it doesn't work, it doesn't work. It just move on to the next step. But at least this has been done beforehand. Very, very important in postpartum care. Bladder retraining, every 3 hours they should be voiding. Fluid management, no fluid after 8 p.m. because that is the main cause for the nocturia. Avoiding caffeinated drinks, especially the fizzy drinks, and the importance of biofeedback are put in the evidences which are supportive for each of these interventions in the management of incontinence. We have a plethora of medications. The mainstay is now beta-sympathomimetic agent, which is mirabegron, which is having a lesser side effect profile. Patients do not suffer from constipation and dry mouth. However, exercise caution in women with very high blood pressure because it can rise the systolic blood pressure. For the anticholinergic, an important history is absence of glaucoma. If there is glaucoma, anticholinergics are contraindicated. Topical estrogen is a must, especially if the woman is postmenopausal. It acts synergistically in the management of bladder health and improves incontinence, both in urgency-related incontinence as well as stress incontinence to some extent. Pessaries. Pessaries are also very useful in the management of pelvic organ prolapse and associated stress incontinence, and they will have lesser voiding dysfunction if the bladder is reposited. So this, along with the pelvic floor physiotherapy, goes a long way in the management of urinary incontinence. We do have, again, midurethral sling and autologous facial slings. Midurethral slings are still the best option for the management of stress urinary incontinence. Unfortunately, the Western population has jumped in too soon to blame the tape rather than the technique for the mesh erosion and mesh exposure. The European countries still continue to do it, and the rest of the world still continues to do it. If done properly with the correct type of tape, with the correct training, you will not get major complications associated both with TVT or TOT. A retropubic TVT is a far better option in the management of stress urinary incontinence than the rest of the procedures which are being done. Bursch-Kolper suspension, not everybody is trained to do it, and it has to be done abdominally. It has its own complication, though it has been mentioned as the gold standard. There are various non-hormonal therapies, especially with industry-driven products these days, about electrical stimulation, but it's about choosing the correct one for the correct patient. May be useful in grade 1 to 2 severity of incontinence, but not after that. There are a few trends in the latest management, especially with regards to biofeedback addition to the Kegels. This is very important in patients who do not understand Kegels, so they can visually see whether they're contracting the right muscle and appropriately contract them to get better response. Again, it is supervised. It's between 8 to 10 sessions. Is there a role for laser and radio frequency? Yes. Only in cases of grade 1 to 2, not beyond that. It will not be curative. You have to understand that it's still under research settings. It minimally needs 3 sittings of laser and a memory recall after 6 months. So it's not a one-off procedure. So it will not compare itself to surgical procedure for permanent cure or efficacy. Radiofrequency is the same. It has been shown to improve pelvic floor laxity and OAB and urinary incontinence and mild vaginal laxity. This is different from cosmetic gynecology, where these are done for vaginal tightening and rejuvenation. That is on patient request. These are clinical indication. Both are different. We should not confuse both of them. Electrical stimulation chairs. These are more magnetic stimulation chairs. Imagine this causes 11,000 contraction for the pelvic floor muscle. If I do biceps 11,000 times, I will end up in a muscle injury or a fatigue of the muscle. So I'm going to leave the house to think about it, whether it's the right way to exercise your pelvic floor rather than a supervised pelvic floor therapy. Now we have AI and digital health. Now we have smart pans, which sense the possibility of a leakage and alerts the patient so they do not develop significant urinary incontinence episodes. There are mobile health apps, which act as a bladder voider reminder for a bladder app for 3 days and a water reminder as well. So these are being done in our own IISc Bangalore. I have been associated with them for development of electrical stimulating smart pans in patients with incontinence so as to contract the pelvic floor better, and it has been in the phase 3 research now. So the final word on the SUI tapes, it's definitely the gold standard. If you use a retropubic tape, it is significantly beneficial compared to the various other tapes which are available with the least amount of complication for the patient in the long run. Now we have 20 years study evidence available for this, and this is the success rate between the TVT and the TOT and the complication rate. So mesh controversy is there, but unfortunately I have to admit it is a scam by the lawyers and the mesh removal surgeons rather than true evidence with regards to mesh causing the complications. Bulking agents is a stopgap which is being used in the UK and the US because the meshes are out of vogue. This has to be repeated every 3 years and has got only 70% success rate. It basically causes the coactation of the urethral mucosa so as to cause the cushioning effect of the mucosa and aids in the intrinsic sphincter mechanism for incontinence therapy. We've already looked at the various therapies available for medical management, and now we have Botox injection which are being done inside the bladder. If the patient is not responding to medical therapy after 6 to 8 weeks, I proceed to do intravesical botulinum toxin. These patients do not need a further injection for nearly 12 to 18 months. In fact, it's life-saving for patients with neurogenic bladder. I also do sacral neuromodulation for patients with neurogenic bladder, voiding dysfunction or refractory OAB, whereby we place a pacemaker in the buttock area which stimulates the S2, S3, S4 and treats the incontinence as well. So I'm going to just move through this because of the want of time. So it's all about breaking the stigma, creating more awareness, educating our patient and empowering them. And we have the onus of responsibility to do that and take the support of media as well as the publication network. So we have lots of gaps in our current knowledge. We need to do a randomized control trials in various populations regarding the demographic prevalence and the treatment, and we will be taking the help of AI and the available technology to do further research. So we know that urinary incontinence is a significant problem and menopause or UI are linked. The high prevalence after menopause testifies to that. There are multiple risk factors. Effective treatments are available, so incontinence is not an integral part of aging. Patients should not be reconciling to that fact, and the need for early intervention has to be emphasized, and it's always holistic care approach which is going to win, especially with institution and maintenance of lifestyle modifications. Thank you for your patient listening. Thank you, sir. Thank you, sir.
Urinary incontinence in women. It was a great lecture, madam.
Thank you, sir.
To add to this, there is another group of incontinence in women, especially who come after hysterectomy, where patient come with incontinence continuously, and examination, clinical examination, thorough examination, cystoscopy, even vaginal examination does not demonstrate any fistula. this group of patients is very difficult to manage.
Yes.
And that forms a small percentage of patients coming with incontinence. Either they have a minute vesicovaginal fistulae, or they may have an intramural ureterovaginal fistulae.
Yes.
This group of patients needs careful diagnosis, especially under anesthesia, to find out what is the cause of incontinence and where is the incontinence. We should not write them off as other types of incontinence like stress or OAB, and then these ladies will be suffering from the problems of incontinence. It was very exciting lecture, madam.
Thank you.
Thank you very much.
Thank you, sir.
Madam, a nice presentation. And for stress incontinence, madam, which investigations you prefer? Clinical examination is enough, or you go for urodynamics?
I will do urodynamics. I didn't go much into that because we had to cover all these aspects as well. Urodynamics is to be done if you are planning intervention of any nature. So if I am planning a Botox for a refractory overactive bladder or planning a surgical procedure for stress urinary incontinence, I would go ahead and do urodynamics. There are two reasons for that. One, we will rule out overactive bladder issues and treat them accordingly. Second, we will also know whether the patient is completely voiding and choose the appropriate tape for the stress urinary incontinence. Yes.
The incontinence is basically a clinical spectrum. A thorough examination, history taking will confirm the diagnosis, and most of the patients, 70% of them will be managed clinically.
Yeah, most of them would need only lifestyle and medical management. But in the subset of 30 to 40% who are going to need interventional treatment, then we need to perform the urodynamics.
Madam, very excellent talk. Covering all etiological factors to surgery. But what is the permanent solution for any incontinence? Permanent solution. All these surgical procedures are to be taken time to time, once in 3 to 6 months like that. But what is the finalist surgical intervention?
The size for the surgical
you want
intervention,
to divert the urinary diversion, or you do suprapubic cystotomy?
No, we don't need to do all that. Those are in cases where the
Very
bladder has got
severe
low
uncontrollable
capacity. A
incontinence.
stress urinary incontinence will be cured with patients for retropubic tape itself. But we have to understand, if the patient has a retropubic tape and puts on 20 kilos after that, it is the weight which has to be reduced, not the tape to be blamed for failure.
So very elderly people we come across sometimes, more than 70, 80 years. So
They
they
are still
cannot
good
even go
candidates
to,
for therapy.
They cannot go even to washroom. By the time they reach, definitely they
Those
spoil
people
the,
have,
in those cases,
people
what are you
have
going to do?
overactive bladder, and overactive bladder can be managed medically. 80% of our elderly women have obstructive sleep apnea, which is another reason for the nocturia, nocturnal polyuria, and frequency. That has to be screened and treated, and 80% of them will improve with correct management of their fluid and medical management. Only 20% will go on to need any intervention like Botox.
Sometimes that behavioral therapy also we cannot explain to those people which are more elderly. So thereby what is any permanent solution? Because household people, they are more suffering rather than fellow.
Do we offer permanent cure for rheumatoid arthritis? Answer is no. Do we offer permanent cure for asthma? Answer is no. We have to pitch the expectation right, saying that your symptoms will be controlled. Now you're looking 10 out of 10. With my treatment, you will be probably dry 8 out of 10. However, you have to maintain these lifestyle changes for life, not for 3 months, for life, so as to have prolonged effect of these medications. I might be able to take you off the medication if you continue the lifestyle modification, or I might reduce the dosing. But that's what we can do. That is pitching the expectation right.
Thank you very much,
Thank you,
madam,
sir.
for a nice lecture.
Thank you.
Thank you so much, ma'am, for this interesting session. Thank you to all the chairpersons. Moving forward to the next session. Role of Doppler in enhancing obstetric outcomes. Speaker for this session is Dr. Sushila ma'am. Dr. Sushila ma'am is senior consultant at Fernandez Hospital. She is fetal medicine specialist, head of multiple pregnancy clinic and prenatal interventions at Fernandez Hospital. She is a visionary, passionate teacher and architect of fellowship program at Fernandez. Chairperson for this session. I request all the chairpersons to come forward to mentor this session. Dr. Shakila Sridhar ma'am. Ma'am is senior consultant and obstetric gynecology from Sattanpalli. Dr. Subhashini ma'am. Ma'am is well-known gynecologist and obstetrician with over 32 years of experience from Guntur Medical College. Dr. Ramadevi ma'am. Ma'am is senior consultant from Narsiraupeta. Dr. Sushila ma'am. Ma'am is senior consultant and obstetrics and gynecology from Sattanpalli. Dr. Janardini ma'am. Ma'am is senior obstetrics and gynecologist. Ma'am is director of Janardini Hospital, Guntur. Dr. Bharti ma'am. Ma'am is senior consultant. She is director of Health Hospital, Guntur. Dr. Jayanti ma'am. Ma'am is professor at Andhra Medical College, Department of Obstetrics and Gynecology. She has many papers to her publications. Dr. Usha Rani ma'am. Senior consultant at GGH Hospital, Guntur. I also invite Dr. Venkatesh Rao sir
to come and chair this session. I request Dr. Chandrasekhar sir also to come on to the dais to chair this session.
Okay. A very good morning to one and all. At the outset, I really thank Dr. Mamta and Dr. Anuradha for giving me this opportunity and then warmly welcoming me to my alma mater. The topic today for my discussion is that role of Doppler in enhancing obstetric outcomes. As you all understand, the obstetric Doppler is actually the prime antepartum fetal surveillance device or methodology which takes care of high-risk fetuses. This is my storyline which I'm going to cover in the 30 minutes. However, color Doppler in fetal malformations is beyond the scope of this presentation, though it is 30 minutes. The basics of the Doppler includes it is a non-invasive tool, and then whenever you put the color box, you will get red and then blue, which means that towards and away from the probe. And the Doppler works with the principle of ALARA, that is as low as reasonably achievable exposure. Because if you do the Doppler at 8 weeks of pregnancy, embryo, it is wrong. Because the fetus will have Doppler will have thermogenic effect, and it will have impact on the embryo. So it has to be after 12 weeks of pregnancy only that we need to do the Doppler. These are the different types of the Dopplers. Either it can be divided as placental or fetal, or it may be arterial or venous Doppler as well. This is how a Doppler waveform is represented by the pulsed wave. It has a cardiac output, cardiac cycle, which includes a systolic component and a diastolic component. So the difference between the systolic and diastolic flows is what is given as Doppler indices. And it works just like the signature of us. Each one of us have our own signatures, so also each vessel has its own signature. By this signature, that is pattern of the flow in that vessel, we can identify the vessel. How do we identify the interpretation of these Dopplers? It is by either presence or absence of end-diastolic flow, or assessment of impedance, that is how much resistance against which the blood is flowing in that particular vessel. The arterial Dopplers are read as automatic tracing, whereas the venous, because they also have sometimes a component, that is atrial contraction, it has to be traced by the manual method. As I have said, there are many Doppler indices. When I was doing my post-graduation, I was told that it is systolic to diastolic ratio which is important. However, in the modern obstetrics and fetal medicine, what is important is pulsatility index, because despite being absent end-diastolic flow, this resistive index can be calculated. And PI values are always gestational age dependent. Therefore, we don't have to remember any value, but we have to see either through the tables available or online calculators are there just at your fingertip. So a small interpretation here, this is the uterine artery. In this particular waveform, it is showing a good diastolic flow, whereas the pattern below is showing a poor diastolic flow. The umbilical arteries, if it is normal, then there is a systolic and diastolic flow. If there is a 30% reduction in the placental function, it shows poor diastolic flow, which is called as high resistance. Absent end-diastolic flow or reversal of flow occurs when almost 70% of the placenta is already damaged. But what is the difference in reversal flow is that cardiac pump also is abnormally functioning. Middle cerebral artery, normally there is no excessive blood flow during diastole to the brain. Whereas if it is a hypoxic environment, then fetus tries to save the brain by sending more and more blood flow, not only in the systole, but also in the diastole. So this is how, as the hypoxia increases from normal less diastolic flow, there is a vasodilatation, and hence more of diastolic flow also is there present in the case of hypoxic environment in middle cerebral artery Doppler. CP ratio is one of the things that we follow while we are looking at hypoxic, that is growth restricted fetuses, and normal is up to 1, and it is again a gestational age dependent nomograms are there. Ductus venosus Doppler directly indicates that acidosis, that is normal flow, and then reduced flow in the diastole, and then reversal of flow in the A wave. So absent A wave or reversal of A wave almost indicates that impending fetal death. There are certain prerequisites before which we do the Doppler, because there has to be a valid indication and fetus has to be normal. There is no point in doing Doppler for an anencephalic fetus, isn't it? So that's why structural survey has to be there. And Doppler is always disease specific. The way we look at the functional aspect, that is flows, in a particular high-risk condition is different from a different way. That is, like, for example, fetal growth restriction to the fetal anemia, there is a difference in the way the Dopplers are actually interpreted. So the role of Doppler in enhancing the obstetric outcome, yes, it is very important in cases of high-risk pregnancy, which is, a Doppler is useful for the screening, diagnosis, as well as management. Let us see how Doppler is used for the screening. We all know that aneuploidy screening, Down syndrome risk, is calculated by the nuchal translucency and then nasal bone, also on the baseline maternal age and gestational age. However, the tricuspid regurgitation and ductus venosus Dopplers, they have add-on value on the increased detection, like up to 97%, with a low false positive rates of 22.5%. So the Dopplers of the ductus venosus as well as the tricuspid regurgitation, they reduce the false positives and hence better detection. First trimester screening for the preeclampsia, yes, there is history taken, and the mother is asked to sit in the comfortable position. Simultaneously, we took the blood pressures from both the arms. A scan is done to see that fetus is normal, and then uterine artery Doppler. Along with that enhanced first trimester screening, the women also gives the bloods, which includes not only free beta HCG and alpha fetopapiae, but also the PLGF, that is placental growth factor, as well as the alpha fetoprotein. So with all these things, by applying the fetal medicine algorithm, the detection rate of preeclampsia of less than 34 weeks can be as high as 90%, whereas preeclampsia of 37 weeks, the detection rate is less, that is 75% only. Ophthalmic artery Doppler is a new addendum. It has an add-on value while we are doing the assessment of risk. Couple of our fellows are doing the thesis on the ophthalmic artery Doppler in the prediction of preeclampsia, the new algorithm where we can, it's actually very easy when compared to the uterine artery Doppler as well. But it is still in the research stool and it has not come into the algorithm as such. So ophthalmic artery Doppler, it gives peak systolic velocity of 1, 2, and then end-diastolic values, and then it is increased velocity forms in cases of the preeclampsia. Now let us move on to the Doppler for the diagnosis of certain high-risk conditions. A primary booked at 20 weeks, spontaneous conception. She's come for anomaly scan. Fetus is normal, however, the placenta is approaching the very close to the cervix. So it is by transabdominal scan and transvaginal scan, the distance is almost 1.7 centimeters, that is 17 millimeters, which means that it is a low-lying placenta. Whenever there is low-lying placenta or any placental abnormalities, there is a high possibility that there can be vasa previa also. And vasa previa, the fetus exsanguinates. Whenever there is antepartum hemorrhage, it is the fetal blood, and hence we may lose the fetus. Therefore, the ISWAG guidelines has come with this article, bubbles and lines. In the lower uterine segment, you can see here the cervix, and there is a bubble, and that is the transverse section of the cord, as well as there is a line which is longitudinal. So whenever there is a abnormality of the placenta, always try and then do the transvaginal scan to not only confirm, exclude central placenta previa or then low-lying placenta, but also vasa previa. So the management of vasa previa is very tricky. The women as well as the consultants will be very anxious because she may report to the emergency with any time bleeding, and then as I said, this bleeding is from the fetus. Of course, the recommendation is still unknown. It can be an elective cesarean section at 34 to 36 weeks of pregnancy. You can see in the surgical specimen showing the vasa previa. We now move on to the next, a referral at 27 weeks because of the enlarged placenta. Fetus is normal. You can see a big mass coming here, and then there is a good blood supply. So this is the feeder vessel, and this condition is called chorangioma, which is a very benign tumor. And then the options for the treatment are either supportive by amnioreduction, if at all amniotic fluid is more, the polyhydramnios, or if the fetus is anemic, it may be intrauterine blood transfusion, or the feeder vessel, if it is identified, it can be coagulated by one of the minimal access surgeries, which include bipolar cauterization, RFA, etc., etc. So all chorangiomas do not need treatment because there is something called as placental senescence, and these tumors may disappear actually. So in these cases, we have to follow these women with the ultrasound every 6 to 8 weeks. This is the operative specimen because these women had a cesarean section and also the baby. The outcome of this chorangioma is very good, and Doppler has actually helped us in managing this particular case. This is third gravida para 2 live 2, 41 years, previous to cesarean sections. She is referred to a hospital for institutional care in view of adherent placenta. I have actually, added some few slides here because there was a discussion, previous session. As you understand, the placenta accreta can be, adherent placenta can be accreta, increta, percreta, and the risk factors are cesarean sections. The more number of cesarean sections, the more the placenta previa, the more is the chance for the adherent placenta. The grayscale imaging, you can see here the normal hypoechoic plane, whereas in abnormal cases, that is adherent placenta, there is no hypoechoic plane here. Also, myometrial thinning, 2 millimeters is what we take it as cutoff, and whenever there is adherent placenta, there is no myometrium at all. You can see the bladder wall interruption. You can see the tissue, penetrating into the bladder wall as well. This can also be identified in the 2D ultrasound. So lakes are common in placenta, whereas lacunae are abnormal. You can see here the moth-eaten appearance of the placenta, which says that definitely there is a high chance of abnormal adherence. Also the placental bulge, which is protruding into the bladder, as well as focal exophytic mass. So all these things are 2D grayscale imaging which can be identified the 2D ultrasound itself. Then this is a surgical specimen. You can see the bulging placenta into the bladder, and you can also see the placental bulge. And then hemorrhagic collection of the fluid here, and then operative specimen of hemoperitoneum as well. The color Doppler imaging, how is it going to help us? The utrovesical hypervascularity is there. You can see a lot of vessels here. And then also the bladder uterine serosa interface is hypervascular, which is identified on the scan with the Doppler, as well as you can see the vessels. These are called bridging vessels as well. Subplacental hypervascularity is there. Also you can see that the lacuna are filled with hypervascularity, which has turbulent flow in a way different from what we see laminar flow in otherwise lakes. A feeder vessel can be identified on the scan itself. So all these inputs are very important, including the 3D power angio. This gives the surgeon the insight like how much of involvement of parametria or other things are there. This is a MAP scoring sheet that is being discussed in the first session. This is given by the ISWAG guideline, which gives right from the history to ultrasound findings of 2D imaging as well as the color Doppler imaging. And then the patients are divided into 3 grades: low, moderate, and high. Less than 5 points, 6 to 7 points is moderate risk, and more than 8 to 12 points is a very high risk of having the placenta adherence. So coming to our referral, who is third gravida para 2 live 2 post-cesarean, referral at 33 weeks, and with all the features of ultrasonography as well as the 2D, her score is at 11. So we know that she is a very higher risk of having the chance of adherent placenta, so that the teams are ready. And then detailed counseling, which includes multidisciplinary approach of cystoscopy, ureteric stenting, hysterectomy, blood products were also explained, including prolonged hospital morbidity for this. And this clip again I have shown the longitudinal section and then incision, and then the uterus is incised at the upper segment and fetus is delivered, and then hysterectomy we had to proceed ahead. And this is all done by the placenta accreta team. The motivated surgeons in the hospital, they formed into a team which are more skilled than the gynecologists and obstetrics, what we do. And this is how we manage the case. This particular woman required 28 units of blood and blood products. So that is why interventional radiology, whenever there is a scope, then there is a high possibility that the blood requirement can be reduced, as the previous speaker has said. Now we move on to the Doppler in the fetal growth management, for which accurate dating is very important. Apart from the Negeli's rule, it is the crown rump length and then head circumference in the first trimester, which are important factors to identify the gestational lace. The first trimester gestational lace, CRL, is the gold standard, and we all have to follow the rule of ISWAG that if at all there is a gestational lace determined in the first stage, we should not be changing it in subsequent scans, and it remains the gold standard. Once the gestational is determined in the first stage, in the third trimester, then we will follow the biometry, which includes head circumference, abdominal circumference, and femur length. Estimated fetal weight is calculated by the Hadlock formula, and this is plotted onto the fetal growth curves, dividing the fetuses into either appropriate for gestational lace, large for gestational lace, or small for gestational lace. By definition, small for gestational lace means estimated fetal weight less than 10th percentile for that period. I strongly recommend you follow this update on the diagnosis and classification of fetal growth restriction SGA by the Barcelona group, which we follow in our hospital. It has brought in uniformity in the management of these cases. What this update says, whenever the fetal weight is less than 10th percentile, look at whether it is less than 3rd, or do the uterine artery Doppler if it is high resistance, or the CPR is less than 5th centile. If any of these things are there, then the fetus belongs to the fetal growth category, fetal growth restriction category. If none of them are there, then it belongs to the small for gestational lace. And the protocol for the small for gestational lace, we have to do the estimated fetal weight every 2 weeks and can induce at 40 weeks. Let the women or fetus go beyond the 40 weeks. Whereas if any of the parameters are there, we have to go ahead and do the multi-vessel Doppler, which not only includes the uterine artery and umbilical, which were already done, but it also includes the ductus venosus Doppler. And hence, it is important to divide these into 4 stages. Stage 1, if it is one of the things are abnormal, then we have to monitor them weekly and induce the labor at 37 weeks of pregnancy. In the stage 2, it is the absent endorsal flow, so we have to do the Dopplers every bi-weekly, and recommended is cesarean section at 34 weeks of gestation. If it is a stage 3, that is umbilical artery reversal or ductus venosus is high velocity, then we have to do, admit her of course, and 1 to 2 days, every day we have to do the Dopplers, and then at 30 weeks the cesarean section is recommended. Whereas stage 4, ductus venosus reversal, we have to consider birth depending upon whatever the salvageable period is there. When we are anticipating a preterm birth, that is less than 35 weeks, we have to give the steroids and then of course magnesium sulfate when we are considering the birth less than 32 weeks. So let us see how these are, it is all easy to say in the guidelines, but how do we implement them in the clinical practice? Here is a third gravida para 2 live 2, gestational age is verified, 37 weeks, estimated fetal weight is 2.4 kilograms. So I don't know whether it is a normal grown fetus or growth restricted fetus or I don't know what it is. And then what is important is Google via, all the chat GPT and everything is there. So when you Google it, Google to the proper, lines, that is Barcelona, I have said, they have an online calculator. Even at Fernandez Hospital, we use this online calculator to categorize the fetal growth parameters. So we put this information into that, and then it has shown that estimated fetal weight 2.4, and then the estimated, the centile is that 14th centile. We know that small for gestational is less than 10th centile. So 14th centile means what is the diagnosis? It is appropriate for the gestational age, and therefore it requires only the standard obstetric protocol. No intervention is required at this point of time. As we move on, 37 weeks, third gravida, previous 2 miscarriages, and estimated fetal weight at 37 weeks is 2.2 kilograms. So I put this into the calculator, then it showed that percentile is 2 percentile. So second centile means we know that less than third centile is a fetal growth restriction. So it belongs to the stage 1 of fetal growth restriction, and therefore the delivery recommendation is there at 37 weeks of gestation. Because the Doppler is normal, still we can go ahead with the induction of labor. As we move on, here second gravida, first miscarriage, gestational hypertension. At 32 weeks of gestation, her estimated fetal weight is 1 kilogram, and then umbilical artery Doppler is absent and diastolic flow. So let us put it on the calculator. Estimated fetal weight is 1 kilogram, which is 0 centile, and then umbilical artery Doppler is absent and diastolic flow. So it is stage 2 of the fetal growth restriction. What is the recommendation? We have to follow every 2 to 3 days, and then we consider birth by cesarean section at 34 weeks of gestation, or whenever it becomes, mother shows more of preeclamptic signs, because 30% of the women still develop hypertensive disorder whenever there is growth restriction. Also, if it is reversal of flow, we have to consider birth immediately. Okay, this baby was doing all right. Then another case, second gravida para 1 live 1, 35 weeks of pregnancy. Previous baby is already CP. At 28 weeks, she was referred, and umbilical artery is showing absent and dorsal flow. Weight of the baby is 530 grams. So do you think we can salvage this fetus? So that's where comes the issue. If we put this into the calculator, 530 estimated fetal weight, 0 is the percentile, and absent and dorsal flow and reversal and axial flow, it is stage 4 fetal growth restriction. So all of us should have the surveillance test cut off. Where do we draw the line? At Fernandez Hospital, the limits of viability are 26 weeks of pregnancy and estimated fetal weight of 750 grams. If any of the fetus or mother reaches this target, then we go ahead with the growing aggressive, that means Dopplers frequently, give the steroid, give the magnesium sulfate, and deliver. But 530 grams is too low to salvage as well. Therefore, counseling and then preparedness of the mother for the adverse perinatal outcome is very important. Now we move on to our last case, that is 4th gravida, para 2, live 1, was 1 miscarriage. She's 35 years, O negative, rhesus negative, husband rhesus positive, previous neonatal death probably due to the high drops, and then current pregnancy, she's ICT positive. So Doppler plays a major role in helping the fetal anemia diagnosis as well as management. The rationale for doing the middle cerebral artery Doppler is that the parameter we see here is the peak systolic velocity, because there is increased cardiac output, reduced viscosity because the hemoglobin is less, and then there is hyperdynamic circulation, which can be manifested at increased peak systolic velocity, and middle cerebral artery is the artery that we sample here. And MCA for the fetal medicine consultant is called as darling vessel, because it is very, very approachable and then doable. So the peak systolic velocity is plotted on the graph. This is called as Mary's curve. If it is more than 1.5 multiples of median for that period of gestation, then the fetus is said to be anemic. If it is less, then it is different. So the Mary's curves also have different zones, A, B, C, D, depending upon the peak systolic velocity for the period of gestation. If it is D zone, repeat MCA 2 to 3 weeks. If it falls MCA in the C zone, that is 7 to 10 days. If it falls in the B zone, 5 to 7 days. Whereas if the MCA peak systolic velocity falls on the A zone, that is more than 1.5 multiples of median for the gestation, then it is fetal anemia, and therefore we need to transfuse this. So the algorithm goes, if it is more than 1.5 and then less than 35, cardocentesis, and then you have to transfuse. If it is more than 1.5 multiples of median, peak systolic velocity trend we have to see. If it is less than 1.5 multiples of median, sequential monitoring till birth or at 37 weeks of pregnancy, we can consider this birth. Our case, it is rhesus negative and ICT positive. So MCA peak systolic velocity is showing A zone here, and therefore we give the blood transfusion. The first transfusion, we also collect the blood and ask for the fetal blood group and type, bilirubin, karyotype if it is possible. For this, our case, the pre-transfusion hemoglobin is 4.7. It is almost on the verge of developing fetal high drops. And 50 ml of O negative blood transfusion was given. You can see the streaming into the cord, the Brownian movement. So that's where the cardocentesis is done, and then blood transfusion was done. So soon after the blood transfusion, the peak systolic velocity has dropped. So do we take a rest and relax? Not really, because ICT is positive. There are antibodies, and hence hemolytic anemia still may occur. And she is just 27 weeks. So there is no way that when fetal therapy is available, we are going to deliver this baby. And hence we continue to monitor. 5 weeks later, again the peak systolic velocity reached A zone. And therefore, second IUBT is planned. So pre-transfusion hemoglobin is 7 grams. We gave 70 ml of O negative compatible blood transfusion. And then post-transfusion, the hemoglobin has increased to 16 grams. Also, you can see that there is a drop in the MCA velocity, which has fallen down. So this says that our management was good. At the same time, the fetal hemodynamics are settling. And now we continue to monitor. At 34 weeks of pregnancy, again it reached the A zone. At 34 weeks, we are all comfortable. If required, there is a debate: do we give intrauterine transfusion or deliver and then give the exchange transfusion? This woman required a C-section at 35 weeks of gestation, and the baby is 2.2, doing very well. Monitoring twins is not possible without doing the Dopplers. So in a case of dichorionic diamniotic twins, we follow them every 4 weeks, and Doppler is required only there is one or both the fetuses are having the fetal growth restriction, just like the singleton pregnancy. Whereas monochorionic twins, because they have specialized and then unique complications like twin-twin transfusion syndrome or anemia polycythemia sequence, and therefore we have to follow them on a regular basis every 2 weeks. And then Doppler is one of the constituents of this monitoring, and we consider monochorionic twins delivery at 36 to 37 weeks of pregnancy. Whereas monochorionic monoamniotic twins, the same will follow, but the delivery is around 32 to 34 weeks of gestation with the steroid and magnesium sulfate as well. So Doppler is one of the very important vital parameters for the monitoring of especially monochorionic twins or dichorionic twins with the growth restriction. So I conclude saying that the Doppler doesn't have any role in low-risk pregnancies, whereas the Doppler is an important non-invasive tool for the high-risk pregnancy. It helps in the screening, diagnosis, and management of various abnormalities or pathophysiological conditions, and surveillance is always disease-specific. In a case of growth restriction, follow the PI values, not the SD ratios anymore or RA ratios anymore, whereas in a case of fetal anemia, follow with the MCA Doppler peak systolic velocity. Thank you very much for the opportunity and patient listening.
Thank you for the excellent lecture, Sushila. Any doubts from the audience?
Sorry, sir, increased? Yes, thanks, sir. You always put me on spot, right from my post-graduation days. See, Doppler is assessment of the functional fetoplacental functional unit. So it is possible to have high resistance sometimes. High resistance is fine. Then, I suggest that we go by the abnormal parameter so that we will be increasing the surveillance. But high resistance is not a trigger point for the birth. Whereas in case of absent endoceral flow, sometimes we do get this tricky situation of the intermittent absent endoceral flow, because the PI values are very varied from the placental cord to free loop of cord to the fetal end. That is why in a singleton pregnancy, always it is suggested to sample the free loop of the fetal, umbilical cord. So in these cases, if there is absent endoceral flow, go for a kill. Means, you admit her, monitor her, give the steroids, but do not immediately take an action. If there is a pathology, I am sure that it will manifest sometime little later. By giving the steroid, we are, gaining time. We are buying time. And if it is a constantly absent endoceral flow, then it becomes easy because the recommendation is delivery at 34 weeks. As a matter of fact, at Fernandez Hospital, we birth them at 32 weeks if there is absent endoceral flow, because in our neonatal follow-up cases, we realize that the neurodevelopmental challenges are more when we birth them at 34 when compared to 32. So the guideline says 34, intrauterine hypoxia. That is the reason why we do consider the birth at 32 weeks gestation itself. So though I answered about the absent endoceral flow, same thing holds good for the increased resistance, sir, because we keep them coming for the monitoring twice a week, every 3 days or twice a week. So the monitoring protocol will increase, not the actual action. We have to respond but not react. Thank you all. Thank you, chairpersons.
Thank you so much, ma'am, for such an informative session. I request Dr. Janardini ma'am and Dr. Bharti ma'am to please felicitate Dr. Sushila ma'am. Thank you so much, ma'am. I request the chairpersons to stay back for the next session. I request Dr. Anita ma'am to come forward to chair the next session. Dr. Anita ma'am is senior obstetrician and gynecologist with 15 years of experience at KIMS Hospital, Guntur. Moving forward to the next session, recent advances in gynecology. The speaker for this session are Dr. Urmila ma'am and Dr. Sujata ma'am. Dr. Urmila ma'am is cluster head and senior consultant of Department of Minimally Invasive and Robotic Gynecology at Aster MedCity, Kochi, Kerala. She is director of Urmila Center for Minimal Invasive Gynecology, Kochi. Dr. Sujata ma'am is consultant gynecology at Sujata Laparoscopic Center, Kotapet, Guntur. She is a faculty for hysteroscopy training workshops. I request ma'am to come forward on the stage for the session.
Over to you, ma'am.
A very good afternoon, one and all. Warm greetings from Aster MedCity, Kochi, Kerala. And my topic for today is Future of Gynecology, the Robotics and the Innovation. Actually, myself being a hardcore laparoscopic surgeon for 22 years, I was quite reluctant to take up this technology, more considering about my patients, what will be their cost, will they be able to afford, am I depending too much on this technology, what this can offer for my patient regarding the safety and the morbidity. So the evolution of minimally invasive surgery from open to laparoscopy and now to robotic, and there is a constant need for upskilling. And why robotic surgery is the next frontier, I'll be showing you a few videos, just you can decide. And you know that this robotics has come in a big way, and all the other specialities has taken up, especially cardiothoracic, colorectal, general surgery, gynecology and head and neck surgeries. And once thought to be a futuristic idea, where time may never come, robotic surgery is here to stay. And coming to laparoscopy, the strength and limitations. Strength are reduced morbidity, shorter hospital stay, established instrumentation, and the limitations are restricted degrees of freedom, 2D vision, steep learning curve of complex procedures, and ergonomic fatigue. I know almost all of you must be doing laparoscopic surgeries and you know what it is. And why transition to robotics? This is because of the enhanced precision control, 3D HD visualization, endo-wrist articulation, tremor filtration, superior ergonomics, and it facilitates the complex dissections. And what is the difference? Laparoscopy and robotic surgeries are performed using similar techniques. The surgical principles doesn't change at all. And robotics is technology, a more sophisticated extension of traditional laparoscopy, I should say, and robot can reach where the surgeon's instruments in laparoscopy can't reach into deeper pelvic spaces. And this is the endo-wrist movement which these robotic instruments can offer with the advancement of the technology. And skill transfer from laparoscopy to robotics, that is something very important. What happens is that there is a lot of dissection when happening into deeper pelvic spaces. The tissue handling experience is an asset, and dissection planes and anatomical understanding remains the same but with better visualization, and the energy source knowledge transfers directly. Camera navigation is easier with robotic system because you don't have to depend on somebody else for your camera. You can work on a steady platform, and this is exactly what is being done here. That is the technical perfection and the steady platform which you can sit and work on. And building a robotic program, you need an institutional support, trained team, and case selection during your initial phase is very important, documentation and data collection, and continuous audit and improvement. And common challenges which you face when you when the transition phases from a laparoscopic surgeon to a robotic one, the console camera coordination, lack of haptic reader. See, in laparoscopy, when you use your straight stick instruments itself, you can go touch and have some feeling of the pressure or the strength with which you are handling your tissues. But this doesn't happen with a robotic system. And initial increase in operating time, yes. Overcoming the resistance to change is the thing. A surgeon should have that conviction about the technology to take up this and move forward. And team training and synchrony is the key for a successful program. And definitely we are talking a lot about the advantages of robotic system, but there are disadvantages also regarding the tactile feedback. And once the arms are docked, the position of the patient cannot be changed, and the setup time, yes, with the generations of actually I'm working with Da Vinci Xi system, and as and how it's almost there into the market of past 20 years, and there are different generations, latest ones coming up, and that has definitely decreased the docking and undocking time there, and the maintenance cost of this robot. And what exactly it is doing to our patient part is that patients experience less amount of pain, and this is mainly because of the fulcrum effect. So once the robotic arms are docked and the instruments are in place, whatever movements you are creating is only at the tip of the instrument and very less movement onto the abdominal wall. And this translates onto the patient part as less postoperative pain, and also the tissue handling and the dissection is very fine, so that there are no much charred tissues left behind. Tissue handling is less, and that is being transferred onto the patient side as a lesser postoperative pain as well as the morbidity. Another important function that has been incorporated here is the Firefly mode. This integrated fluorescence imaging help you to identify ureters, bladder, bowel, if the ICG is put into these organs, and then you can illuminate and go precisely and do your dissections properly. So coming to the robotic applications in gynecology, you can do all your procedures including urogynecological, pelvic reconstructive surgeries, gynecology, and even in reproductive endocrinology. And robotic applications in benign gynecology. See, when I started my journey, I was not very convinced in having this robotic system for smaller uteruses, smaller cysts, or minimal procedures, because as an experienced laparoscopic surgeon, I always had that confidence that I can do it in without causing much cost. The cost effectiveness definitely matter, and not depending too much on the technology. But in complex surgeries like large masses, obesity, repeat surgeries, frozen pelvises, and reconstructive procedures, yes, this has got a definitive role. And for the patient, it becomes a reduced hospitalization, quicker recovery, less postoperative morbidity, fewer perioperative morbidity and complications, lower estimated blood loss, and less patient score. And this is how a surgeon sits in the console and work. And when you start talking to a patient about robotic surgery, they'll be telling like, oh, the doctor is not coming near me and operating, some robot is going to come near me and operate. So a lot of effort was taken in the initial stages to counsel the patient, make them understand what exactly is being done. And always I assure my patients that I never go out of the theater or never leave their operation table, so that any time I need to have an access onto my patient, I'll be always there. Only thing is that whatever movements I am producing sitting inside the console is being mimicked on real time onto the patient side. And we'll just go and see these cases one by one. And these are two different scenarios of robotic hysterectomy. This is again a case. See, I'm using a harmonic scalpel here, and you can see how now it's being converted into a robotic one. So the steadiness of the platform, you can see there. I'll better demonstrate in some other video. So this is the precision work which we are doing. See, the tip of the instrument is only 3 millimeter, but in laparoscopy it's 5 millimeter, and the stability and the vision. You can see all the small vessels are directly in front of your eyes, and this is the case of previous cesarean section. Both are previous cesarean sections, and here you can see this is a ventriflex uterus. So ventriflex uterus, what happens is that you never know where your bladder begins and bladder ends. Your cervical length will be more than what is expected, and here this is the end-on dissection for the bladder, and see how meticulously I can sit and do my dissection. So they cannot scroll it back. Actually, I've kept the bookmark. I cannot see the bar now. Okay, so this is how it goes, and I just want to fast forward it. I cannot. So, taskbar. I cannot see the taskbar. Yeah, it is there, but enlarge more. Yeah. I'm sorry for this. Okay, now see the bladder dissection here. This is the long cervix there, and this is the bladder there, and meticulously I'm getting all the bladder fibers out there. And this sort of dissection, it becomes very easy. I'm not depending on anybody else. My surgical platform is stable, and here, rather than using a uterine manipulator, what I've been using is a prograsp, and that helps me in having a better traction, counter traction, and all the dissection planes are well shown, and the surgery can be completed with actually the postoperative time, blood loss, everything is far better when compared to a laparoscopic procedure. So this is how the suturing happening here, and this is the end of the surgery here. And coming to robotic myomectomy, these are two different scenarios. And you can see one is an anterior wall fibroid, another is a submucosal fibroid. This is a ultrasound transducer which is used to map the myoma. So before putting the incision, I can know where my uterine endometrial cavity is, and then I can put my incision accordingly. Actually, this was a posterior wall submucosal myoma. You can see the incision out is being made, and in myomectomy, what is the key is that get into the correct plane and go ahead with your dissection, and you can do a thorough enucleation, keeping yourself very close to the myoma there. And this is the endometrium out there, and without causing much damage to the endometrium, you can go ahead with your suturing. And can you see here, this is the correct enucleation plane, and with the actually in laparoscopy what we do, we put in a myoma screw, do a lot of traction, counter traction, and enucleation happens. But here you walk around with your camera all around the fibroid, and see, that is the endometrium there. Without damaging the endometrium, this has been done. The most important thing is that while suturing it back in 3 different layers, you're not supposed to leave back any dead spaces there. So without including the endometrium, fertility specialists are here. And again, you can have these iatrogenic adenomyosis, which if you are going to include this endometrium also along your suture line, you can have this adenomyosis happening. So you can get rid of all these things precisely. You can go ahead and suture, and this is the first layer being done, this is the second layer, and here what I am doing is the uterine artery ligation at the origin. This was prophylactically done because this patient already had completed her family. She was in her early 30s, and she didn't want to take she didn't want hysterectomy. So that was done prophylactically on both the sides, and this is how suturing happens. And in laparoscopy, you know how much traction you are applying onto your suture, and here in robotics, you don't have the tactile effect. So depending on that experience, once it comes, like depending on the blanching of the tissues, we tighten. So these are the suturing happening with barb sutures, and this is the end point. So now coming to this is also myomectomy. Can you see? These are both are cervical fibroids. Here on the left hand side, what you are seeing is a posterior wall cervical fibroid, and right hand side you will be seeing a anterior. See, this is an anterior wall fibroid. Actually, these are all broad ligament fibroids, and you cannot even see the uterus out there. So, depending on the decision of how to make an incision, actually in anterior ones, how will you put an incision? Parallel to the UV folder peritoneum. So, what happens? I'm trained in laparoscopy as an ipsilateral surgeon, and when I put an incision onto a myoma, I always decide on how I'm going to suture. And my incision line comes, the decisive factor comes onto that laparoscopic platform, how well I can suture. But here in robotics, depending on the site shape, you can just change your position and then put the incision in the correct way, what it exactly need to. And this is a posterior wall fibroid, and you must have already seen the ureters were running very close to the pelvic side wall. This is a ureter actually. You can see the peristaltic part of it, and then once I come here, what happens is that this whole thing is arising from the junction of the cervix and the vagina. So some colpotomizer is kept there, so that this is completely being detached. So the problem is after detaching. So once you get detached from there, I'm putting it into the endobag and taking out that specimen through the colpotomy. So you will have to sit and reconstruct, right? So I have kept a sound negotiating the cervix to the uterine cavity through the vagina, and then this is the reconstruction part happening with the uterosacral ligament out there, taking care of where exactly my ureters are, and then slowly the reconstruction progresses, and on, see, that is a uterosacral ligament reconstruction, and then you can see the sound happening there kept in place. So this also actually the anterior one sitting, see, this is the reconstruction part happening. So this sort of reconstruction, it would be very difficult with laparoscopic instruments and the platform. Can you see that is a sound passing in, and cervix is being reconstructed, and this is the postoperative picture here, and this is after reconstruction in this part. So this sort of advanced surgeries, yes, definitely robotics has got a role, and this was a large degenerated fibroid, and again previous cases myomectomy linear incisions were made, but this was a bigger one. So I think my time is up. I'll just show you all these things can be possible, and here this is the suturing part, and it's like just like laparoscopy, the size of the myoma, the size of the uterus you are handling, it increases with your experience, and you can go ahead with larger sizes also. And this is a case of both the sides ovarian cystectomy. One is with multiple dermoid cysts on both the ovaries, another with an ovarian endometrioma. So can you see here? These are the, so I've already kept the bag there, enucleating all these dermoids and then putting it into the bag, and the completeness of the surgery, small daughter and dermoid cyst onto that. And the beauty of that is that I can leave back healthy ovarian cortex with minimal trauma to the tissue and minimum use of energy sources in this case. And can you see that that's much sort of the completeness of the surgery, and that will help in reducing the recurrences. And see, this is an endometrioma here. This chocolate material coming out, bowel adherent to the posterior surface, and all these things you can beautifully do without causing much damage. Here the bowel is being retracted down, and the amount of ovarian tissue which is being left back, you can see that will help a lot, this sort of surgeries. And again, I'll just skip through all these things. This is a case of chronic ovarian torsion, and you can see a big mass sitting there. Twice it has been gone around this pedicle, lost this blood supply. And this was a case of post-hysterectomy chronic torsion, and that is a normal ovary there. And this was almost onto the bowel there with all inflammatory responses. So I could go ahead and do a surgery in confidence, with confidence, so that I'm not going to damage any of the important organs around. And this is with endometriosis, and this is a nerve sparing endometriotic surgery here happening. See, I already told you about the role of ICG there, and I should say, see this, my ureter is there, that was a hydroureter sitting up there. So if the ureter is held up like this up there, there can be nerve entrapment also in such cases. So that you have to do a nerve sparing surgery in such cases. I'm opening the pararectal space there, identifying the nerve there, and the surgery goes on. And this sort of advanced cases, definitely robotic surgery helps. And even for adenomyosis, same thing. For want of time, I'm not urogynecological procedures. I can show you the same surgeon doing. See, this is a case of laparoscopy pectopexy being done here, and onto the other side, after hysterectomy, I'm combining and doing a laparoscopic pectopexy here and a robotic pectopexy happening here. You know, same surgeon. It's a tremor filter that is helping here to give me a steady platform, and this helps a lot in the suturing also, and developing a space laterally, creating a 4 centimeter long iliopectineal raw ligament there, and suturing onto the mesh laterally. Actually, this is a very vascular space. Between the major vessels, I have to sit and do my suturing, and all these things I can do with ease. And you can see here my straight stick instruments, I'm finding it very difficult, and here I'm not confident enough to use my sutures because the turning of the instrument becomes a problem. So in this case, what I have done is I have applied tackers on both the sides with the mesh. So that is the difference, and here actually I'm combining it with a Birch Colpo suspension also. This is the space of Retzius, Cooper's ligament, paravaginal sutures being taken up, and all these things I can do without causing much fogging. I'm actually operating too near to the organs, but what happens in laparoscopy, when you operate too near to the organ, there will be a lot of fogging. Each time you will be pulling out your telescope, cleaning and reintroducing, and then you will be losing the plane of dissection. But this doesn't happen. Again, this is a case of sacrocolpopexy where I have to dissect down a lot because this was a en masse descent, and then I'll have to prepare and put a V-shaped mesh down there, going deep down into the levator ani there. I have to pull up the whole thing because rectocy will not be corrected if I don't put the mesh deep down there. And this is how you measure how much tape you have to custom make, and then no excess mesh should be left beyond. Lot of suturing happening there, and then you know, that is a ureter there, and that is the final part. And when you keep a mesh, always go peritonize, and that is the end point of it. And out of the box also, as a surgeon, my confidence level has increased with this platform, and I've started pushing my boundaries. And out of the box, we were doing different surgeries, and this was one among them. A 36 week size uterus, and this is a vessel sealer which is being used here. You can see how it is sealing and going. Large tortuous vessel sitting there. For this case, I have kept everything. Like my laparoscopy set was ready, laparotomy set was ready, blood was ready. I just wanted to see whether I will be able to do this or not. And then I could complete this surgery with hardly 40 to 50 ml blood loss. Without blood transfusion, I could do this. So the task here was not the bleeding part. How will I take the specimen out? That was the problem. And once it was detached completely, can you see the vessels there? So if one bleeder happening either from the vein or the artery, this immediately that field will be lost. So everything was kept ready, and I could do that. And after detaching that is a specimen sitting onto the aorta and pulsating, and then I had to take it out. This lateral coring technique was used transabdominally, reverse C-shaped incisions. I could take it out as a single piece, and this was the same vaginal morcellation which we do. I've done it abdominally, and the specimen weighed about 4.82 kg. So again, this is another case of arteriovenous malformation. And this was happening. This was an AV mass sitting there. This is the ureter there, and this arteriovenous malformation was there at the internal iliac artery. And as and how the mass was exposed, you can see the pulsating mass sitting there, and going very near to such pulsating masses, you get all confidence just because of your steadiness of your platform and because of the vision and the tremor filter. Otherwise, it would not be possible. Actually, this was a case referred to the interventional radiologist, but what happened was, since it was a 9 centimeter big one, they didn't want to, they gave back and told that better to do, go ahead with the surgical thing. The whole mass was not excised, but all the feeders and the AV mass itself was reduced by putting multiple ligatures with silk and number 1 silk. And CTVS doctor, she was standing next to me, and I could convert it into a high resistance low flow system. So, so many we were we were doing so many after the box cases also, and like I always said, as I already said, these are the benefits for the patient, and as surgeons experience, limiting factor for performing laparoscopy are the surgeon's skills, experience, and availability of proper instrumentation. Time for mastering endoscopic surgery and suturing using robotic technology may be shorter for those having less experience in laparoscopy, and robotic assistance may enable more surgeons to do minimally invasive surgeries and convert their open procedures to the same. So when I was introduced to this technology, the company, they said that it was easy for a open surgeon to get converted into a robotic surgeon, but in my experience, I should say that laparoscopic surgeons, they have an edge towards becoming a better robotic surgeons, because all these both these technologies share so many common principles in minimally invasive gynecology, right from ergonomics to port placement to specimen retrieval, and your judgment and your eyes, your experience into the pelvic spaces, all these things matters for you to get converted into a better robotic surgeon. And these are our publications, academics, and these were the spectrum of robotic procedures which we are doing. And my first case was done in May 2023, and from there my robotic journey. Earlier I used to sit and counsel my patients about robotics, and I have to sit and fight with the insurance people, but now the scenario is people are coming and asking me for robotic surgery, and the insurance people are also coming up because I talk to them with my data. These are the QTIs comparing different surgeries on both the laparoscopic arm and the robotic arm done by the same surgeon. And the advantages which I gained after transition is confidence in handling complex benign and malignant cases and improved patient outcomes, increased surgical satisfaction, expansion of surgical indications, and long-term benefits for ergonomics and longevity of the practice. Even after a whole day of robotic surgery, I still have my time and my health to be spent with my family. And these were the milestones achieved throughout this journey, almost nearing 400 cases now. And the words of advice: embrace the learning curve, leverage your laparoscopic foundation, practice diligently, stay updated with the technology and techniques, and collaborate with learn from the peers. And in summary, robotic surgery is a natural evolution. Laparoscopic skills are not wasted but enhanced. Structured transition ensures safe outcomes. The future is technologically driven, and be ready for that. And this is not the Da Vinci Xi system. This is D5. This is a fifth generation Da Vinci, where you have even the haptic sensation. So the pressure with which you are handling tissues, that even you can do. This is completely a surgeon's autonomy. You don't even have to take the head out of the console to do to change it to a firefly mode or camera moving up, down. Everything is being done inside the console, and that becomes actually a boon to the surgeon. And this is my team. This is after my first case. This is Dr. Rohit Renade. He was my proctor. I never end my presentations showing this slide because it's very close to my heart, and he was there with me as a proctor. And this is my journey, and thank you all for patient listening.
Thank you, ma'am, for the wonderful insight into the robotics. Any questions?
Thank you, ma'am. That was a very wonderful presentation. You walked us through all the surgical procedures through robotics. You actually mentioned that when coming to the larger masses, the robotics has a better precision. So are there any different tissue retrieval systems in robotics when compared to the laparoscopy, or is it the same way that we go?
As I've already told you, I'm a hardcore laparoscopic. I was a hardcore laparoscopic surgeon, and whatever you are seeing here is just the translation of my experience into a robotic technology. That's all. It's not like one fine morning I've given a robot and I started doing it. It's not like that. That is for the juniors here to listen to. It comes with a learning curve, and I had always that confidence that because I'm a laparoscopic surgeon, I can do anything with robotic. It's not like that. After 2 cases, I understood that. The ergonomics is completely different. So the techniques, ergonomics, yes, they have something to share, but the ergonomics is completely different. So the port placements in laparoscopy doesn't come in the same way as in to the robotics. And also, we have got an assistant port up there, so that somebody helping from the patient end, they can put in a cannula, they can give you sutures, you can help you in surgeries. But in the myomectomy which I showed, I used a stenoculum for robotic surgery. Earlier I had the thing that I use a lot of myoma spiral for pushing, pulling the myomas and then enucleating it. But the same myoma screw, if it is coming onto that, see for laparoscopic surgery, all the instruments come and act as a triangle. So triangulations are always at a particular point, and this is a 60-degree working angle at every point. But in robotics, it is not like that. All the instruments are coming end on. And by the time you reach the tissue, only the tip of the instrument moves. And suddenly, if you are bringing something against the rule, again hitting of the instruments happens. So that sort of things happen, and slowly, as your experience increases, you will be like tuned more towards your robotics.
Regarding complications, anything more with the robotic?
Touch wood. I'm waiting for one, because I thought that was my, I didn't have much confidence up to my first 10 cases, because I always thought maybe what will happen if suddenly the current goes off? What will suddenly if this instrument is not working? And over 20 years into the market and into the system, with lot of advancements they are incorporating. Actually, this is a DeFi, actually I'm working on an XI system where artificial intelligence is being incorporated. Yet anything, the machine itself detects any technology. The problem, if suppose some instrument, it's not maybe the life of the instrument, completed the life of it, it will not work. It will show that this is the proper error, and you have to rectify this to continue with your procedure. That machine itself prompts. And 24/7 assistance is there from the company across the globe. We are sitting here, this part of India, the amount of work, I told you about 400 cases and all. I have gone across to US Connect programs and all. I've seen people who have done more than 5,000, 6,000 robotic surgeries, and we are just catching up with them. And this is a technology which is coming in, and we are adapting, and we are also moving ahead along with the world.
Thank you.
That was a real feast to our eyes, ma'am. That was an excellent presentation. Thank you.
Thank you, ma'am. Now I request Dr. Sujata madam for the talk.
Good afternoon, everyone. First of all, thank you, Dr. Anuradha and Team Ramesh Hospitals for giving me this opportunity. Today, my topic is taking control of endometriosis. As you all know, endometriosis is a chronic inflammatory disease due to ectopic endometrium. The incidence can be as high as 50% in infertile women. And the pathogenesis, as you all know, it's due to retrograde menstruation and reflux of the endometrium. And why this refluxed endometrium gets implanted? It is because of the immune dysregulation. And a relative high estrogen to progesterone ratio, it augments the disease. So in endometriosis, we all know estrogens increase and progesterones decrease the endometriotic implants. And always we should remember that it's a chronic, progressive, and a lifetime disease. All estrogen-based diseases are lifetime diseases. We shouldn't think that they end by menopause, because there are extra ovarian sources of estrogen. Adrenal androgen and the adipose tissue are the causes for extra ovarian estrogens. So how does the adipose tissue produce estrogen? It is because of the aromatase, which converts the androgens into estrogens. So coming to the tissue aromatase activity, breast fat has the highest aromatase activity, subcutaneous fat has high, gluteofemoral moderately high, and visceral adipose tissue has less aromatase activity but high inflammatory activity. So always insist on normal BMI, lifestyle modification and weight loss for all your gynec patients. Coming to the symptoms, pain and infertility are the common symptoms. Pain, you all know the different types of pain, and infertility, especially infertility in endometriosis, is because of anovulation, luteinized unruptured follicles, progesterone deficiency, tubal distortions, and the important cause is inflammatory mediators in the peritoneal cavity. So how to diagnose endometriosis? Never skip a physical examination for any female coming to your OPD. Physical examination, simple pervaginal examination, you can diagnose with scarring or puckering in the fornices. And coming to the imaging, it's always better to have a bedside ultrasound, and imaging vaginal ultrasound, rectal ultrasound in adolescents can diagnose endometriosis. MRI is rarely indicated. A typical endometrioma can diagnose endometriosis. Otherwise, subtle signs, never miss subtle signs in endometriosis in the absence of chocolate cysts. What are the subtle signs where we can diagnose endometriosis? A fundal retroflexion, an ear sign, or we can see kissing ovaries without endometriomas, or a case of infertile lady who is under ovulation induction. If you have recurrent luteinized unruptured follicles or a recurrent hemorrhagic corpus luteum, always suspect endometriosis. And the signs of advanced disease, your transvaginal ultrasound, with your transvaginal ultrasound, you can diagnose bowel involvement. You can carefully track the bowel, and you can diagnose adhesion. There is increase in the thickness of the muscularis layer, increase in the hypoechoic muscularis layer, which with probe tenderness, that can diagnose the involvement of the bowel. That is very important preoperative diagnosis. Laparoscopy is no longer a gold standard for diagnosis. So this is a typical endometrioma, and this is the ear sign, which is a subtle sign which can diagnose endometriosis in cases of sometimes in the absence of endometriomas, where we have retroflexion at the fundus. This is an image of kissing ovaries. And coming to the medical treatment is the first line treatment for endometriosis. So what are the principles? We should decrease the estrogen levels, increase the progestational activity, and the drugs should have anti-inflammatory activity. And most important among all this, a long-term safety profile is very, very important, because you are aiming at long-term treatment, because endometriosis is a lifetime disease. So coming to hormonal treatment, what are all the options we have? We have combined hormonal contraceptives, progestins, GnRH agonists, antagonists, and aromatase inhibitors. So combined hormonal contraceptives, we know the mechanism of action, everything. Coming to the dosage, continuous dosage is better. We have better outcomes, and we know the side effects like venous thromboembolisms and the effects of the breast. But where these combined oral contraceptives are useful, they are useful in short-term treatment. In mild to moderate disease. Only short-term treatment, mild to moderate disease, because they're not very effective in advanced disease, and we shouldn't give them on long-term basis because of the side effects, and especially in women who need cycle control and contraception. Coming to progestins, these are the first-line drugs, the drugs of choice in many situations, and the mechanism of action, we know it is by decidualization and atrophy of the endometrium, and the effectiveness, they are very effective. LNG-IOD is one of the most effective medication. We know the minor side effects and the major side effects of the different progestins. They depend on the preparation. Where these progestins are suited, they are first-line treatment for moderate to severe disease, and we are looking at long-term treatment. So first and foremost thing, while prescribing medication to endometriosis, we should look at the side effect profile. What are all the areas we should look at when we are prescribing a drug? Its effect on breast, its effect on coagulation profile, on bone, on endometrium, metabolic and androgenic effects, all these are very important before prescribing a drug. And the most commonly used drugs in endometriosis are dydrogesterone, LNG-IUS, and medroxyprogesterone acetate. Coming to dydrogesterone, it usually doesn't have any side effects. It is a little, it doesn't increase breast so far. There's no increased risk in breast cancer, no effect on coagulation profile, no effect on the bone mass index, and it has a protective effect on the endometrium. It doesn't have significant metabolic or androgenic effects, and it's well tolerated. But it is a little milder progesterone. It may not be effective in severe disease. LNG-IUS, it's an excellent option, but LNG-IUS, it releases 20 micrograms daily into the uterus, but at the same time, it releases nanograms of levonorgestrel into the systemic circulation. So recently, there have been studies showing mild increased risk of breast cancer, because it is releasing nanograms of levonorgestrel into the circulation. We can have minimal systemic risk on the coagulation factors, minimal risk on the metabolic metabolisms like carbohydrate and lipid metabolisms, but on the endometrium, it has excellent protection. It even reverses atypical hyperplasias, and this is highly effective for contraception. And coming to medroxyprogesterone, it can be used only for short term because it has significant systemic effects, and it has significant effects on the coagulation system and the metabolism. It has androgenic effects. It has effective protection on the endometrium. So coming to the Dynogest, the newer progesterone, we know the mechanism of action: anti-proliferative, anti-inflammatory, anti-angiogenic. But here, Dynogest, we have limited experience only up to 5 years. Safety is studied. We have to wait for, we have to get ourselves updated regularly regarding the side effects. And as of now, it is neutral on bone mineral density, metabolic effects, androgenic effects, and venous thromboembolism. But because it is a 19 not testosterone, always be cautious while prescribing Dynogest for any woman with history of thromboembolism or venous thromboembolism. And coming to elagolix, the recent drug, it is a oral GnRH antagonist, which decreases the estrogen production. The dosage is 150 milligrams once daily for 2 years. It causes partial suppression of estrogen, or 200 milligrams twice a day for 6 months. It can cause strong suppression. What are the side effects? Because it is suppressing estrogen, all the benefits of estrogen are gone. So the bone mineral density is decreased, and we can have adverse lipid changes. So elagolix should be considered as a second-line treatment. It is never a first-line treatment. It is always a second-line treatment for those who do not respond or who cannot tolerate the first-line agents. First-line agents are always progestins. And elagolix, it doesn't have a contraceptive efficacy. It is suitable for only short or medium-term treatment. And coming to letrozole. Letrozole is an aromatase inhibitor. Its use in endometriosis is off-label. In postmenopausal endometriosis, we can use, and letrozole should be reserved for refractory and recurrent cases. The dosage is 2.5 milligrams OD. Letrozole is an aromatase inhibitor. It reduces the production of that estrogen from our unwanted fat. So the adverse effects are hypoestrogenic, hot flushes and all hypoestrogenic features, bone mineral density loss, and hyperlipidemia. So coming to the summary of medical treatment, first line are always combined hormonal contraceptives and progestins. If they are ineffective or unacceptable, then we should go for a second line agents such as GnRH agonists or antagonists. When we go for agonists, we should give add-back therapy. And when that lady or that case is refractory, then we should go for aromatase inhibitors. Aromatase inhibitors can be given along with progestins or other drugs. So the drug of choice among all these, we should see the patient, her body mass index, her risk factors, the duration of treatment, clinical situation, everything should decide. Surgery for endometriosis, coming to surgery for endometriosis, what are the indications for surgery? Severe pain. Severe pain, and when the lady fails to respond to medical treatment. And in infertility, stage 1 and 2 disease, when they fail to conceive in the preliminary treatment, then surgery improves the outcome by removing the superficial disease and removing the inflammatory mediators. And surgery has a role when there is significantly distorted anatomy in symptomatic patients who want to conceive. And prior to ART, when you want to improve the access to the ovaries, then surgery has a role. Surgery doesn't have significant role in deep endometriosis in improving fertility. In improving fertility prior to ART in deep endometriosis, you need not go for surgery. So, and in extrapelvic endometriosis, surgery is the treatment of choice, and postmenopausal endometriosis. And in surgery for endometriosis, always have a proper preoperative assessment. A vaginal ultrasound, good vaginal ultrasound. If she is an adolescent, go for a transrectal ultrasound. Transrectal ultrasound is as good as a vaginal ultrasound, and you can assess the extent of endometriosis exactly. Check for bowel involvement before the surgery, because surgery should always be a one-time procedure. It should always be a one-time procedure. Don't think of a repeat surgery. If you are not confident about the surgery, send her to a place where there is equipment, there is a good experienced surgeon, or who can clear the complete disease. Always plan complete excision of the whole macroscopic disease at one sitting. And a cystectomy should be done. It's not drainage and coagulation anymore. Always minimize the damage to ovarian cortex. Hysterectomy and plus or minus oophorectomy in elderly women depending on the indication, and along with that, removal of the entire visible disease is very important. And coming to postoperative hormone treatment. Postoperative hormone treatment is not indicated in women seeking fertility. As soon as you do surgical clearance, send them to ART center for further treatment, and it is indicated in women who are not planning to conceive. So coming to the fertility treatment, in early stages, it is better ovulation induction. After the initial trial, we can go for ovulation induction IUI cycles. And if they don't conceive in the preliminary treatment, we can go for surgical clearance. In stage 3 and 4, we can try a few cycles, just 1 or 2 cycles of controlled stimulation IUI. And if they don't conceive, better to go for ART. Why ART? It is because the inflammatory mediators, which are gametotoxic, they prevent conception. So in ART, we are overcoming that peritoneal exposure of the gametes. And coming to recurrent disease, endometriosis is known for recurrence because we are only removing the macroscopic disease, we have the microscopic disease. So prevention is first, during surgical clearance, it should be a complete one, it should be a one-time one, complete one, cystectomy and not drainage. And postoperative hormone treatment is very important. Even if you think it is a complete clearance, postoperative hormone treatment is important unless she is desirous of fertility at that time. Long-term hormone treatment in postoperative case of deep endometriosis is important to prevent recurrence. And the treatment of recurrence is either hormone treatment or surgery depending on the situation. And in endometriosis in adolescents, in clinical examination, go for a perrectal examination instead of a pervaginal examination because we can't do that. And in imaging, always do a rectal ultrasound, which is very easy. It's almost equivalent to our vaginal ultrasound. In adolescents, the drugs of choice are progestins and NSAIDs for pain relief. If they don't respond, then we can go for GnRH agonists, but only for 1 year with the add-back treatment. And even beyond that, we shouldn't go because they have adverse effects on the bone mineral density. And surgical treatment, removal of all the visible disease, and depending on the desire for fertility, their marital status, then postoperative hormone treatment. Endometriosis and menopause. In menopause endometriosis, always surgical excision and histopathology should be done. Surgical excision and histopathology. And workup and treatment should be according to the oncology guidelines. Always rule out malignancy in postmenopausal women. And if this surgical excision and histopathology is not feasible, then better to go for aromatase inhibitors. These GnRH antagonists, they don't work because it's not the ovarian source, it's the extra ovarian source that is working in postmenopausal women. So, and coming to extrapelvic endometriosis, surgical removal is the treatment of choice. And if it is not possible, then we should go for hormonal treatment. In thoracic endometriosis, it's hormonal treatment, but I never encountered any. And take-home messages for adolescents, it is pain relief, fertility preservation, and minimal surgery. For reproductive age, balance pain and fertility. For perimenopausal, consider definitive surgery and malignancy risk. And for postmenopausal, surgical excision and watch for malignant transformation. And coming to the surgical treatment, let it be a one-time surgery, a complete surgery. And always insist on ideal BMI and lifestyle changes for all your gynec patients. Thank you all for your patient hearing.
Thank you, madam. You have given a wonderful insight into endometriosis at every stage of women's life. You covered everything from adolescent to menopause.
Nice talk, Sujata. I have one question. I have a 45-year-old patient with chocolate cyst of one ovary. And she
Pardon, ma'am,
has
45 years female?
45 years female.
Madam.
She came for hysterectomy. One ovary had a chocolate cyst, another ovary is normal, absolutely normal. Do we need to remove the other ovary also?
If we don't have any peritoneal, don't have any...
It's confined to the ovary only. Chocolate cyst is confined to the ovary only, no endometriosis elsewhere.
If we don't have any peritoneal endometriosis, I think we can preserve the ovary, ma'am.
We are doing that only because we are preserving the other ovary.
Yes, ma'am. It's better to preserve, ma'am. So because we don't have any other macroscopic disease in that.
In cases of adolescent girls with endometrioma, is there any medical management route?
Medical management, yes, medical management is the first line. Pardon? Asymptomatic. Actually, according to guidelines for asymptomatic endometriosis, according to ASHRAE guidelines, we should not offer any treatment, but we should inform the girl and her parents, and we should follow it up closely. We should tell her these are all the symptoms. If you have such symptoms or the progression of the disease, everything, the biology of the disease, everything we have to explain, and then we should follow her closely. According to guidelines, we shouldn't treat her if she is asymptomatic.
Thank you.
Thank you.
Thank you. Thank you, ma'am. Moving on to the next session, Gynae Oncology. I request Dr. Leela Madam to come on to the dais for her talk on proactive protection and preventing gynecological cancers. I request Dr. Durga Kumari Madam to come on to the dais to chair the session. Dr. Madhavi Lata Madam to come on to the dais to chair the session. Dr. Sunita K, Dr. Swarupa Rani K, Madam to come on to the dais to chair the session.
Yeah, respected chairpersons, senior faculty, delegates. At the outset, I thank the Aster Ramesh Hospital's team for inviting me for this wonderful CME, and my special thanks to Dr. Vasanta. Both of us worked together in Visakhapatnam before she moved to this place, and I moved from Visakhapatnam to Hyderabad. So you've been listening a lot about obstetrics and the advances in obstetrics, how you are saving the lives of women, reducing the maternal mortality, and you also heard a lot about advances in the surgical aspects, the robotic surgery, the urogynecology, how you are trying to improve the quality of life. So I'm actually on a different ball game now. I'm going to talk about the other spectrum, So we have saved the lives of women with fertility related issues, birth and other things, but we need to save them by not getting cancers, because the lifespan of women is increasing, and with increasing age, we will all would be having the risk of getting cancers, not only gynecological cancers, many other cancers. So actually the recent statistics show that India is going to become a capital of cancers in addition to diabetes and hypertension. So that's why the government is focusing a lot on non-communicable disease, and in that cancer is also playing a major role. So I'm going to talk on preventive aspects, not about actually diagnosing the cancer and treating the cancer. We don't want any woman to get into the diagnosis of cancer, so we should aim to prevent it. And as obstetricians and gynecologists, all of us have a role to play in preventive aspects of gynecological cancers. So if you look into the figures, the global burden of gynecological cancers, it is quite significant and it's growing. They contribute almost 14.4% of newly diagnosed cancer cases in women with significant morbidity and mortality. If you come across the statistics of the year 2022, 1.47 million new cases were diagnosed and 680,000 deaths were recorded. This is with regards to gynecological cancers, not about other cancers. So if you come look into the Indian statistics, this is a study from Delhi. You all know that cervical cancer is the topmost cancer. Of course, if you include the breast cancer, that is the #1 cancer in women. Then after that, cervical cancer is the second most common cancer in women. But when you take into gynecological cancers, this is the #1 cancer. Then after that, as I said earlier, with increasing age and women living longer in the postmenopausal age, they are also subjected to endometrial cancer, ovarian cancer, then of course a small percentage of vulval vaginal cancers also we are seeing nowadays. So what exactly is the proactive protection? It's a wonderful statement, and actually when Dr. Vasanta asked me to talk on this, I really have done a lot of literature search to understand what is this proactive protection. It's an active healthcare approach focused on preventing cancer or detecting it at the earliest, most treatable stages. We all know that if you diagnose any cancer in a pre-invasive stage, like in cervical cancer, or if you diagnose it in a very early stage, like stage 1 or 2, we know that the lifespan wouldn't be affected, and we can always aim for a cure in early stages or in pre-invasive stages. So that is what is the meaning of proactive protection. We don't want women to be diagnosed with, when they come to us with the symptoms of the cancer. So this is called as a reactive approach. That means women come to you with symptoms, you examine, you take the history, and then you do the investigations and you diagnose that they have cancer. But many cancers are preventable by taking proactive measures against modifiable risk factors. So we know there are a few risk factors for each cancer. If you can modify those risk factors, you can reduce the risk of a woman getting cancers. So we all know that most of us are going for master health checkups. We are worried about hypertension, diabetes, and many other things. So similarly, we should also be worried about preventive aspects of cancers. I don't think any woman walks into us, at least in the present situation, asking for a pap smear test or a mammogram. But as obstetricians and gynecologists, as a part of our history taking, especially in gynecological cases, we need to ask them whether they heard about cancer screening, whether they had cancer screening anytime in their life. If not, we are going to do one now. So that is how we need to start our part of our history taking. That counseling also should be there. So what is this approach for this proactive protection? So vaccination, screening, lifestyle modification, genetic counseling, preventive or prophylactic treatments. So let us discuss about these things with regards to each of the gynecological cancers. So cervical cancer, we know already that it is the commonest cancer in women in India. Almost every year, more than 130,000 women would be diagnosed as new cases, and more than 70,000 die within 1 year because they're all diagnosed in advanced stages of stage 3 and stage 4. But we know that this is a preventable cancer. This is caused by high-risk HPV infection. Those women who have got persistence of HPV infection in their genital system are at risk of getting cervical cancer. And we know now that it can be prevented by vaccination, and it can be taken care by organized population-based screening. I think all of you must have heard about these global targets declared by World Health Organization, and this is the director of the WHO. 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy, and we can prevent it. How do we prevent it? Through cost-effective, evidence-based interventions, including HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers. We can eliminate cervical cancer as a public health problem and make it as a disease of the past. So that is the statement which was made in the declaration came in 2020, and we are supposed to reach these global targets by the year 2030. So you must have heard this mantra of 90%, 70%, 90%. So 90% of girls have to be vaccinated by the time they reach the age of 15, and 70% of women, eligible women between 30 and 65, at least twice in their lifetime, 35 and 45, they need to have a screening by a high precision test. The high precision test is considered to be the human papilloma virus screening test. And similarly, it doesn't end there. Once they are screened positive, you need to triage further, you need to do colposcopy and offer the treatments. So that is the 90%. So if you remember this slide, this is a wonderful slide which tells you everything in one step, how we are going to eliminate cervical cancer. So as I said, the primary prevention is by HPV vaccination, and after that, as a secondary, you do the screening. You have the VR test, you have the cytology, you have the HPV test, and after that, you can do a colposcopy and I take a biopsy, and based upon the biopsy report, you can offer the treatment. So this is the road for cervical cancer prevention. So just, we all know about the risk factors for cervical cancer. We know that multiple sexual partners, early marriage, early sexual activity, multiparity, and all these things. And now it is proven beyond doubt that HPV virus is the responsible agent, and all other factors are the cofactors. So if you see this picture, you will understand how HPV causes pre-invasive cancer and which can progress into invasive cancer. So here, this is the normal cervical epithelium which can be affected by HPV virus once we start the sexual activity. So our aim is to vaccinate the girls before they start their sexual debut, so that they will not get this infection of HPV into their genital system. So by chance, those who could not receive the vaccine, because of the vaccine is there only for the last 15 years, so the next step would be doing the screening. So in screening, we can test using the different modalities, what I have said, and this virus slowly enters into the cervical cells, and again, if you have a good immunity, more than 90% would clear the infection. But those who are immunocompromised, the infection can persist, and that can produce a lot of changes in the cells, and finally it becomes a pre-invasive to invasive cancer. But this doesn't happen overnight. It takes almost 10 to 15 years. So you have a long window period of screening your woman for these cancers. So that's why we said the screening tests are to be offered for women between 30 and 65 years of age. So these are the vaccine recommendations which are there in our FOXY website. So this is the FOXY recommendations. We do have our Indian vaccine that is called Sarvavac, which is made by Serum Institute of India. We have imported vaccines, Gardasil 4 and Gardasil 9. One is quadrivalent, one is nanovalent. So we can use all these vaccines according to the age schedules that are recommended by the government of India, and we can vaccinate all our girls. Then we do vaccinate, we can even vaccinate the boys with our Indian vaccine. You may be asking why boys. Boys are also at risk of getting penile cancers, and both men and women are at risk of getting anal cancers, oropharyngeal cancers. In addition, women can be protected not only with the cervical cancer, but vulval and vaginal cancers. By one vaccine can protect 6 cancers. So timely vaccination is one of the preventive aspects, proactive preventive aspects. And of course, the screening test, you are all aware, know about the screening test. Visual inspection with acetic acid and leucoalzidine is what is recommended by our government of India. And cytologic screening tests are very popular. The pap smears, either conventional or liquid-based cytology. Most of the government institutions do have the facilities to do it. But the latest WHO recommendation is to move towards HPV screening. And of course, we don't have a government recommendation. We don't have India-made HPV tests. We have imported tests which are validated. But in good centers where the facilities are there, resources are there, at least in private setups, many people are doing primary HPV DNA testing, which is considered to be the gold standard because of its high sensitivity and high negative predictive value. And these are the screening recommendations according to the age. In a good resource settings, if you want to screen, you can start from 21. But in India, the recommendation is from 30 years of age. And of course, immunocompromised, you can start from the age of 25. So before 30, never do a HPV screening test because majority of women will be HPV positive and unnecessarily you will be over investigating them. So you need to do HPV testing only after the age of 30 for general population. Only in HIV and immunocompromised you can do from the age of 25. So the screening interval varies depending upon the test you use. Then that is all a little about cervical cancer. There's a lot to talk to. So I just stop with this vaccination and screening. Coming to the endometrial cancer, the lifetime risk of endometrial cancer is 3.1% and the overall 5-year survival rate is 81%. In India, it accounts for 4.3 per 100,000 women. The incidence is increasing because of the lifestyle changes and metabolic syndrome of hypertension, diabetes, obesity. So these are some of the risk factors for endometrial cancer. Some of the factors are modifiable, some of them are not modifiable. The modifiable risk factors are, as much as possible, we are not using estrogen alone treatments. We are always giving a combined estrogen progesterone preparations. And sometimes women on tamoxifen for breast cancer, anti-estrogen, are slightly at an increased risk. Then nulliparity, obesity, metabolic syndrome, as I said earlier, sedentary lifestyle, consumption of red meat, alcohol, and fatty foods. These are all the modifiable risk factors which are in our hands, but we can't modify increasing age, early menarche, late menopause, PCOS, estrogen-producing tumors, type 1 diabetes, Lynch syndrome, Coverdin syndrome. These things, the genetic things we cannot modify, but at least we can do some kind of a screening in women who are at a higher risk for getting endometrial cancer. So this slide which shows us about healthy lifestyle, we all know we have been discussing about healthy lifestyle from morning to reduce many other conditions, not only cancer. So the screening for endometrial cancer is not recommended for general population, but those who are at high risk, like what I have said, shown in the picture, those women need to have screening. They can have a transvaginal ultrasound annually, and if needed, if they have any suspicion, then they can go for endometrial sampling. But as such, any woman perimenopausal, postmenopausal comes with any menstrual irregularities, and for that matter, postmenopausal women coming even with one episode of bleeding, it's better to investigate. So we do usually transvaginal scan to find out the endometrial thickness, and if the cutoff is more than what is recommended, we all do endometrial biopsies or hysteroscopy or whatever it is. And that actually helps us to diagnose endometrial cancer in very early stage, and the surgery is the gold standard for early stage endometrial cancer. And that actually gives a very long, good survival, good response, and almost cure for many women. Then coming to ovarian cancer, I know it is the most dreaded cancer, and we cannot really diagnose an ovarian cancer in very, very early stages. And we don't have any screening tests for ovarian cancer for general population. So patient characteristics wise, advanced age, personal history of breast cancer, these are all high risk factors. So if there is a strong family history of ovarian cancers, or those women who had ovarian cancers or breast cancers are genetic testing positive, that is BRCA1 and BRCA2 mutations positive. So in those situations, the entire family is at a risk of getting these cancers. And similar to endometrial cancer, nulliparity, early menarche, late menopause, where there is more and more chance of continuous ovulation, which actually acts as a stimulus for ovarian cancer. So PCO, infertility, endometriosis, ovulation induction, these are all the risk factors. So what we need to do is, for general population, as I said, we don't have any recommendations, but all high risk women have to be on a follow-up at regular intervals. They need to have a physical examination, regular ultrasound scan, and CA125 estimations. Of course, there are lots of ultrasound indices are there, Roma, so many things are there. But whenever you see any cyst, it has to be characterized according to IOTA guidelines to see whether it is benign, malignant, or suspicious. Suppose somebody is a genetic testing positive, then we need to think of some prophylactic measures for them. So these are some of the recent advances. There are lots of advancements are happening for ovarian cancer screening. So a lot of biochemical tests, blood tests to identify the biochemical markers, circulating tumor biomarkers. These are all not into clinical practice. These are all in the process of evaluation in clinical trials. So just one word about genetic testing, because so many things are coming with one sample of blood, one can detect so many genes which are at risk of cancer. So like that we are seeing lots of ads and other things. But for any test, for any genetic test, one should have a good pre-test counseling. First of all, we need to understand what is the importance of this genetic testing. Suppose if the test comes positive, what are we going to do? So that is very, very important. And especially, as I said, if there is a strong family history of a genetic abnormality like BRCA1, BRCA2, or microsatellite instability, Lynch syndrome, and other things, then only those families need to be screened. And then, of course, the process of sample collection, laboratory analysis, results, and post-test counseling, all these things have to be done by a proper person, the genetic counselor, and those who are experienced and those who have enough knowledge about these tests. It's not just a simple testing, similar to what we do for our anomaly scans and other things, NT scans, so many things we are doing. So we all need to learn about these aspects very clearly before you advise anybody for genetic testing. Then just one slide, this is the last slide. So if you have done all these preventive strategies, if you find somebody as a high risk group, you can do frequent screenings, especially those who have got a strong family history of breast cancers or a gene positive breast cancers. You can advise them mammograms and colonoscopies for these colon cancers and other things. Risk reducing medications. So OCPs also can protect against ovarian cancer and endometrial cancers. Then of course anti-estrogens also have a little role to play for women who have got a higher risk of breast cancers. Then we all do a lot of salpingectomies when we do hysterectomies because to reduce the incidence of ovarian cancer, especially the serous cancer, and we know that the fallopian tube is the precursor for ovarian cancer. So especially in high-risk women, just doing a salpingectomy doesn't serve the purpose. You need to do risk-reducing salpingo-oophorectomy. And of course, there are situations some women do undergo prophylactic mastectomy. So lifestyle changes, no excuse for that. So the best approach is a personalized plan developed with a healthcare provider, tailored to the specific genetic mutations, cancer risk, and evidence for such interventions. So thank you very much for the opportunity given to me. I hope I have conveyed some message about the preventive aspects with regards to gynecological malignancies. Thank you.
Thank you, ma'am, for accepting our invitation at a very short notice. And it was a very elaborate talk on preventive oncology. Thank you, ma'am. I request you to chair on the dais, ma'am. And I request Dr. Fani Rajkumar, sir, to speak on precision surgery for women's cancer.
Good afternoon, everyone. Thanks for Astra Ramesh Group of Hospitals giving me this opportunity. One thing I noticed when Dr. Vasanta started announcing about this gynec oncology topic, the people started going, the youngsters especially. Slowly they started trickling out. I started seeing there. Then I came here. I was more concentrating how many of them are going out. True, actually, true. What happened is over the 8 years, what I observed is so many gynec PGs, they used to come and work with us. Whatever, usually that casual discussion, when we sit with the coffee or after the surgery and all, what are your future plans? Most of them, out of 90%, they are getting into this IVF, all this stuff. So exciting. Only one girl turned out to be a gynec-oncologist of my 8 years. And that she also discontinued in 3 months, I believe. Okay. But please get into this because all are getting saturated. you have to turn upon us, towards us, because over the time you will be pushed to take the gynec oncology. You will be forced to do it, and you will become more passionate towards gynec oncology. Definitely it is an exciting thing. So that way, thank you. The next thing is so happening. I will just go through, just not like statics or anything. This madam nicely elaborated about the preventive things, everything, but one unfortunate patient had escaped all these things, and she got into the theater. Just what we will do is we'll just go into the theater, not the theater. So I also have to go to Kantara chapter 1 after this. This theater, we are going into the theater. We know that presumably that is going to be CA ovary and looking like an early stage CA ovary. How are you going to handle this patient? Yeah. So the mode of surgery. See, usually the patient will be draped, painted, everything and all. One assistant will be there. What is your plan? Na? Then most of the times, we'll put a port, sir, first. Yeah, put a port. Always put a port. See whether what you can see inside and what are all the diseases there, all that. It's a good thing. When you cannot put a port, sometimes there will be huge cyst will be there. It is occupying the whole abdomen where you cannot place a port. Rather, you will puncture the cyst. So try to avoid putting a port. There you have no choice. You have to open and take the cyst off, and then the rest of the job will be done, right? So, but provided you take here, there is a small cyst is there, the rest of the tummy is fine. Just put a port. Once you put a port, so many things will happen. There is two set of people will be there. One a young, enthusiastic, minimal access surgeon, and another one is a very well experienced laparoscopic surgeon. Two will be there. The younger one will be so excited to finish it off in laparoscopy. The senior most one will think, at any cost I should be able to finish this in laparoscopy. Two different contrast poles. But just why? Because yes, you can do all these things. Minimal invasive surgery is accepted. There is a decent evidence in ovarian cancer, but not robust evidence. When you are well trained, expertise, you feel it is a small cyst, but it is nothing to do with the size of this cyst. You are seeing one cyst here, right? That cyst is a small cyst, but that cyst is effaced with the uterus. You may not able to separate, and you may puncture that fellow. So very important message here is, you are not playing with the cyst. You are playing with the life. That thing you just keep in your mind when you are handling these complexes. Yes, this can be done minimally invasively. Yes, doctor. Because I am telling this, some of the gynec PGs will be there, they're going for the exam. Can we do it in a minimal invasive? Yes, there is evidence that you feel it is a small cyst that can be taken, that cannot be ruptured, that can be disconnected, properly placed in the bag. I will puncture the cyst in the bag and I will retrieve it. Then it is okay. I am very expertise. I have a backup of expertise hands with me at the theater. Then do all these things. But otherwise, just remember, you are not playing with the cyst, you are playing with the life. So don't hesitate to convert. So my take-home message is, don't hesitate to convert. Never hesitate to convert. Conversion is not like humiliation. Just conversion, the priority is the safety of the patient. Just convert it, open it. If you see the cyst is like this. Yeah. So the next step, you put a port. You saw a small cyst there that is sitting in the pelvis, and you just try to move that cyst. That fellow is adherent to the uterus. You feel it like it is to be opened. I have to take it out. You decided about it. But before coming out, taking out the port, what you just go through the tummy once, do the diagnostic laparoscopy, see all the areas. The only hitch here with the laparoscopy is some hidden areas will be there where you cannot see also, but try to see all the areas where any disease is there. So that is one very important thing. And once you see everything, then if there is a fluid inside the tummy, take the fluid off. If there is no fluid in the tummy, try to do a peritoneal cytology, a peritoneal lavage. How will you do the peritoneal lavage? Because why I am telling, anyway I am opening the tummy, no, that time I will do. Because when you have a laparoscopy access, sometimes the earlier you saw the cyst that is sitting in the pelvis. For that stage, when you want to do a staging laparotomy for CA ovary, you need not cross the umbilicus here. You can manage the incision below the umbilicus up to maximum to the umbilicus. But you cannot do a proper peritoneal lavage. What is a peritoneal lavage? I just not putting some water in the pelvis and aspirating. Put water in all the quadrants, especially in the right subdiaphragm, left subdiaphragm, and the pelvis everywhere. Take a proper fluid, minimum of 200 ml. Minimum of 200 ml. Whenever you read a cytology report, you read the right report, they will say there is no cells. There is nothing. Like that, sometimes you will see this report. Even otherwise also, when you take a peritoneal fluid, the yield of peritoneal fluid cytology, even otherwise if you take 1 liter also, it will be yield will be very, very, very less. So, at least you target of 200 ml, all the depend areas, you just lavage everything, okay, and come out. Then you open for the cyst, okay? Right. Yeah. So, one interesting point is, when you do a peritoneal lavage, most of the times we use normal saline, right? And after it is an interesting study that is being denoted by the MD Anderson, using a normal saline is just allowing the peritoneum to get access to the tumor cells. Interesting point. Many a times when you ask for the wash, usually you will ask your sister, ward sister, that floor sister, you will ask for NS, normal NS. But this NS is a culprit, that is what they are assuming. They started using the ringer lactate solution for the peritoneal lavage. Okay, it's an interesting point. Just keep it in mind, but still we use NS only. So, but once you do this cytology, always very, very important, interpretation of this cytology report is a very important thing. And take more fluid and ask your pathologist, discuss with your pathologist. Many a times when you give wash, lot of exfoliated mesothelial cells will from the peritoneum will be there. They should be able to differentiate it from the mesothelial cells from the malignant cells. So, okay, so you open, you just put a port, there was no disease, you just did a peritoneal lavage, you are planning to open, right? Sometimes. This is another scenario. There is a cyst is there, you are seeing some disease here and there, and you are seeing some diseases there in that paracolic gutter, and you are seeing some diseases here, and now what is to be done? Very important thing is to take a biopsy of this rather than removing the cyst unless it is causing trouble to her. So take a biopsy of this cyst. Why I am putting this slide very importantly is when you do a biopsy, you see this kind of, very often we do see this kind of picture. What you have to do is when you are taking a biopsy of this tissue, I don't know whether it is a malignancy or not. Sometimes my Nirian sir also is sitting here, he is very much fond of tuberculosis, and he will ask for so many tests. It's very relevant, definitely. And when you are taking this biopsy, don't scratch here and there, don't try to take small tissue. Try to take a good chunk of peritoneum, dissect it off and take a good chunk of peritoneum. That will help in so many ways. One, for the diagnosis, if it is a confirmed, if at all ideal situation is, if you have a frozen section facility, utilize the frozen section facility, send it for the frozen, ask a pathologist whether it is a cancer or tuberculosis. She will be able to tell. If she says cancer, ask a second question, whether my specimen is adequate or not. Because I cannot go and do a second biopsy in this patient. Whatever biopsy, and we brought so much extensive counseling, she landed into theatre. Second time I cannot take her to do theatre. So ask these two questions. That is done. If she says cancer, if the specimen is adequate, then it is fine. If she says it is a cancer, specimen is inadequate for the further molecular testing, please take extra biopsies. And at the same time discuss, if she says, I am seeing only granulomatous inflammation or something, take some more tissue, you will ask for the culture, you will ask for gene expert, everything and all. Because very important, these are all the practical things when you are doing this procedure, because repeatedly they cannot afford for this procedure. So finish everything at one go and come. The take-home message here is, when you see this kind of peritoneal abnormality, try to take as much tissue as you can. Okay, that is very important. Next. And thorough examination of the abdomen, whether it's a laparoscopy or not. So there you are seeing a small nodule which is seen in the momentum, and there is one thorough exploration of the abdomen. Every nook and corner of the abdomen to be examined. So many a times laparoscopy has the limitation of seeing all the hidden areas in the tummy. When you open, you just go through everywhere, find out the disease, see, document the disease everywhere, wherever it is. So that is very, very, very important. And you have done all these things. You are just left with the cyst. There is no disease. Now you have to go ahead with the cyst. Don't break, and just remove the cyst in toto without rupture. Sometimes these things do happen, but don't get upset. Once you see the spillage, suddenly you will lost your rhythm. You thought, I ruptured it, I ruptured it, I ruptured it. Okay, you ruptured it. Okay, fine. Finish the surgery and come out first. So that is not, that can happen with best in best hands also. Best in best hand also, because this location, that is a huge cyst. It is adherent everywhere. You are trying to manipulate it. It got ruptured. But very important thing is this part to be counseled to the patient prior hand, very important. That is very important. Now ChatGPT has come. All the AI tools can come. They will just put what is staging laparotomy. If they put 1, 2, 3, it will give. So on that it will highlight spillage, intraoperative spillage, because the technical difficulty of the surgeon. That also that fellow will mention. So just be aware of this thing, but don't lose your rhythm doing the surgery. Finish it up, take the cyst off, remaining the disease, everything come out, and take off the cyst and send it for ideal situation. If you have a frozen section facility, send this cyst for the frozen section. For what? For doctor? The thing is, one, most of the times when you are handling a postmenopausal woman, but it may not be a big deal. So many a times we'll take a consent for the total hysterectomy, all that staging and all. But it comes to the reproductive women, especially premenopausal and reproductive young adolescents and all. And 2, 3 things we'll come to know: what type of tumor it is, and whether it is a serous or non-serous. And if it is a mucinous tumor, the earlier tumor I showed, like that kind of the picture, if it is there, you will tailor your surgery, what extent of surgery you are planning to do at that time. And the most important thing is the fertility preservation. Leave about the fertility, and knocking off both ovaries and make them attain the menopause at early age is also a very, 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 very distressing thing, right? And there you just keep that thing. If you have the backup of this, just take off this thing and think about that part also, that you will tailor your surgery accordingly based upon the report. But that is a foolproof, sir? No, it is not a foolproof. It has its limitations. What are the limitations? The limitations: bigger the size, sampling will be difficult at that short span of time, and some borderline tumors, it is a difficult sampling error. The far most important thing is expertise of your pathologist. Seeing the frozen section, whether invasion is there or invasion is not there. Something is there, is not there. They'll be comfortable. I will not be comfortable in the theater. They will get away with the report, but I will not get away with that, because the next day patient will be standing in front of me. I had done a big, 1 hour counseling, and then again I have started the same counseling for her. So it is very difficult, but as in most of the times, if you have a frozen section facility, utilize it. Yeah. The next, yes, you have done. Frozen section came as a positive, and you are going ahead with the THBSO. So, yeah. Can we spare the remaining things? Like now the only discussion will come is, can we spare? Most of the times we will found the incidental cyst, you have knocked off, and you have a strong suspicion whether we can I retain the remaining things or not. The fertility sparing surgery is accepted in this patient or not. So that is why the frozen section helps you a lot in this scenario, especially. If that is not that, you have a red flag signs like it is a complex cyst, the markers are elevated, you have a strong suspicion, but still the age factor, you can consider younger age, germ cell tumors will be there, around perimenopausal, stromal cell tumors, borderline tumors will be there, postmenopausal carcinomas will be there. But just that keep in this thing. Yes, fertility sparing surgery is recommended in ovarian cancers, provided there is a certain limitations for all these things, and like borderline tumors, non-epithelial tumors, low grade serous tumors. And do unilateral salpingo-oophorectomy, but don't play with the opposite ovary. Just see if it is fine, come out. Yeah. And the next is, I'll just finish in just 1 minute. Next is infracolic cholecystectomy and random peritoneal biopsies. You have to take not omental biopsy, minimum is infracolic cholecystectomy, will yield more of this thing. Infracolic cholecystectomy will upstage the disease, right? Yeah, there is a recent study which I found, rather taking a random peritoneal biopsy, you take a Douglas pouch peritoneum where the cyst is lying, that gives a more information, it is a more prognostic significant. Some the patients who had the Douglas pouch peritonectomy, they are living longer, and they found some 10 to 20% of the disease in the Douglas pouch. These are all the things. But routinely what we do is many a times, practical aspect, what I'm trying to tell is, when the cyst is lying in the pelvis, there will be a lot of unhealthy peritoneum in the pelvis. You don't know whether that is because of the compression effect of the cyst or the disease. So we don't, because inflammatory adhesions also to be considered as a peritoneal disease. In that scenario, routinely what we do is we'll take off all this Douglas pouch peritoneum, all this you see, as this specimen is showing the total pelvic peritonectomy with the uterus. Interesting thing. And the last lymph node evaluation. Whether lymph node, this is the only area they will ask for this help, Dr. UB, some of the gynecologists, when they call us with the help, and just whether to do nodal dissection or not to do, or if at all you want to do, how much extent you want to do, that is the only thing will be there. So the most distressing part of whole staging laparotomy is lymph node dissection, because it is not the technical difficulty or anything else. It's just like you can wear off all the vessels, take off the tissue, everything. It is just a matter of 1 hour, 2 hours job. But the thing is, the distressing part is the post-operative period. Patients will have, lot of them will have a lymphoria. Managing them with the lymphoria and the chylous ascites is the most distressing complications. Many a times you will be like, you cannot send the patient for the chemotherapy, and patient will be roaming with the drain, and water is pouring out, and all this, so much stuff will be there. I used to be in so much distress. Then we started thinking about how to avoid all these things. When we just so much, then we started reading more of the lymphatic drainage. The interesting lymphatic drainage will be there. Lymphatic drainage will be there. The 3 parts will be there. One through the IP ligament, one is the ovarian ligament, and another is the round ligament. The most of it is with the IP ligament and uterovarian ligament. So that means pelvic and para-aortic. So taking off these things, started seeing the literature. The standard is, when you are doing early stage, especially serous carcinomas, epithelial serous carcinomas, standard template lymphadenectomy, and where you can avoid lymphadenectomy is low-grade serous carcinomas and mucinous carcinomas, where you can avoid lymphadenectomy if there is no visible abnormal lymph nodes and non-epithelial tumors. It is just bird's eye view I am telling. So non-epithelial tumors and borderline tumors, where you can avoid a lymphadenectomy. But when you see a serous carcinoma, how much I have to remove? That is the only distinction, because I am very scared of the lymphocyte, right? Then we started exploring the evidence. Then the evidence started coming. If the cyst is on the right side, remove the right side pelvic nodes, leave the left side lymph nodes. There is an evidence started propping up, like the lymphatic drainage, there is a crossover between the uterus is very less. If the cyst is on the right side, right pelvic nodes will be there. The chance of having lymph node metastasis in the opposite pelvis is less than 1%. So try to avoid doing a opposite side pelvic lymphadenectomy, finish the ipsilateral pelvic lymphadenectomy and para-aortic nodes. In between, we started enjoying the sentinel node biopsy, doing with laparoscopically, robotically, giving the ICG. This is very robust evidence for the endometrium as well as the cervix, but is not well in ovarian cancers. I am personally so many lymphocytes I have managed. I am eagerly waiting for something to come up to get away from this distressing complication of lymphoria after pelvic and parietic lymphadenectomy. If you do a thorough parietic lymphadenectomy, if you have not done a thorough parietic lymphadenectomy, you will not see the real lymphoria. If you have done a proper pelvic and parietic lymphadenectomy, the drains will be like full and you will have the music for at least a month. But this sentinel node biopsy is not validated in ovarian CA as of now. And appendicectomy to be done or not. Appendicectomy, usually when you see a mucinous tumors, if that is on the right side, you try to take off the appendix. This is a gray zone area. Some of them they will do. If the normal appendix don't do, all this stuff will be there, but better you do it because removing the appendix is not going to cause major morbidity to the patient. So that's wind up the local early disease. Just I will walk through the advanced disease, it will be less thing. And when there is an advanced disease, your goal is to remove everything. So your aim is there should not be any disease in the tummy. And extra abdominal disease also, if you feel like supraclavicular node and pleural effusion and inguinal nodes, those to be addressed, those to be treated with a curative intent. Just I'll go through. So remove all the disease, whatever you see in the tummy, your target is CC0, there should not be any disease inside at the end of your surgery. To achieve that, naked eye examination is not sufficient. So started using the fluorescence guided surgery, using ICG. When I attended for the Stryker conference in Delhi, they started showing me the cytologs using for the peritonectomies and all. That will map out the disease, which is not seen. And you are seeing that that thing, that peritoneum looks like a normal, but it harbors some occult metastasis. That will be picked up by the cytologs, and you will remove that all that peritoneum. So technology is helping us to get away. This, after doing this surgery, this is all this recent stuff, giving intraperitoneal chemotherapy like finishing the surgery, give intraperitoneal chemo, put a chemoport and give chemotherapy, adjuvant chemotherapy in the post-operative period. The next one is giving a HIPEC. There's two stuff. These are recent things, that adjuvant IP chemotherapy, way back we started 2014, but it is very difficult to deliver the adjuvant. Chemoport will be there, post-operative, there will be big laparotomy. You have to give the drug. There will be a chemoport here, drug will be delivered through, but the evidence also says 40% discontinuation is there because of the morbidity, because the fluid will collect, unanimous distribution won't be there, lot of pain will be there, pus formation, port site infections, all these things. We discontinued giving adjuvant IP chemotherapy, putting a port, but then we started doing 2015, started doing this HIPEC. Initially there were so hiccups and evidence was not so strong. We were going up and down with morbidity, mortality and all. After 200 cases, then it is more or like a stabilized, when to do, how to do. The technique has been completely standardized, and now we are so comfortable. There is a robust evidence to do HIPEC in ovarian cancers, especially after doing a interval cytoreductive surgery. Thank you.
Hello, hello. Hello.
I request all the birth and beyond time to come onto the stage.
Good afternoon, everyone. Nurture 2025, a step forward in women's health. Sorry, my hyperglycemia is kicking in. Dear ladies and ladies, sorry again, dear ladies and gentlemen, pun intended. We now proceed with the formal inauguration and felicitation ceremony after this engaging and enriching session. At the outset, I invite Dr. Mamta Raipati ma'am, Deputy Managing Director, Aster Ramesh Hospitals, to join on the stage to lead the ceremony and welcome the dynamic and esteemed delegates.
I request Dr. Venkat sir, present President of Guntur Society, to come on to the dais. I request Dr. Chandrasekhar sir to come on to the dais. Dr. Uma Shankar sir, Dr. Rajakumari madam, Dr. Hanumant Rao sir, Dr. Aruna madam, Dr. Prabha Devi madam, Dr. Tripura Sundari madam, Dr. Jhansi Vani madam, Dr. Sujata madam, Dr. Urmila madam, Dr. Meera Raghavan ma'am, Dr. Leela madam, please come on to the dais. And I request Dr. N. Murli Krishna sir, our APMC observer, to come on to the dais. Please ma'am, please ma'am, please ma'am.
A big round of applause to all the stalwarts of obstetricians and gynecology. Shubham Kurutvam Kalyanam Arogyam Dhanasampadam Shatrubuddhi Vinashaya Deepam Jyoti Namostute. Let us invoke the blessings of God Almighty by lighting the lamp. I request all the dignitaries on the dais to do the honors. Music, please. I request the Birth and Beyond team to be there. Dr. Saupna, Dr. Deepthi, Dr. Sneha. Let us bow to the light of the lamp, a symbol of auspiciousness, health, and prosperity.
Ma'am, Dr. Janardani, ma'am, please come on to the stage. Please, ma'am. Please.
As we light the lamp, we illuminate the path of knowledge, compassion, and care, nurture, birth, and beyond. That symbolizes our CME. Thank you all the dignitaries on the dais. May I now request Dr. Mamta ma'am to share the journey of the CME from the birth and beyond team.
Good afternoon, everyone. I'll make it very, very short because I'm sure we're already getting late. So first of all, thank you all so much for being here, right from the speakers and chairpersons, consultants, and all the students who have come here, believing that we will be able to give some knowledge to all of them. As per today's norm, there is a continuous learning process where we all have learning, unlearning, and relearning. That's what is making us survive. And I think AI, again, is going to bring a lot of change, but I'm sure it's going to be positive in favor of the doctors who want to do better things for the world. And today's trial is just the exchange of knowledge between all of us. And I'm sure as doctors, we are poised to do greater things for patients, for community, and for the world at large. Thank you all so much for being here, sir. Thank you very much.
Thank you, ma'am. May I now request Dr. Venkat, sir, to address the gathering. We're honored to have you, sir, amidst us on this occasion. Your vision, experience has inspired so many. Over to you, sir.
Good morning to everybody. So on behalf of the Guntur Obstetrics and Gynecology Society, I congratulate the Aster Ramesh Hospital for conducting a very extravaganza of CME today, nurture and beyond. So it has included from IVF, conception to surgeries, and also the latest methods, robotic surgeries, and everything you have covered. So I congratulate the management, Dr. Raipati Mamata Garu, and especially Dr. Anuradha and his team for fantastic conduction of this CME. A big applause to all the team members. So congratulations for all the speakers. Thank you very much for giving this opportunity.
Thank you, sir. May I now request Dr. Chandrasekhar, sir, to share his thoughts.
I congratulate the Aster Group of Ramesh team because they have well organized this team and highly knowledgeable. I am a consultant and I retired 4 years back, even though I learned recent points regarding management of some recent trends. Thank you with the Ramesh Group. Thank you so much.
Thank you, sir. May I now request Dr. N. Murali, sir, APMC Observer, to share his thoughts of the gathering.
Good morning, and I welcome you all for this Nurture 2025 conducted by Aster Ramesh on behalf of Andhra Pradesh Medical Council. And I congratulate all the speakers as well as thanks to Aster Ramesh Group Hospitals for conducting regular CMEs. More than that, almost learned people, many senior-most obstetricians are there. Please give some space to the youngsters, and I request the President, B. Venkateswara Garu, to give opportunity to the youngsters so that they will not be disappointed during their learning period. Learning is unlimited and it is worth. We encourage our youngsters if we give some space to work as well as to impart our knowledge to them and to prove during their career. I hope all the dignitaries on the dais as well as off the dais may show some empathy and sympathy towards patient as well as to juniors. With this, this allopathy will cherish like anything. Once again, I congratulate Managing Director Mamata Garu as well as all the speakers, and thank you one and all.
Thank you, sir. A mark of respect and gratitude towards senior invited delegates, we, the family of Aster Ramesh Hospitals, take this opportunity to felicitate the stalwarts in the field of obstetrics and gynecology. To do the honors, I request the team of Aster Ramesh OBG department and senior management to be around. It gives me immense pleasure now to request Dr. Venkat sir to kindly step forward to receive the felicitation. To do the honors, I request Dr. Anuradha ma'am and Dr. Mamta Raipati ma'am. Music, please. Thank you, everyone. May I now request Dr. Chandrasekhar sir to please step forward to receive the honors. To do the honors, I request Dr. Deepa and Dr. Mamta ma'am. Thank you. May I now request Dr. Uma Sekhar sir. May I now request Dr. Aruna to please step forward to receive the felicitation. Okay. May I now request Dr. Prabhadevi ma'am to do the honors? To please step forward to receive the felicitation. And I request Dr. Vasanta to do the honors. Thank you. It gives me pleasure to invite Dr. Aruna ma'am to kindly step forward to receive the felicitation. May I request Dr. Banu Teja to do the honors? Thank you. May I now request Dr. Tripura Sundari ma'am to kindly step forward to receive the felicitation. May I request Dr. Anita and Dr. Anuradha ma'am to do the honors. Thank you, ma'am. May I now request Dr. Jansi Rani ma'am to please step forward to receive the felicitation. I request Dr. Swapna to do the honors along with Dr. Anuradha ma'am. Thank you. May I now request Dr. N. Murli sir to kindly step forward to receive the honors. May I request Dr. Karthik Chowdhury, Cluster Head Business Development, Aster Ramesh Hospital, to do the honors. Thank you. May I now request Dr. Urimila ma'am to kindly step forward to receive the honors. To do the honors, I request Dr. Lavanya and Dr. Mamta ma'am. Thank you. May I now request Dr. Sujata ma'am to step forward to receive the felicitation. I request Dr. Apurva and Dr. Anuradha ma'am to do the honors. May I now call Dr. Janardani ma'am to step forward to receive the honors. To do the honors, I request Dr. Tanveer, Dr. Mahesh. Thank you. May I now request Dr. Leela ma'am to kindly step forward to receive the felicitation. To do the honors, I request Dr. Vasanta and Dr. Jyoti Prakash. Thank you. It gives me pleasure to invite Dr. Meera Raghav ma'am to kindly step forward to receive the felicitation. I request Dr. Deepa and Dr. Vasanta and Mamta ma'am to do the honors. As we say, no occasion is complete without capturing it in memories. Now I request the team of Birth and Beyond, along with the stalwarts of obstetrician and gynecologist, to join for a photograph, group photograph. I will also request senior management, Dr. Karthik Chaudhary, Dr. Nitin Nalluri, to be on the stage. Ms. Anusha. I request Ms. Pooja also to join on the stage. I request all the gynecologists who are here to please join us on the stage for this group photograph. It'll be wonderful to have you all in this frame. Please join, ma'am, please. Thank you, one and all. Now we'll proceed with the next session. Before we proceed to the next session, we have a short lunch break. It's 2 o'clock, 2:20, the session resumes. 2:20 we have panel discussion. Various case studies will be discussed. So I request everyone to please join back in the hall by 2:20.
Good afternoon, everyone. Moving forward to the next session, diverse perspectives, panel discussion. Now I invite our panel members on the dais. Now I invite Dr. Jyoti Prakash Reddy, sir. Sir is a consultant pediatric cardiology at Rashtra Ramesh Hospital. He is highly trained in pediatric interventions and performs many procedures like ASD and VSD closures.
I like to call Dr. Shilpa Chaudhary, ma'am. Ma'am is head of Department of Critical Care Unit of Aster Ramesh Hospitals, Guntur.
And I invite Dr. Chaitanya, sir. Sir is a consultant gastroenterology at Aster Ramesh Hospitals. As he is interested in research and advancement of medicines, he has done many studies and published articles in reputed journals.
I would like to call Dr. Ramarao, sir, senior cardiologist at Ramesh Hospitals, Guntur.
And I invite Dr. Niren, sir, consultant infectious disease specialist at Aster Ramesh Hospitals, Guntur.
I like to call Dr. Naveen Krishna, sir. He is one senior cardiologist at Ramesh Hospitals, Guntur.
Duplicate with that.
And I would like to invite Dr. Vasanta, consultant gynecologist, as a speaker on Heart of Mother, Understanding the Peripartum and Navigating Pulmonary TB in Pregnancy. Welcome you, ma'am.
వచ్చింది ఇక్కడ డూప్లికేట్
Good afternoon, everyone. Now I'm going to present a case. A woman, Mrs. A, 25 years, primary gravida at around 36 weeks gestation. She was referred from an outside hospital in view of eclampsia for further intensive care management. On arrival to our emergency, she was irritable and confused with a GCS of E4, V5, M6. There's pallor and pedal edema up to the level of the knees. Her vitals are like pulse is around 110, BP 160, 100, SpO2 around 82 to 85. And on auscultation, bilateral clefts were present and cardiac heart sounds were heard. On per-abdomen examination, uterus is term size, cephalic, relaxed, and fetal heart sounds are heard. On per-vaginal examination, cervix is os closed, uneffaced, vertex at -3 station, and there's no evidence of bleeding or leaking PV. She had no history of previous high blood pressure recordings before in this pregnancy. The insult started as she complained of pain abdomen and uneasiness, and she threw a fit at home with frothy discharge and vomiting. Later she was taken to a nearby hospital. Her status at that hospital was she was conscious, confused, pulse around 100, BP 200 by 110 mm of Hg, SpO2 around 92% and GRBS 140. She was stabilized there by giving injection labetalol, magnesium sulfate loading dose and lorazepam. She further had 2 episodes of seizures at that hospital, and then she was referred to a higher center. History in the present pregnancy, it is almost normal. She had regular ANCs from the 3rd trimester of pregnancy. All the scans were normal, and she had no history of GDM or raised blood pressures according to her previous records. On arrival to our hospital, she was evaluated, investigations were sent, and she was started on ventilatory support. Magnesium loading dose was started, labetalol infusion and Levipil was started. And in view of eclampsia, she was taken up for emergency LSCS and delivered a live baby girl at around 2.8 kgs. And further which she recovered, and she was extubated the next day. Later she recovered well, and on the 4th POD she was discharged and shifted to the KMC ward for the baby side. And on 8th POD, while she was still in the hospital, she developed shortness of breath, and her vitals were like pulses around 120, BP 130, 80, and on respiratory examination, bilateral cramps were present. Keeping in mind the DDs as pulmonary edema, peripartum cardiomyopathy, pulmonary embolism and sepsis, we investigated her, and the investigations were like this. The hemoglobin is 9.3, total counts are 8,000, sugars are normal, creatinine is normal, CRP is 40 and NT-proBNP is 8,500. On ECG, it's sinus tachycardia, and on chest X-ray, it showed signs of pulmonary edema. Her echo on admission showed adequate LV function, and there's only mild TR and mild PAH. Apart from that, it looked normal. But on 8th POD, it showed marked global hypokinesia of left ventricle with moderate LV systolic dysfunction, and left ventricular ejection fraction is around 35%. She had mild MR and TR, and we came to the diagnosis of postpartum cardiomyopathy, as the left ventricular ejection fraction is markedly decreased and there is marked global hypokinesia. And we managed her with, we shifted her to the MICU care, and we managed her with oxygen support and NIV and injection diator, aldolactone, metoprolol, and Sidmus was added during the time of discharge. Now, I would like Dr. Ramarao sir, our senior cardiologist, to give us insight onto this case.
Good afternoon, everybody. So, for the next 5 minutes, I will briefly discuss about the peripartum cardiomyopathy. So, actually, it is the diagnostics of exclusion. So, what are the criteria, all these things in the next 5 minutes we will discuss. So, as per the ESC guidelines, peripartum cardiomyopathy is an idiopathic cardiomyopathy with the following characteristics. So, development of heart failure towards the end of the pregnancy or within 5 months following the delivery, and absence of any another identifiable cause for the heart failure, and LVEF should be less than 45% with or without LV dilatation. So this is the criteria it was given by ESC.
Coming to the epidemiology, so it is highly variable. It is mainly dependent on geographic area and races. So very highest in Nigerian population, which is 1:100. Whereas if you come for Japan, it is 1:20,000. In US, it is approximately 1:10,000. Coming to the risk factors, so it can be divided into two types, probable and proposed risk factors. The probable risk factors like twin pregnancy, high parity, then high gravidity, then extremes of reproductive age more than 30, and prolonged tocolytics with beta agonists, then preeclampsia. So genetics, so some of the genes which are involved in DCM, they are also known to cause the PPCM and obesity, and proposed risk factors like smoking, hypertension, malnutrition, cocaine abuse, African ancestry, and low socioeconomic status. So if you ask pathology, actually it is not clearly known and it is always multifactorial. So there are different theories are proposed. So one is the myocardial inflammation and oxidative stress, and second thing is the prolactin fragmentation hypothesis. So during delivery or after delivery, prolactin is secreted, which when it is fragmented to 16K DA prolactin segment, so that is known to cause decrease the VEGF and myocardial inflammation and decreasing the LVEF. And another thing is angiogenic imbalance and other factors like genetic and autoimmune factors and hemodynamic stress of pregnancy also has been proposed. Coming to the symptoms and signs, see whatever the, so the patients will have routine heart failure symptoms. The problem is even pregnancy people also will have similar kind of heart failure features like routine dyspnea, cough, like pedal edema and all these things. So you need to have thorough evaluation and examination and routine echocardiography. Otherwise, you will miss the diagnosis very easily. That's why actually the incidence of peripartum cardiomyopathy is much higher than it is calculated, because the symptoms are both are similar. So most of the times mild cases we will miss it. So the routine symptoms are dyspnea, cough, orthopnea, PND, pedal edema and hemoptysis. And physical signs, if you come across, then they will have tachycardia, raised JVP. So whenever there is a LV dilatation, a displaced apical impulse, third order sound, and a murmur of MR will be there whenever there is a severe MR. And so whenever they have severe LV dysfunction, they can have thrombus formation even left as well as right side of the heart, and it can lead to embolism. So coming to the diagnosis, actually peripartum cardiomyopathy is a diagnosis of exclusion. So whenever these symptoms are there, so we need to check the routine, what are the other things it can mimic like this. So what is the most common thing is pregnancy, delivery and all these things. First thing we have to consider is the anemia. So second thing is the sepsis. Then third is the pulmonary embolism. Then fourth one is the, if there is what we call previous history of any valvular heart disease or any dilated cardiomyopathy is there, that also you need to check. So if all of them are not there, then only we have to come for the PPCM. So if you come for the ECG, so ECG you won't find much findings except like sinus tachycardia with LVH strain pattern with mild prolonged PR interval. Other than that, you won't find much factors. And 2D echo is most sensitive and specific. So here the LVEF is decreased, and the pattern of LV dysfunction also here is peculiar. Here the LV dysfunction is more of generalized rather than regional, and they will have similar picture to DCM. So all chambers of the heart are enlarged, but it is not always. So maybe 30 to 40% only you will have dilatation of the all chambers. So remaining people, they will have only dilatation of the left ventricle and left atrium and the dilatation of the left ventricle. Some of the patients, they can have severe MR and TR, and the EF is less than 45. And whenever they have arrhythmias, severe LV dysfunction, they can have the LV thrombus. So all these things we need to see. So this is the picture of, so one is the left side is the normal one and right side is the, so PPCM heart picture where we can see the dilatation of the all 4 chambers. Coming to the biomarkers, NT-proBNP it is not specific, but it is highly sensitive. And CRP is useful to diagnose sepsis as well as for the prognostication of the disease. And 16K DA prolactin, it is not done routinely. If it is available, that is also sensitive. So once you made the diagnosis, so mostly it is clinical and echocardiographic finding only the PPCM diagnosis. Once we have made the diagnosis of PPCM means next what? So management is, so we have to divide the management into 3 categories. Like one is first what to do for decreasing the symptoms. Next is the slowing the progression of the LV dysfunction. Third thing is the improving the survival. So it is a multidisciplinary approach by the obstetrician, cardiologist as well as the anesthesiologist. So once you diagnose the patient of PPCM, first we have to make diagnosis whether the patient is in cardiopulmonary distress or not. So how to make cardiopulmonary distress is there or not. So we have to see whether any tachycardia, tachypnea, hypoxia, hypotension, decreased urine output, then altered mental status, and elevated lactates. So if any of the findings are there, then we have to conclude that the patient is in cardiopulmonary distress. Because if the patient is in stable and if the patient is in distress, the treatment will be various. If the patient is in distress, so first we need to optimize the patient. Suppose the patient is in pulmonary edema means we have to give the diuretics. If the patient is dehydrated means we have to give the volume and keep the BP around 110 and optimize the oxygenation. So if necessary, we have to go for the BiPAP or ventilator, rarely VA ECMO also. Then if patient is in hypotension, then we have to consider for the inotropes. And here the most important thing is, apart from routine inotropes, if BP is permissible, then we have to consider the levosimentamine. That is the drug of inotropes. And whenever the patient is in hemodynamic compromise, so we have to go for the urgent delivery, preferably cesarean section. And whenever the LVEF is very low and the patient is in severe PPCM, then we have to consider the bromocriptine. However, the role of bromocriptine is controversial. And if the patient requires, we have to go for the ventilator support. And once the patient recovers, then we have to wean off the treatment. If doesn't recover, then we have to go for the transplantation. In US, I think 4th reason for the cardiac transplantation is the postpartum cardiomyopathy. So if the patient is if stable, then we have to divide the patient into 2 categories, again antepartum and postpartum. If the patient is in antepartum, then we have to give the because here the drugs will be differ. So in antepartum, we have to give the drugs like hydrogen, nitrates, beta blockers, and if necessary, we have to go for the diuretics. So I will come across in the next slide regarding the delivery and all these things. If the patient is in postpartum, then we can give ACE, ARB, beta blockers, spironolactones, diuretics, and if necessary, we can give the ivabradine also. And again, I am telling that bromocriptine role is little controversial. It is depending on the individual and institutional based. And if the patient is having severe LV dysfunction with arrhythmias, then we have to consider for the wearable cardiac defibrillators. And in case of once you diagnose the PPCM, better to continue the treatment for 1 year or at least for the 2 years. So, as I told, the routine management of drugs in PPCM. So coming to the advanced therapies, so inotropes. So if BP is permissible, we have to give the levosimentamine rather than routine catecholamines, because levosimentamine is the calcium sensitizer, so it will cause the myocardial increase in contractility and peripheral vasodilation, so that workload on the heart is decreased. That's why it is the drug of choice. So if required, then we have to, whenever the patient is in hemodynamic compromise, so IABP is a very good role, has a very good role. I think in our institute we have seen a number of cases. Whenever they present with a severe peripartum cardiomyopathy, so IABP has done very well work, and if you put for IABP for 5 days and ventilator, most of the patients, so after 5 days we have removed the IABP and they have came out. And if necessary, we have to go for the ECMO and LVAD. So if the patient is having severe LV dysfunction despite of treatment, so if the patient is fit for ICD, so we have to consider for ICD or CRTD, and cardiac transplantation is the last option. So despite of treatment, if the patient is having severe symptoms and if she developing complications, maybe at the end of the 6 months, we may consider for the cardiac transplantation. Regarding delivery, if the fetus and mother doesn't have any distress, then we can go for normal vaginal delivery. So if there is any distress, then we have to go for the cesarean section. So type of anesthesia, epidural is the preferred one. And early delivery is not required if the baby and mother is no hemodynamic compromise. And breastfeeding, again, this is one of the controversial topic. So previously everybody used to avoid breastfeeding once you diagnose the PPCM, but nowadays some of the studies are saying that we can give, but whenever the patient is having severe PPCM, severe LV dysfunction with the complications, better to avoid the breastfeeding. And so in mild cases, we may consider, so European ESC guidelines are saying 2B indications for regarding the avoidance of breastfeeding. So it is individualized. We have to take the group approach and team-based approach only, consider the breastfeeding decision. Coming to the prognosis, so once you diagnose the PPCM, 50% of the patients will have complete recovery, 25% they will have persistent symptoms, and 25% of the patients, they will develop new complications like progressive heart failure, arrhythmias, and thromboembolism. And overall mortality rate is 3 to 9%. And if the patient is having persistent cardiomyopathy with symptoms, despite of treatment, even at the end of the 6 months, the mortality rate will be 85% in 5 years. So follow-up of the patients. So once you diagnose the PPCM, then once in 6 months, we need to do the echo. And so once you diagnose the PPCM, so generally heart failure drugs are routinely given. So the 4 pillars are SGLT inhibitors, ACE/ARB, mineraloreceptor antagonists, and 4th one is the beta blockers. So generally SGLT inhibitors, generally will be avoided in postpartum cardiomyopathy, either pre or post delivery. So other drugs like once you initiate it, so MRIs after 6 months, if the LV functions improves to normal, first drug we need to withdraw is MRA till the end of the 1 year. After 1 year, so if still LV function is normal, then we can withdraw the ACE/ARB or ARNI. So beta blockers are generally continued till the end of the 2 years. And if the patient is again going for another one more pregnancy, then it is better to continue the beta blockers rather than stopping. So now the thing is, what for the next subsequent pregnancy, what to do? So here it is divided into 2 groups. If the LV completely recovers normal, one group, and another group is they are having persistent LV dysfunction. So if the LV is completely recovered, means here also recurrence chance will be 20% is there. But here the good thing is mortality and morbidity is slightly lower, and they will have likely to have a normal delivery. However, we have to counsel the patient definitely regarding the relapse and all these things. So if the patient is having persistent LV dysfunction, means here the risk is very high. 50% of them have again PPCM during the pregnancy, and here the thing is they have very high mortality and morbidity, and they will land up with most of the patients premature delivery and abortions are more common. So here counseling of the patient is very, very important. Thank you.
Going to the next case, she is 29 years old, Gravida 2 Para 1 Live 1 at 33 weeks gestation, was brought to the emergency with complaints of blood vomiting around 500 to 600 ml followed by loss of consciousness. The patient is not conscious and coherent, and when she came to the emergency, her GCS was E2V2M4. There's severe pallor, pulse around 120, BP 80-60 and SpO2 75. On auscultation, bilateral crepes were present. For abdomen, uterus is around 28 to 30 weeks, a cephalic relaxed and the fetal heart rate is present. Emergency intubation was done and inotropic support was initiated. She had her regular ANCs from 4th month of pregnancy. TIFA scan was normal, but broad scan showed a 2 weeks lag discrepancy and with mild oligohydramnios. In this pregnancy, like she had chronic cough, history of one episode of mild hemoptysis followed by this before the admission, for which she consulted at a local hospital. A chest x-ray was done and it showed left lung consolidation with cavitations. She was started on oral antibiotics and was advised to review SOS. And past history, she's married for 5 years. She was diagnosed to have pulmonary TB before her first pregnancy. She was treated for it. 1 year later, she conceived and delivered through LSCS for obstetric indications. Antenatal and postnatal periods were uneventful. At 6 months postpartum, she was diagnosed to have recurrent PTB and she was started on ATT again, for which the patient was not compliant. She did not complete the treatment. 2 years later, she conceived with present pregnancy and had checkups from 4th month of amenorrhea. No other comorbidities. On CECT chest, it was shown as a left bronchial artery aneurysm, collapse of left lung with bronchiectasis and peribronchial ground glass opacities in the right lung. Right lower lobe peribronchovascular consolidation was seen. You can see the left lung fully is like consolidated and with cavitations. And on for the left, this is the left bronchial aneurysm which was found, and later we proceeded with, we diagnosed her to have left bronchial artery aneurysm secondary to consolidations, query pulmonary TB, and so what next? Mother first or baby first? Should we deliver the baby or go ahead treating the mother? In this case, we went for a bronchial artery embolization, and then the confusion is like whether to deliver the baby or whether to wait and continue with the pregnancy. But here we did an ultrasound. It showed like 30 weeks gestation. She's around 33 weeks, but the baby is only 30 weeks gestation with severe oligohydramnios of AFI 1 to 2. So we proceeded for an emergency LSCS in view of previous LSCS, and baby had severe distress and baby was managed in the NICU. Later, bronchoscopy was done on first POD and the fluid was sent for gene expert, which showed to be low positive. She was started again on ATT and eventually extubated on the 4th day and discharged on 8th POD. Now I would like Dr. Niren sir, our infectious disease expert, to share his insights on pulmonary TB in pregnancy.
Thank you, ma'am. So, tuberculosis is still the world's most infectious disease killer, and India contributes to almost more than 1/3 of the world TB cases. So, everyone, I think, should know about how tuberculosis and how it's present in pregnancy. So, when you talk about pregnancy and tuberculosis, we categorize the risk. We are talking about two people here. So, the maternal and the fetal risks. So in pregnancy, most of the time, it is TB reactivation rather than a new infection. So that is mostly because of the apparent immunosuppressed state of the pregnant female. And you will have other associated conditions as well, which could be due to pregnancy for which TB has superadded, like anemia, and it could also lead to preterm labor. So TB, even in maternal deaths, it causes up to 6 to 15% of the maternal deaths globally. When you come to the fetus, we also talked about preterm death. Similarly, you will also have the low birth weight babies born with people with mothers with tuberculosis. There is also the risk of postnatal transmission, especially when TB is not adequately treated in the mothers. So the main hurdles when you talk about diagnosing TB in case of pregnancy is, most of the times the symptoms coincide with that of pregnancy. Sluggishness, early morning vomitings, feeling weak. So these symptoms may sometimes be disregarded as normal pregnancy symptoms. And even the cough, sometimes this patient had chronic cough. Most of the times pregnant females try to suppress this cough or vomiting sensation, and they usually don't become overt symptoms. And they are, as I said, most of the times disregarded and not considered. And we also already know, pregnancy is an immunocompromised state. That is why the reactivation of whole TB is more common in case of pregnant females. Again, the low clinical suspicion being the highest burden country for tuberculosis and having a high reproductive rate as well in India for now, we should keep a clinical suspicion of tuberculosis, especially when someone is not, there is not enough weight gain, or there is having slow chronic cough in pregnant females. When you come to the test to diagnose tuberculosis, so the common things when you talk about diagnosing TB in adults, we say one is symptoms, imaging, MAN2, and microbiological tests. So when you so imaging, there is always the problem of safety with imaging in case of pregnant females. And when you talk about MAN2 and these, it has been not an ideal test to diagnose TB even in adults, but people still tend to use when you don't have other. And in females, all these patients, because of reactivation and low immune status, MAN2 tends to be negative even if they're having overt disseminated tuberculosis. So that is not at all a good test, even more so in pregnant females. And when you talk about all the main important test that still remains is the microbiological confirmation with AFB or gene expert or CBNAT test. So these remains the main test of how you identify TB in case of pregnancy. So our way ahead to diagnose early tuberculosis in pregnant females should be having a good clinical suspicion, identify who are the high-risk patients. Though we say TB is still a disease for low socioeconomic status, the affluent people are not too far away. There are many people who have been affected with TB as well. So always a strong clinical suspicion helps. Don't shy away from getting an imaging when required with having a good abdominal shield. Try for microbiological confirmation, not use other tests. And also important, if not done till now, a retrostatus is also important when you diagnose TB in a case of pregnant females. So just to overline some of the principles of TB in pregnancy, in untreated TB patients, definitely the risk is much higher when compared to the mild risks due to anti-tubercular drugs in pregnancy. So when you talk about the drugs that are used, most of the times it is drug-sensitive TB. The usual 4-drug regimen consisting of rifampicin, isoniazid, pyrazinamide, and ethambutol. These are the ideal drugs. No known teratogenic effects have been known. Only thing is, should remember to give pyridoxine as well when you are treating with isoniazid. So, and when you should continue the ATT, it should be continued postpartum as well. And even in lactating mothers, the concentrations of these drugs are very low and not harmful to the baby at all. But in turn, when you talk about eliminating and decreasing the TB burden, we also should assess the child for congenital and neonatal TB and also give INH prophylaxis wherever it is necessary. The risk of where the risk of transmission from the mother to baby is more. MDR TB is another count. The burden is still high. So whenever it is there, that is a whole different thing that we need to talk about, starting from the antenatal care. So my take-home points when it comes to TB with pregnancy are, there will be only mild symptoms most of the times, but the patient status actually, they will have more of disseminated disease or a miliary TB. Molecular testing is more important. Imaging may help, but don't use any MON2 or tuberculin skin test to diagnose TB in pregnant females. Hemoptysis, as we have seen in this case, is a potential, definitely a fatal TB complication that has been successfully treated, thankful to the whole multidisciplinary team in this case. So thank you, that's it.
Thank you so much, sir. Now I invite Dr. Bhanuteja and ma'am, consultant Aster Ramesh Hospital, Guntur, for next topic, liver health in focus, understanding ALP and liver cirrhosis.
Good afternoon, everyone. Now I'm going to discuss 3 interesting cases of liver complications in pregnancy that were presented to us. Case 1. A 22-year-old primigravida with 38 weeks of gestational age referred to us in view of deranged liver function test and abnormal coagulation profile. Her chief complaints were loose stools and vomiting since 15 days and abdominal pain on and off since 15 days. Fever with LOS, discoloration of eyes since 3 days. On examination, patient looked pale, icteric, and anasarca was present. Her vitals were BP 110/70, pulse rate 100 per minute, saturations 96 on room A. On per abdomen examination, uterus appears term gestation, relaxed cephalic presentation with fetal heart rate 90 beats per minute on handheld Doppler. Growth scan findings were 2 to 3 weeks growth disparity with oligohydramnios with fetal heart rate 100 beats per minute and mild maternal ascites was present. On pervaginal examination, cervix 30% effaced, os admitting one finger, pelvis was gynecoid, and foul smelling vaginal discharge was present. Her laboratory parameters were like this: HB 10.4, WBC count 42,900, serum bilirubin 10.1, elevated liver enzymes, INR was 4.8, serum creatinine was 1.6, GRBS was 42 milligram per deciliter, LDH was 393. CTG was pathological with absent variability and late decelerations. Grave maternal and fetal prognosis was counseled and taken up for emergency lower segment cesarean section. In her intraoperative findings were mild to moderate ascitic fluid was noted, thick grade 3 meconium strain liquor was noted, abgas was 0 to 4 and birth weight was 2.34 kg. Uterine cavity, umbilical cord and placenta were stained greenish yellow in color. Intraoperatively, we transfused 1 unit PRBC and 4 FFPs. Post-procedure, uterus was retracted well with minimal blood loss and no evidence of PPH. Intraperitoneal drain was kept and she was shifted to MICU for further management. She was started on broad spectrum antibiotics. Post-operatively, she had recurrent episodes of hypoglycemia, which were managed with dextrose infusion. And she had decreased urine output with metabolic acidosis. On post-operative day 2, she became tachypneic and developed tachycardia and also developed abdominal distension. Ultrasound abdomen was done and it showed paralytic ileus and polyserositis. Viral etiology of deranged liver function was ruled out. In view of fever spikes, drain fluid was sent for culture and sensitivity and antibiotics were changed based on culture report. Albumin infusions were given and adequate serum potassium levels maintained and later abdominal distension improved gradually. Intraperitoneal drain was in situ for 10 days with around 1 to 1.5 liter serous fluid for 7 days, which progressively reduced to minimal. Liver parameters were started to improve from post-operative day 7. Serial blood investigations were followed and she progressively improved. Patient shifted to room in stable condition and discharged 5 days later. Case 2. A 29-year-old gravida 4, para 2, live 1, death 1, abortion 1 with 2 previous cesarean sections with 8 months of amenorrhea She was referred to us in view of BP recordings of 160 by 90, deranged liver function test and low platelet count. On general examination, patient was icteric, pallor was present and had pedal edema. Parabdominal findings were uterus was 32 weeks size, relaxed cephalic presentation and fetal heart rate was 110 on hand Doppler. Growth scan findings were 1 to 2 weeks growth disparity with severe oligohydramnios with signs of uteroplacental insufficiency, and her vitals were BP 140 by 90, heart rate 112 per minute, saturation is 96 on room air. Her lab parameters were bilirubin was 6.4, elevated liver enzymes, platelet count was 1.1 lakh, INR was 2.92, serum creatinine was 1.9, uric acid was 8, and FBG shows mild metabolic acidosis. She was taken up for emergency lower segment cesarean section in view of severe oligo. Delivered a live female baby of weight 1.7 kg with Apgar 689. Intraoperatively, we transfused 4 FFPs. Intraperitoneal drain was kept and patient shifted to MICU for further management. Postoperatively, she had recurrent episodes of hypoglycemia. On day 5 of LSES, she developed sudden hypotension and increased bleeding from drain site. CT abdomen was done and it revealed a hypodense hematoma of size 18 to 4 into 8 centimeters in the rectus sheath. She was taken up for emergency laparotomy for rectus sheath hematoma and hemoperitoneum evacuation under general anesthesia. There was almost 500 ml of rectus sheath hematoma and 2 liters of hemoperitoneum. In this picture, you can see the blood collected in the section container, and almost 13 mops were used during this procedure. She was started on inotropic support in view of hypotension, and ventilatory support was continued. During her hospital stay, we transfused 8 units of FFP, 4 units of cryoprecipitate, 1 unit of SDP, 4 units of RDP and 3 units of PRBCs based on TEG report. Serial ABG, LFT coagulation profile and CBCs were monitored. Postoperatively, she had fever spikes and blood was sent for culture and sensitivity. Antibiotics were escalated accordingly and was started on antifungal medications. On day 11, fever spikes were continued. CT abdomen revealed intraperitoneal collection or hematoma in the pelvis. We planned for a conservative management after discussing with intervention radiologist and infectious disease specialist. On follow-up scans, hematoma was resolved. Patient had no further fever spikes after that. With team-based care and close monitoring, the patient is stable and her bowel and bladder functions were normal. LFT coagulation profile, platelet count and CRP were found to be improving and was discharged on 18th day in a stable condition. The differential diagnosis for about 2 cases were acute fatty liver of pregnancy, HELP syndrome, intrahepatic cholestasis of pregnancy, preeclampsia associated hepatic impairment. Based on Swansea criteria, the diagnosis of about 2 cases appears to lean more towards AFLP. 6 or more features should be present to diagnose AFLP based on Swansea criteria. Discussion. AFLP may be challenging to differentiate from HELP syndrome, severe preeclampsia, and may coexist at the same time. Liver failure signs like coagulopathy, disseminated intravascular coagulation, hypoglycemia are more typical of AFLP, which also shows higher transaminase and bilirubin levels. Management of AFLP and HELP syndrome preeclampsia involves early recognition, supportive care, and timely delivery to prevent maternal and fetal complications. Dr. Shilpa, our head of critical care department, will discuss differential diagnosis and management in further. Over to you, ma'am.
Good afternoon, everyone. So now Dr. Banu has presented 2 cases. So we have seen the differential diagnosis also. So it's mainly liver diseases complicating the pregnancy. So now next few minutes we are going to discuss about the how to diagnose and management of the liver diseases complicating the pregnancy. So if you come to the liver diseases in pregnancy, it can be classified diseases per se related to the pregnancy and liver diseases which are unrelated to the pregnancy also. When come to our both cases, so these two cases we are ruled out those diseases unrelated to the pregnancy. So in this session we are going to discuss only about the pregnancy related liver disease, because our two cases, our main DDs are acute fatty liver of pregnancy, HELP syndrome, severe preeclampsia and cholestasis of pregnancy. So how we can differentiate these conditions? Because AFLP, HELP or severe preeclampsia, if you see the clinical features, most of the clinical features are overlapping. Even some of the laboratory findings are also overlapping between especially AFLP, HELP and preeclampsia. So it is very, very difficult to diagnose a single entity based on the clinical features alone. And depending upon the investigations, we can have a diagnosis, most probable diagnosis only we can say. If you want a definitive diagnosis, most of the times we will require a liver biopsy, which we won't do routinely. So if you see the clinical features, like generalized features like pain abdomen, generalized malaise, vomiting, nausea will be there in almost all the conditions. The only clinical features which are specific to obstetric cholestasis is the pruritus, which we may not see in the other three conditions. If the patient is having pruritus, especially it will start in the palms and soles, then it will become generalized. So those symptoms are very specific to cholestasis. The other symptoms are similar in all the three conditions like AFLP, HELP and severe preeclampsia. So other signs and symptoms and laboratory symptoms which are specific to AFLP are ascites is usually present in AFLP, hypoglycemias and the level of rise of aminotransferases which are there in AFLP are around 5 to 10 times the normal. So these are specific for AFLP. If you come to the HELP, so they can have hypertension and proteinuria in 85% of the patients, and the ascites is very rare but still can be there in some of the patients, like less than 10% of the people only they can have ascites. The level of LDH rise is very high in HELP when compared to the other conditions. So usually in HELP there will be the rise of LDH will be more than 600 units per liter. And even NGM elevation also it will be up to 100 times it can be there in HELP when compared to AFLP. If you see preeclampsia, so coming to the symptoms in preeclampsia, they'll have a more neurological symptoms when compared to the other conditions. The symptoms like headache, blurring of vision, even seizures can be there in a severe preeclampsia when compared to the other conditions. So here the prominent features will be they can have mild AKI, but the other symptoms like hypoglycemias, hemolysis will be very rare. But thrombocytopenia can be there in preeclampsia. So if you see all the features, there is overlapping of features in all the conditions, and it is very, very difficult to diagnose a single entity based on this. So that is why we have a certain criteria to diagnose these conditions to have a high index of suspicion for the diagnosis. Like Dr. Banu said, there is a Swansea criteria for diagnosing the AFLP, and we can have a Tennessee criteria or Mississippi criteria for diagnosing the HELP. So Swansea criteria, there are around 14 parameters are there, including clinical, laboratory, and even histological diagnosis also. So amongst 14, if 6 or more are present means there is high probability of diagnosing the AFLP. We can diagnose early AFLP based on the Swansea criteria because early diagnosis and treatment is key for reducing the morbidity and mortality in a mother and child. So the sensitivity, if you see the sensitivity and specificity of the Swansea criteria, it is 100% sensitive, but the specificity of Swansea criteria is very less. It is around only 60 to 70%. And if you see the predictive value, the positive predictive value of criteria is only about 80%. But if you see the negative predictive value, it's 100%. So if you have the criteria, it is 6 or more, we can say it is probably AFLP. But if the criteria is not meeting, we can definitely say AFLP is very, very less likely because the negative predictive value is 100%, but the positive predictive value is only 85%. So if you see that 14 features whichever there in the Swansea criteria, almost 5-6 factors are common for HELP also. That is why most of the times the AFLP, HELP or severe preeclampsia, it is very, very difficult to differentiate, and most of the times they can coexist also. So that is why based on this we can have a probable diagnosis, and then The treatment is almost similar for all the three conditions. So what are all the complications we can expect in a liver diseases complicating pregnancy? Because the management for AFLP, HELP or severe preeclampsia is almost the similar, and the ultimate or final treatment will be the delivery of the baby. So what are all the complications we can expect, like hypoglycemias, acute renal failure, sepsis, they can have encephalopathy, coagulopathy, disseminated intravascular coagulation, bleeding, even ultimately they can land up with the fulminant hepatic failure, especially AFLP patients. So management, it needs a multidisciplinary approach including critical care physicians, obstetricians, hepatologists or medical gastroenterologists and neonatologists. So it comes under maternal stabilization and delivery. So maternal stabilization and delivery will go hand in hand, because while stabilizing the patient, we have to plan for the delivery, because the ultimate treatment is the delivery of the baby. Once you deliver the baby, most of the symptoms will come down. Until you do the delivery, it is very, very difficult to control the symptoms, and stabilization of the mother is also very, very difficult. So the stabilization and delivery will go hand in hand. While stabilizing the patient itself, we have to plan for the delivery, because these patients usually will have a coagulopathy, low platelet count, and they will be in dehydration. So we have to do stabilization at the same time the plan for the delivery. So initial management includes airway, breathing, circulation. So we have to maintain the patient's airway, breathing, and along with circulation also. These patients mostly they will have a intravascular dehydration. So we have to have a proper hemodynamic monitoring for fluid management. So we have to maintain the euvolemia. While giving the fluids, we have to be very careful, because these patients, they'll have a very less oncotic pressure. So if you overload them, they are more prone to have a pulmonary edema. So we have to give fluid management very carefully, and we have to try to maintain the euvolemia by doing a proper hemodynamic monitoring. At the same time, these people, they'll have thrombocytopenia and coagulopathy. So while planning for the delivery, we have to correct the coagulation abnormalities and thrombocytopenia. So it includes prompt delivery of the fetus. Coming to the mode of delivery, which mode of delivery to choose, whether vaginal delivery or cesarean section. So it depends on the maternal and fetal factors. Depending on that, we can plan either vaginal delivery or cesarean section. But whichever is the mode of delivery, we have to keep our coagulation factors ready, because our target is we have to maintain platelets at least 50,000, and we have to maintain INR of around 1.5 before going for the delivery by giving the platelets and FFPs. Otherwise, the chances of bleeding will be very, very high. Even the risk of bleeding will be very high in cesarean section when compared to the normal delivery, but most of the times it may not be possible to go ahead with the vaginal delivery, because in these conditions the mothers are in a very unstable condition, so vaginal delivery may not be possible, though the bleeding risk is very less. So almost in literature also 65% of the times when the patients are in liver diseases complicating pregnancy, they'll end up with cesarean section only. The bleeding risk is very, very high. We have to alert the blood bank before going for delivery. We have to order, and we have to keep ready all the blood and blood products like PRBCs, platelets, FFPs. Sometimes they may need cryo also. So all those things we have to keep ready before going for the delivery. And if the patient is hypotension, even with the after fluid resuscitation, the blood pressures are not coming up, we may need to start vasopressors to maintain the mean arterial blood pressure. And if necessary, if the patients are going into pulmonary edema, or if the patients are having any respiratory distress, they might require mechanical ventilation, and we have to continue even after the delivery also, depending on the condition of the patient. And these patients, especially AFLP patients, they are more prone for hypoglycemias. Even sometimes in severe preeclampsia and HELP also, they can have hypoglycemia. So we have to monitor the patient regularly for development of hypoglycemia. If necessary, we have to give continuous dextrose infusions for correcting the hypoglycemic episodes. And these patients will have coagulopathy. As I said, they might require multiple transfusions. So usually our practice is to do a point of care testing like thromboelastogram, which will gives us the actual functionality of the coagulation system. Based on that, we can plan our blood products. So it says us that which products to give, where exactly is the defect in the coagulation system, it will tell us.
so that the amount of utility of the blood products will be reduced by using the thromboelastogram. So in our hospital, routinely we will practice using the thromboelastogram for giving the blood and blood products, especially if the patient is having bleeding manifestations or if the patients are having coagulopathies. Then comes the renal replacement therapy. These patients usually they'll have acute renal injury and they'll go into metabolic acidosis also. If you see both the cases, they have a metabolic acidosis. Even if there is acute renal failure and with the involvement of liver, they can have a lactic acidosis and severe metabolic acidosis also. So if the patients are having these severe metabolic acidosis or if they are going into oliguria or anuria, they might require continuous renal replacement therapies. So in these patients, when do we refer these patients to a tertiary care center? Because these patients are likely to go into fulminant hepatic failure. So before that itself, we have to shift the patient to a tertiary care unit, because early treatment and early interventions, we can prevent the morbidity and mortality. So if the patients are having coagulopathy is not recovering, they are going into severe coagulopathy, it's always better to shift the patient to the tertiary care centers. And coming to the advanced therapies, when the patients are going into acute liver failure, because most of the AFLP patients, they can go into acute liver failure. Even HELP patients also, they can have hepatic hematomas, subcapsular hematomas, they can have hepatic infarction, and ultimately sometimes they can have hepatic rupture, or sometimes they can go into acute liver failure. If the patients are having acute liver failure, the adjunctive therapies include, we can give N-acetyl cysteine infusions. Next comes the plasmapheresis. If the patients are having coagulopathy or if they are developing encephalopathy, coagulopathy is refractory to our correction of coagulation factors, we can offer them the plasma therapy or plasma exchange. So in most of the studies, it has shown that plasma therapy, if you are offering plasma therapy to a patients, those who are going into acute liver failure, we can prevent them going into a liver transplant. But we have to offer the liver transplant to the patient. Meanwhile, while preparing the patient for the liver transplant, we can do a plasmapheresis and other liver supportive therapies like MARS also we can try in patients, those who are going into liver failure. Ultimately, if they are not recovering, they are having severe signs of liver failure, we have to offer them the option of liver transplant. So the take-home messages, we have to maintain the high index of suspicion of AFLP, because the early management is very, very important. So early recognition and prompt delivery are crucial for improving the outcomes. So the management is primarily the supportive only, focusing on organ support and treating the complications. So a multidisciplinary approach is needed, and we have to be very vigilant in identifying the complications and treating, such as sepsis, disseminated intravascular coagulation, and cerebral edema. We have to always consider AFLP in the differential diagnosis of severe liver dysfunction in pregnancy, even though if the initial presentation suggests more common conditions like preeclampsia or HELP. Because AFLP remains a challenging condition in critical care, but the outcomes have improved significantly with advances in the supportive care and increased awareness. If you see, the mortality rate in AFLP in previous days is around 85%, but now with the advances in the treatment, the mortality has come down to almost as low as 4% to 25%. So the mortality in AFLP nowadays, it is only 4 to 25%, previously which is around 85%. So that is why early diagnosis and early treatment is very, very important in AFLP patients. Thank you.
Thank you, ma'am. One more case. A 22-year-old primary gravida with 13 weeks 5 days gestational age referred to us in view of low platelet count. She had history of childhood jaundice at 2 to 3 times at age of 6 years, history of jaundice and ascites in 2012. Patient was evaluated at AIG Hyderabad as decompensated cirrhosis. Her past medical record includes liver biopsy was done in 2012. It showed evolving cirrhosis with cholestasis. Autoimmune markers were sent. LChem was positive at AIG Hyderabad. Later repeated in Kamakoti Hospital, Chennai were found to be negative. She was in close follow-up with medical gastroenterologist, and she was started on azathioprine 50 mg per day since 2012. No history of ascites, jaundice, edema since 2012. Upper GI endoscopy was done in 2022, which was normal. The patient was uncertain about whether to continue the pregnancy, so we provided counseling encouraging her to continue with the pregnancy. She had her regular antenatal checkups with us, was in close follow-up with medical gastroenterologist in view of low platelet count and cirrhosis. Ultrasound abdomen was done in third trimester. It showed splenomegaly with features of portal hypertension and few splenorenal collaterals were seen. Patient and her attendants were counseled regarding risk with normal vaginal delivery, including varicose rupture and massive hemorrhage. A decision was made to plan an elective lower segment cesarean section under spinal anesthesia. A multidisciplinary team meeting was conducted, and patient and her attendants were counseled regarding risk associated with the lower segment cesarean section, includes risk of intrapartum and postpartum hemorrhage, need of blood and blood products transfusion, risk of venous thromboembolism, risk of varicose rupture, splenic portal collaterals bleeding, risk of shock, disseminated intravascular coagulation, acute kidney injury, liver failure, and need of MICU admission, and grave morbidity was explained. Elective lower segment cesarean section was performed safely under spinal anesthesia. Postoperatively, she was monitored in ICU for 12 hours, and later we shifted her to room. Key learning points are pregnancy with cirrhosis and thrombocytopenia is a high-risk condition. It requires multidisciplinary management. Early planning for delivery reduces morbidity. MICU preparedness is essential. Patient and family counseling is very important. Next, our medical gastroenterologist, Dr. Chaitanya, will continue the discussion.
Good afternoon, everyone. I am very happy to participate in this academic feast. So today I am discussing about pregnancy and CLD, what we have to be monitoring in CLD patients. So nowadays there is 7-fold increase in cirrhosis among women of childbearing age in the recent times. So there is current incidence of 2.5 patients in 1,000 women of childbearing age, they are having cirrhosis. Most of the cases are now due to NAFLD or MASLD. Previously it was due to viral hepatitis. Nowadays the prevalence is increasing for NAFLD. So pregnancy is possible in cirrhotic patients, but it is high risk and it required multidisciplinary care. So coming to pathophysiology, why pregnancy complicates CLD. So usually there is increase in plasma volume about 45% in the pregnancy. So it will increase the portal pressure and it will increase the risk of variceal bleeding. There are hormonal changes like estrogen and progesterone which may worsen the portal hypertension, and there is some altered drug metabolism which can cause various medication to not act properly, and there is hyperdynamic circulation. There is increased cardiac output and decreased systemic vascular resistance which will promote further worsening of the CLD, and there is compression of inferior vena cava in pregnancy which will increase the risk of ascites. So how will we risk stratify cases of CLD? So we have to check the MELD score. If MELD score is very low, less than 6, it is low risk pregnancy. There will be minimal complications, so standard monitoring is advised. Whenever the MELD score is 7 to 9, it is moderate risk. There we have to do monitor for some complications, and there should be some enhanced surveillance. If the MELD score is more than 10, it is very high risk for pregnancy, and it is high sensitive with 83% of sensitivity. So we have to consider termination of pregnancy whenever the MELD score is more than 10. Coming to the complications, what complications we should expect in pregnancy. So there are liver-related complications and there are obstetric complications. For a patient with CLD, there is high chance that they will worsen during the pregnancy. Most common complication will be variceal hemorrhage. It will be noted in 30% of the patients. It is the most common finding. Followed by ascites. It can develop newly or it may worsen during the pregnancy. And many patients can develop hepatic encephalopathy, hepatorenal syndrome, and SBP during pregnancy. So all these things may worsen during the pregnancy time. Coming to obstetric complications, what we should expect preterm labor. It will be seen in 30 to 50% of the patients, and there is high risk of postpartum hemorrhage. So it will be seen around 20% of the patient. incidence of cesarean sections, ICU admissions, and blood transfusions will be higher, and there is high chance of maternal mortality with more in the decompensated liver disease patient. Coming to fetal and neonatal outcomes, we should expect preterm deliveries in around 30 to 60% of the patients compared to 4% in the controls. And there is high risk of low birth weights and intrauterine growth rate restrictions and intrauterine deaths and neonatal asphyxia. Coming to neonatal complications, patients can have NICU admissions, neonates, and there will be risk of respiratory distress syndrome and low Apgar scores and stillbirth rates up to 6%. So these things we should be kept in mind. So next I am going to discuss about the specific conditions, how to treat during the pregnancy. Coming to the viral hepatitis, it is common in India, so we have to check for hepatitis B. There should be universal screening recommendation for all pregnancies. So triple panel testing is advised. Not only HbS-Ag, we have to check for anti-HbS and total anti-HbC. So once we check these levels, if the patient is positive for hepatitis B and they have no viral load and not on any treatment prior, and we have to recheck the viral load at 7th month of pregnancy, that is 28 weeks. If the viral load is more than 2 lakhs, then we have to start treatment with tenofovir, which is safer during the pregnancy. Coming to neonates, after delivery, the baby should be given hepatitis B immunoglobulin within 12 hours of delivery. So the usual dose is around 26 international units per kg. So average we will give 100 international units of IV hepatitis B immunoglobulin within 12 hours of delivery. Coming to hepatitis C, there is no antiviral therapy approved during the pregnancy. So we have to avoid internal fetal monitoring and prolonged membrane rupture in these patients. We have to screen infants if more than 18 months for anti-HCV or HCV RNA after 1 month. So whenever hepatitis C positive pregnancy, we have diagnosed during pregnancy. So we have to check the infant after 18 months for anti-HCV or HCV RNA after 1 month. There is no prophylactic screening test for the babies before that. So coming to autoimmune liver disease, how will we manage? So autoimmune hepatitis, we have to continue the treatment what the patient is getting already. Usually prednisolone and azathioprine are safer during the pregnancy. There is high risk of flares during pregnancy, around 20%, and there will be risk postpartum also, it is around 20 to 50%. So if patient is having well-controlled disease for more than 1 year, pre-conception, then the patient have better outcomes. If the patient is not under well-controlled disease, then we will advise them to postpone the pregnancy. And we have to avoid mycophenolate during pregnancy because it has some teratogenic effects. Coming to Wilson's disease, it is not that much common, but we should continue copper chelation therapy during pregnancy. Usually dipencilamine and zinc are safer during pregnancy. There is 26% risk of spontaneous abortion overall. And if the patient was under proper management, the fetal losses are very fewer. So there are 3% birth defect rate, which was acceptable versus when we don't treat the patient with medication. Coming to portal hypertension and varicose management. So every pregnant patient before pregnancy should be screened for varices in CLE patients. Endoscopy in second trimester or preconception is advisable. We have to do varicose prophylaxis either by endoscopic therapy or beta blockers. In high risk patients, we can combine both therapies, both endoscopic varicose ligation along with beta blocker. Coming to during pregnancy, if the patient having any sudden hemorrhage due to varices, we should avoid using vasoactive drugs like terlipressin and octreotide. We should do endoscopic therapy, preferably endoscopic varicose ligation. And after the endoscopic therapy, we can start the patient on beta blockers to prevent further bleeds. So in some rare cases, due to portal hypertension, there is chance of splenic artery aneurysm, which can cause rupture during pregnancy and is a rare complication. Coming to delivery, how will we deliver the patient? So usually in CLD patients, vaginal delivery is preferred unless there are obstetric indications. But you should avoid, to prevent varicose bleeding, we should reduce the time duration in the second phase of delivery. We should avoid prolonged vasalva maneuvers, and we have to monitor the patient post-procedure. So in this case, what Madam presented, the patient doesn't have endoscopy done, it was done 2 years earlier, and the ultrasound was showing signs of portal hypertension. So we don't want to take any risk for the varicose bleed, so we advised her to go for cesarean section. Hence her platelet counts are good and her INR levels are good, then we have no complications post-surgery. So how to manage the patient? So it is multidisciplinary. We have to risk stratify before the pregnancy based on the MELD score and child score. There should be disease optimization stable for at least 1 year before the pregnancy, and we have to give contraception counseling until patient is fit for the pregnancy. So medication review should be done, and some medications we should avoid, like mycophenolate or spironolactone for ascites. These medications we should stop before pregnancy. And we have to screen for varices. This is very important, either before pregnancy. If it is missed, then we have to do in the second trimester of pregnancy. So what we will do is, we will monitor the patients with CLD. We should check regular LFTs, and we will survey, growth surveillance of the fetus should be done. And we have to check for any blood pressure rise or proteinuria during the pregnancy period. So we should plan the delivery at a tertiary care center where multidisciplinary team is available, like hepatologist or gastroenterologist, and high-risk obstetrician, anesthesiologist, and neonatologist. So only with the multidisciplinary care, we can assess the patient properly, and we can deliver the patient, and the child and mother's health will be in good hands. Thank you.
Thank you so much, sir. I now request Dr. Anuradha ma'am to come on the stage for the next topic, bradycardia to birth, maternal complete heart block management.
Good
I
afternoon.
request Dr. Navin sir to come on stage to chair the session, please.
Good afternoon, everyone. So these are the cases which we did in our hospital with the help of a multidisciplinary team. So this mother is a woman with complete heart block. So what is the unique of complete heart block? So normally in pregnancy, as pregnancy progresses, the heart rate increases. But in a woman with complete heart block, heart rate will be constant. So it will not increase. And that too in a twin pregnancy, the demand will be more, where the chance of mother getting complications like syncope, sudden death, Stoke-Adams attack, complications will be more. This is our case, which we could successfully manage with the help of the cardiologist and anesthetist. So what is complete heart block? It is a third-degree AV block characterized by complete atrioventricular dissociation, where atrial impulses fail to conduct to the ventricles. Most common in pregnancy is congenital rather than acquired, and the incidence is 1 in 15,000 to 20,000 pregnancies. So as I told, twin gestation, there will be increased maternal cardiac demand, leading to challenge in the management of pregnancy. So this lady at 26 years of age, second gravida, DCDA twin, she had a congenital heart block diagnosed at the age of 20 years when she had a sudden syncope. And she doesn't have any other connective tissue disorders, rheumatic heart disease, or any symptoms. So she's an asymptomatic lady, now became pregnant, and that too spontaneous conception, DCDA twins. And her baseline heart rate when she was referred to me at 33 weeks was 40 to 45 beats per minute. And before coming to me, her antenatal course was asymptomatic, and she doesn't had any cardiac symptoms. And when she came, we did a walk test, exercise test, and her heart rate didn't increase beyond 50, but she doesn't had any complaint. And at 36 weeks, she was admitted with labor pains. And on examination, at the time of admission, her heart rate was 46 beats per minute, and DCDA twins, normal growth, and ECG of the lady. So after seeing this ECG, gynecologist, we should suspect normal or abnormal. That we should do first. So this is not a normal ECG, because all P waves are not accompanied by QRS complexes. So there is no association between P waves and QRS complex. So in a complete heart block, the P to P interval and R to R interval will be maintained, but there will be more P waves than QRS complexes, and no association between P wave and QRS wave. So as she came with labor pains and twin gestation, we planned a multidisciplinary team care first done. Cardiologist saw her, and we thought we will insert temporary pacemaker prophylactically, and if she deteriorates, her heart rate comes down, we will switch on the temporary pacemaker. So temporary pacemaker was inserted and we did a cesarean section and both the twins were fine. And post-delivery, her heart rate dropped to 36. So we activated the pacemaker and after 24 hours, as the patient was stable, we weaned off the temporary pacemaker. And she was discharged on a stable condition on post-op day 4 and she is under our cardiologist follow-up. Sir, anything you want to add on temporary pacemaker, sir? Okay, temporary pacemaker, this is the X-ray after delivery and we put in the antenatal period under ultrasound guidance because not to expose the fetus for radiation. Post-delivery, we took an X-ray and we could see the temporary pacemaker and the lead was in the right ventricular apex. And so we have two types of escape rhythms. Normal sinus rhythm, junctional escape, ventricular escape. How to differentiate whether it is a junctional or ventricular? In junctional escape rhythm, there will be narrow QRS complexes and ventricular escape rhythm, there will be broad QRS complexes. So I told normally heart rate increases in pregnancy, but in complete heart block, the heart rate is fixed between 30 to 50. So chances of complications and fetal growth restriction, preterm delivery, and mother having syncope, arrhythmias will be more. So what are the management principles in a woman with complete heart block? We need to do ECG, echo, check for symptoms, and see for the fetal growth. And we should avoid AV nodal blockers like digoxin, beta blockers, calcium channel blockers. And permanent pacemaker is advised when heart rate is less than 40, wide QRS complex like ventricular escape rhythms. And temporary pacemaker only if the woman is unstable either in the intrapartum or postpartum period. And vaginal delivery if the patient is stable. And we need to monitor for 48 hours. So in our case, though the woman is asymptomatic with narrow QRS complex, as the heart rate is less than 50, we went for prophylactic pacing. If the heart rate was more than 50, no need of any prophylactic pacing as per the European Society of Cardiology 2025 guidelines. So coming to contraception, as we know, OC pills are better to be avoided and safe for barrier and copper IUDs. So conclusion, twin pregnancy with pre-existing complete heart block can have favorable maternal and neonatal outcomes with early diagnosis, multidisciplinary care and judicious use of temporary pacing during labor. Careful maternal fetal monitoring and guideline-based pacing decisions are crucial. Sir, Naveen sir, please add some lines on temporary and permanent pacemaker.
That's it, madam.
Okay, coming to okay.
Something I just want to add. So when you are using cautery, when permanent pacemaker is, just change it to AOO mode. It's not DDD mode, or not recommended. Only that thing you have to, when it is permanent pacemaker.
Okay, so this is a temporary pacemaker, so we were on demand mode. Okay, next case is, this is a case of antenatally diagnosed premature closure of ductus arteriosus, and we could manage with the help of pediatric cardiologist and neonatal team in our hospital. So what is ductus arteriosus? It connects pulmonary artery to aorta. This ductus arteriosus will be patent in fetal life because of low oxygen tension and prostaglandin E2 levels in utero. And because lungs are fluid filled, they have high resistance in utero. So the blood from the pulmonary artery bypasses through the ductus arteriosus into aorta. After delivery, because the lungs aerate, resistance decreases and the ductus arteriosus gets closed. So premature means premature closure of ductus arteriosus is a rare and severe condition caused by usage of NSAIDs or polyphenol-rich foods during pregnancy. So this is a case of 25 years old Primey, she had initial antenatal checkups outside and she was referred to me at 38 weeks of gestation, telling that the baby has some cardiac anomaly. NT, TIFA, growth scans done at 28, 32 weeks were normal. And they diagnosed abnormality in the fetus at 38 weeks and they sent to me. So the images of the baby when I saw for the first visit. So this is the 4-chamber view. We can see the discrepancy in the size of the chambers. Right side is more enlarged compared to left side, and I couldn't see any flow through the right chambers. And coming to 3-vessel view, pulmonary artery appears to me dilated with no flow through the pulmonary artery. Then Jyoti Prakash sir was my survivor. So I went to Jyoti Prakash sir, sir, this is my findings. Sir confirmed that it is a premature closure of ductus arteriosus by repeating the fetal echo. So we counseled the couple and we posted for elective LSCS and we delivered 3 kgs female child. Baby had thick MSL and respiratory distress and baby was shifted to NICU. Now NICU care will be dealt both by pediatric cardiologist and Tanvir ma'am.
You start.
Good afternoon, everyone. I'm Dr. Tanvir. When the baby was delivered with a birth weight of 3.0 kgs, the baby had a good cry at birth. Later, we saw that the baby is having persistent respiratory distress. As we know that the ductus arteriosus was closed prematurely, we were in a plan to intubate the baby. Anyway, the baby has persistent distress first. With the pediatric cardiologist on the side, we did the echo. Immediately after birth, the flow through the ductus arteriosus was nil. No ductus arteriosus was seen. So we intubated the baby in view of persistent distress. Then we started the baby on IV sildenafil, which is a pulmonary vasodilator, as the right ventricular systolic pressures were much high and the right ventricle was pretty dilated. So we have started the baby on sildenafil and the baby was intubated for 2 days. With the help of pediatric cardiologist opinion, we tried to wean off the baby from the ventilator to CPAP, then HFNC. On day 5, the baby was out of ventilator and the baby was able to maintain its saturations on room air, and we discharged the baby on day 10. So this is the X-ray of the baby on day 1 of life. The baby had, sir, will you throw the light on echo findings?
So yeah, this is a very interesting case. So this one actually we kept here because majority of the times the foramen valve and ductal arch are actually underdiagnosed in utero. So here why we want kept is because the intactness alone of foramen valve and ductal arch is not sufficient. So you have to mention whether they are adequate or not. So go back to previous slide. So this fortunately the mother when referred, it's a 38 weeks, though that time actually, go back to prenatal.
Prenatal.
Fetal.
Prenatal episode.
Yes. Yeah. So here you can see that there is a significant ventricular disproportion, and when I see the 3-vessel view, the PA is grossly dilated and aorta is suboptimal. So means it's not there. And when we look for the ductal arch view, the ductal arch was not at all seen. Almost it is regressed completely. It is not at all visualized there. So then immediately I got that doubt. And after seeing that there is a significant RV dysfunction, and there is actually here it's not seen clearly, but in my images it was there. There is a significant pericardial effusion, almost like impending signs of hydrops. So go back to the postnatal echo. So the chest X-ray, anyway, you saw that there is a significant cardiomegaly. Okay, run the image. So you can see that there's the left side one is that is the left atrium and the left ventricle are okay, functional well, If you see the right one, there is a significant right ventricular hypertrophy, and there is increased echogenicity of the right ventricular myocardium, and including there is a significant RV dysfunction. And when you see that the cavity, the RV cavity, it is almost compromised, and there is a significant TR. That TR gradient is around 50 mmHg, means which is actually underestimated because of RV dysfunction. Means the PA pressures are much higher than that. And when you see immediate after newborn, the second image, if you see, there is no PDA at all. The PDA at least expected in first 72 hours, we will be seeing at least some amount of PDA. But immediate after birth itself, the PDA is not visualized. So this confirms our diagnosis of premature closure of ductus arteriosus. The fortunate thing here is actually it is drug induced, and actually the patient party didn't reveal to me they have taken NSAIDs just a week before when they came to us. But the advantage is because they are, by the time the RV dysfunction settled, it is 38 weeks. So we electively induced the patient. So we delivered the baby. So luckily there is no endocardial fibroelastosis for the child. So we started an IV sildenafil and managed. We kept everything back up, with, including that. You can see. Yeah, show me this video. Previous one. You can see that the PFO is bidirectional here, showing that there is a significant severe PAH. So yeah, you can see that the PFO is bidirectional there. Okay. So luckily the child went home without any sequelae and morbidity. So post procedure means after discharge, the baby was continued for sildenafil for another 6 weeks, and right now child is doing well. Now I think 4 months has follow-up. Can you show the other images, ma'am?
The baby was discharged on day 10 on oral sildenafil, and the baby was having regular follow-up with us. Now the baby is thriving well at 4 months of age. This is a recent picture with normal development, appropriate to the age. I thank our team for helping us, Anuradha madam also for, and cardiologist team.
So here itself it shows that the always
Team
group
effort.
is
Team
a
effort
must,
is
because it was diagnosed at right time, referred at right time, and managed at right place. Okay.
So most premature closure of ductus arteriosus are diagnosed postnatally, but ours is a case which we could diagnose antenatally and could give appropriate treatment with multidisciplinary support. Okay, so what is NSAIDs are better avoided in pregnancy if used for the maternal benefit for anything. We should monitor the fetus for congenital anomalies in the first 20 weeks and later for oligohydramnias and premature closure of ductus arteriosus by antenatal ultrasound. So early diagnosis is critical for management, and close monitoring and intervention improves outcome. Last case, mice, is dengue in pregnancy. Recently, in this month only, we got this case. She is a 19-year-old primigravida with 35 weeks of gestation, referred to our hospital in view of dengue with severe thrombocytopenia. At the time of referral, her platelet count was 20,000. So she had fever 4 days back, and an evaluation found to have dengue fever and NS1 antigen positive. She was admitted at local hospital and managed conservatively as platelet count was 83,000. Later, her platelet count dropped to 20,000, so they transfused 1 SGP and referred to Ramesh Hospital for further management. So on examination, she was 34 to 35 weeks uterus, and NST was reactive. On vaginal examination, clear leak was present with 2 to 3 centimeters dilatation, presenting part vertex at -3. So what is dengue fever and what is dengue hemorrhagic fever? I think everyone know. So I'm going to the recognition criteria. So if the mother has fever, body aches, nausea, vomiting, rash, leukopenia, and any warning signs, this comes under recognition. And like warning signs, if she has persistent vomitings greater than 3 in 24 hours or diarrhea greater than 3 in 24 hours, third space fluid collection, lethargy, restlessness, abdominal pain, tenderness, spontaneous bleeding, raised hematocrit, rapid drop in platelets, then these come under warning signs. So this checklist should be there in every hospital. This is from Fernandez only. I also continue the same. Okay, so this checklist will be there. So you should have a recognition criteria, warning signs, what are the symptoms in severe dengue, and then you come to the diagnosis like dengue fever without warning signs, with warning signs, and severe dengue. And we should daily check the status of the woman and see how is her temperature, BP, mean arterial pressure, pulse rate, respiratory rate, hemoglobin, hematocrit, WBC count, platelets, all these to be tested daily. So because this is in the third trimester and about to deliver, we need to suspect the vertical transmission to the fetus also, and we should alert the neonatology team. And pregnant mothers come under special group and need admission even in the absence of warning signs. So coming to my case, she is dengue fever, NS1 antigen positive, and she has warning symptoms, that is third space fluid collection, raised hematocrit, rapid drop in platelets. So she has warning signs. And now coming to, we have another phase like fever, critical, recovery phase. So 1 to 4 days is the acute phase, 5 to 7 days will be the critical phase, and above 8 days will be the recovery phase. So this lady presented on 6th day. So she is a lady came with dengue in critical phase with warning signs. So what should we anticipate? She is already in labor. So chances of postpartum hemorrhage will be more if she deliver even vaginally. So she progressed and we were making ready for the blood and blood products as the platelet count was only 20,000. And she progressed spontaneously and had a normal vaginal delivery with SDPs, single donor platelets on flow. She had severe postpartum hemorrhage. We gave all the oxytocics, carbetocin, misoprostol, methergine, tranexamic acid. Even then she didn't respond, and so we need to go to the next procedure, uterine tamponade. And we have done uterine tamponade with Bakri balloon and vaginal packing. And total blood loss was 3000 ml, and we transfused 4 SDPs, 1 RDP, 4 FFPs, and 2 packed RBC in the 6 hours. So coming to PPH, so we emptied bladder, we gave all oxytocics, and the final is uterine tamponade, compression sutures, arterial ligation, embolization, and hysterectomy. Luckily, my lady responded with uterine tamponade, and blood products. So as we were transfusing so many blood products, everything, her saturations was dropped, and so they intubated, and the delivery I have done in the OT, so operation theater. So I should thank all my anesthetist and critical care team who helped me in managing this case. And they intubated the mother, and she developed basilar cryptations, and we shifted to ICU for close monitoring. And to decrease the pulmonary edema, again we started her on dietary infusion, and we monitored her. Luckily, she didn't develop PPH. Further, no PPH, and she's fine. And we removed Bakri balloon and pack after 24 hours. And total 3 packed RBCs were transfused post-delivery. And here hemoglobin for 7.5 grams, for which we gave FCM injections. See the hematocrit and platelet count at the time of admission. Our hematocrit was 39.2 and platelets 22,000. Slowly, by the time we discharged, her platelet count was 1.9 with 21 hematocrit. Now, our neonatologist, Dr. Mahesh, will tell about the baby, how he could manage the neonate, because the lady was in active dengue infection.
Good afternoon, everyone. So very few points about congenital dengue, which behaves very notoriously. So actually there is very limited literature and data about this congenital dengue, but slowly there is increasing number of evidences of vertical transmission of virus from mother to fetus, which ultimately leads to perinatal mortality, morbidity and mortality. And this dengue infection during pregnancy, it can lead to preterm labor, low birth weight, miscarriage and stillbirths. So what is the time frame we have to be aware? This vertical transmission has been reported and should be considered in cases where illness in mother occurs 10 days prior to delivery to 10 hours post delivery. So during this time frame, we have to be aware and consider about the vertical transmission to the fetus. So this intrauterine transmission is high, especially when the mother is in the febrile phase, because viral load is more during the febrile phase. So that is the time where there will be more transmission of the virus. The affected neonates may become symptomatic up to 11 days because the incubation period is 3 to 10 days. So does the mode of delivery affect the rate of transmission? No, mode of delivery does not affect the rate of transmission. Dengue virus has not been shown to cause any congenital abnormalities. But if suppose dengue fever occurs during the organogenesis time, during the early trimester, studies have shown that it might cause spontaneous abortion or neural tube defects. So coming to the signs and symptoms, dengue can be as simple as baby can be asymptomatic, but it can be as devastating as it can lead to many hematological, cardiac and pulmonary complications, ultimately leading to mortality. The common presentations are like the baby may present with fever, erythematous maculopapular rashes with petechiae, and lab shows thrombocytopenia, leukopenia, bleeding manifestations can be there, organomegaly and transaminitis. So coming to the case which ma'am was talking about, which we managed 2 weeks back. So it was a male baby born by a normal vaginal delivery. The birth weight is 2.3 kg. Baby cried immediately at birth with Afghars 7, 8, 9 at 1, 5, 10 minutes respectively. So baby is very comfortable on room air. We were shifted to step down for observation. At 8 hours of life, baby started developing fever. So baby developed fever. Later, baby had asymptomatic hypoglycemia. The sugars were very low. Initially, I started on full oral feeds, but then we had to go upon GIR, increase the GIR and dextrose concentration. Later, almost we went upon to GIR of 10, requiring dextrose concentration of 18. So I had to secure central line on day 1 of life, and I noticed lot of time active bleeding was happening from the site of where I was trying to secure the PIC line. So then I have sent the coagulation profile, which showed INR of 2.5. The baby required FFP transfusion, and platelets on day 1 of life is 98,000. On day 2 of life, the platelet count dropped to 80,000, but there were no further bleeding manifestations. And on day 2 of life at 48 hours, we have done creatinine, which the routine labs we do RFT, was showing creatinine of 2.8. The next day it went on to become 3. It was actually non-oliguric KK because of some intrinsic cause. But from day 3 of life, at 72 hours, baby started responding clinically. Baby became more active. The platelet count started in an improving trend from 1.3 lakhs and so on. Even creatinine has started to come down. We are able to come down on GIR. We have started the feeds, slowly graded up to full feeds. So by day 5 of life, almost the platelets were 2.4 lakhs, and the baby and mother both were discharged on day 7 of life. During the time of discharge, baby platelet was more than 2.5 with a creat of 1. Breastfeeding was established. Baby was very active. Even yesterday they came for review. Both mother and baby are doing very well. But this baby did not trouble much. I have seen a couple of cases during my training days where one baby, term baby born of 38 weeks gestation, baby was very stable till day 4 of life, then started having fever, later developed severe thrombocytopenia with a platelet count almost 11,000, later went on to have deranged coagulation profile, went into coagulopathy, ultimately landed up in DIC, and later developed pulmonary hemorrhage. We had to ventilate and went into shock inotropes, but nothing worked. The baby ultimately landed up in mortality. So we as a clinicians have to be aware of this dengue fever, especially should be aware about the congenital dengue, and the baby also should be monitored closely. A baby born to a dengue positive mother. Thank you.
Thank you. We could survive all these patients because of multidisciplinary care.
Thank you so much, everyone. Moving forward to the next session, what is M in maternal medicine? I request all the chairpersons to please come on dais for this session. Dr. Lavanya Madhasu ma'am, Dr. Nandana ma'am, Dr. Venkat sir, and Dr. Chandrasekhar sir. Dr. Sarita ma'am, I request Dr. Tarakeshwari ma'am to please come on the dais. Ma'am is Chief Medical Director, Senior Consultant and Head Obstetric Medicine Unit at Fernandez Hospital, Hyderabad. She has successfully set up protocols for medical disorders complicating pregnancy. Ma'am is also National Coordinator for NBMS webinars in Fernandez Hospital. Over to you, ma'am.
Thank you. Good evening, everyone. I bring greetings from Fernandez family, and I thank the organizers for giving us this opportunity to present over here in this podium. So the importance of the mother in the maternal fetal medicine has not been so much updated or appreciated, while the fetal medicine has actually improved over the last few decades. So over the next few minutes, I'll be discussing a few case scenarios and the role of the maternal medicine in the MFM curriculum or the maternal fetal medicine fellowship. In the year 1960s, there was increasing number of obstetricians focused on the care of pregnant women with risk factors for pregnancy complications. This was one of the developed countries. They realized, and they first brought in 1974, the first maternal fetal medicine board certification, which was offered. In 1977, the Society of Perinatal Obstetricians has been changed into the Society of Maternal Fetal Medicine. After a decade, there was an interesting article in the Lancet which says it's a neglected tragedy. Where is M in the MCH, mother and child? The next several decades have seen so much of advances in the perinatology. The incidence of stillbirths have decreased substantially since the mid-1900s because of the advances in the perinatal care. Incredible advances happen in the area of the fetal medicine, neonatal medicine, particularly the fetal medicine where you can diagnose the congenital anomalies, the RH sensitization, and actually treat all these babies in the neonatal period. But did the same development happen in the maternal side? No, the morbidity has tremendously increased over the last years because of the reason of women with chronic medical conditions entering into pregnancy. Where do we stand today? There are generalist obstetricians, gynecologists. There are very few midwife-led units who help for the natural births. There is a gynecological oncologist who take the gynec-oncology into it. The medicine subspecialization has happened. The surgical subspecialization has happened. But this all excludes the MFM from many aspects of the maternal care. The maternal mortality in India, we know, has come down drastically. But have we achieved anything in the maternal morbidity? Not really. More and more women entering into the pregnancy with the chronic medical conditions, still the morbidity is very high. Let us see through a few case scenarios now. Mrs. P, 25-year-old with a BMI of 30. Her total weight gain was around 14 kgs. It was a spontaneous conception. The OGTT was normal at 24 weeks. She was normotensive throughout. Fetus was also a low-risk fetus. She was admitted at 37 weeks with reduced fetal movements, induced for the same, ended up in an emergency cesarean section for presumed fetal compromise and birthed a baby girl of 3.12 kg and discharged on POD2 in stable condition. But she came back to us on the post-operative day 7 with cough and headache. Her pulse was 78, but the blood pressure was high, 170/100. Remember, she is normotensive throughout the pregnancy. And she had bilateral basal Krebs on auscultation. She was shifted to the ICU and started on oxygen support. IV labetalol and magnesium sulfate was started, and she received diuretic. ABG showed a severe hypoxemia with respiratory alkalosis. Interestingly, chest X-ray is normal. So the 2D echo showed an ejection fraction of 69%, normal-sized cardiac chambers. These are her baseline bloods. The furosemide was continued once daily for 2 days. Labetalol was continued for 8 hourly, and amlodipine was added to control the blood pressures. She was discharged after 72 hours in a stable condition. So she had a postpartum hypertension. Is it suspected pulmonary edema? Not really. Follow-up after 4 weeks, she's not on any antihypertensives. The home blood pressures were normal. Remember, all of us obstetricians should have a care pathway where we can look at the mother coming in with certain symptoms and then look at which pathway she belongs to. It's a hypertension pathway or it's a cardiopulmonary pathway. So if you have the early warning scoring system and if you monitor the pulse, the respiratory rate, the blood pressures, and then depending upon the symptomatology and signs, and we can get into this care pathway. So this is where the maternal medicine comes into picture. You should have care bundles. It's a case of postpartum hypertension, preeclampsia. As we all know, postpartum preeclampsia is very atypical, and it can be de novo following a normotensive pregnancy. 10 to 30% of the women can develop postpartum preeclampsia. Remember the triggers for evaluation of secondary etiologies when the mother comes for postpartum hypertension, especially if the requirement of antihypertensives is high, and the clinical symptomatology of headache and also palpitations, and any hypertension persisting 3 months postpartum needs evaluation. So the obstetrician follow-up doesn't end with 6 weeks. We should remember to follow them up of 6 months, 3 months to 6 months if some atypical presentation happens in the postpartum period. So the management considerations are the same: antihypertensives to blood pressure control, magnesium sulfate for seizure prophylaxis, and remember the diuretics, it should be always guided by the volume status and the long-term management for these women. So we have a postpartum preeclampsia patient information leaflet. Remember, what is it? What are the risks to you? What are the warning signs? What can you do? We should educate the women, and also when she develops any signs, she should be able to report to the hospital. Center for Diseases and Prevention Control, they have had a campaign last year. It's called Hear Me campaign. Any woman coming into your clinic with new onset symptoms, we need to have time to listen to her. And then rather than saying this is okay, we need to understand what really the symptomatology means for her. Remember the warning signs: very severe upper abdominal pain, severe headache, nausea feeling, and swelling in the hands and face, sudden excessive weight gain over the last 2 weeks, and shortness of breath. So the Preeclampsia Foundation gives us a nice guidelines, and we have to follow up these women, particularly the early onset preeclampsia, where you deliver all these mothers before 34 weeks. We should have a plan to follow them up at 6 to 12 weeks, 6 months, and 1 year, and there should be an annual medical review. So we have to help them and to understand and how best they can manage themselves in the postnatal period. So also remember to do a lipid profile in the postpartum period. There is an International Society for the Study of Hypertension Pregnancy. It's called ISHIP. They have a beautiful guidelines 2022, which has been accepted by the FIGO, and it's worth following those guidelines and also following these mothers, because dyslipidemia is the most common cause of venous thromboembolism during pregnancy and also early onset preeclampsia. So we need to discover HEM to reduce the maternal morbidity and thereby the mortality. Coming to the next case, she's a 40-year-old fifth gravida. She had bad obstetric history and only a one live child, which was a preterm section, but still she wants to have a pregnancy and she comes to you. She's advanced maternal age. Nowadays, 35 years is no more an advanced maternal age. We see more and more women at the age of 35 and 36. 40 years has become very common now, but we need to be watchful, and counseling is very important. And when you looked into her history in detail, she has a history of ulcerative colitis, and she had always had some episodes of bleeding per rectum. There are certain guidelines which we need to follow. The maternal medicine person has to spend time, understand in the preconception period itself what is the medication she is on, how much is the disease-free period for her, and what is the interdisciplinary consultation. You heard the previous cases, how the multidisciplinary team helped each other in managing these women, and also the medication management, we need to be very careful. We see most of the women now, after stopping methotrexate, after 1 month they conceive and people would have terminated. 3 months is theoretical risk, 1 month is the absolute one. So if she conceives after 1 month accidentally, it is all or none phenomenon. Wait for an early pregnancy scan, wait for a nuchal scan. So that is one concept which we all have to understand. And most of these women with inflammatory bowel disease and ulcerative colitis, they will be on sulfasalazine. But remember to continue the folic acid throughout pregnancy. Please don't stop them at 16 weeks because sulfasalazine interferes with the folic acid metabolism. And azathioprine can be continued. Monotherapy is always better for these women rather than a polytherapy. And also biologic therapy can be continued, but we have to measure the serum drug levels. So these are all reality. These mothers are coming to us. It's not a textbook thing. Obstetrician should have this awareness and refer to a proper maternal person, medicine person. Post-delivery care is also extremely important. What is the mode of delivery? Most of them have anal fistulas. They would have had the surgeries for that. So she's for a cesarean delivery. But the postpartum, how do you manage her lactation, biologics? So when does she start her biologics in the postpartum period? So all this is important for us to understand when a mother has a chronic medical disorder. And also we have to, about the vaccines we should be given on schedule and avoid live vaccines in the first 6 months with in utero biologics exposure is an important advice where we talk to the neonatologists and they follow it up. So here comes the role of preconception counseling to reduce the maternal morbidity. So mother has to be looked into, not only the fetus. Coming to the other mother, 26-year-old recently married. She's a known epileptic on anti-epileptic drug. She's on the polytherapy. So she wants to know whether she can plan pregnancy. So how do we counsel her? We cannot say you cannot become pregnant. We need to understand her and also do counseling, effective counseling. So uncontrolled seizures, better not to plan immediately. Taking high doses of anti-epileptic drugs, not immediately. Polytherapy, so ideal is monotherapy, but depending upon her epilepsy, she has to be on 2 drugs also sometimes. And sometimes there is a drug-resistant epilepsy, uncontrolled epilepsy. So we need to be carefully asking her about the compliance with the medication and also look at the other medical comorbidities. So you should optimize the maternal health preconceptionally, remain compliant with the anti-epileptic drugs, close follow-up along with the neurologist. So here the maternal fetal medicine person has to liaise with the other specialties. Avoid seizure triggers, manage seizures with the lowest possible anti-epileptic drug, avoid changing medication if the woman is seizure-free, and please don't stop medication on your own. We need to discuss with the neurologist, talk to the woman, and then only we need to change the medication. Avoid sodium valproate, consider changing to less teratogenic drugs, but if she is very compliant and doing very well, we did not have to stop the drug. So we need to remember the fetal malformations. Yes, there is an increased risk of congenital malformations, but these are the women who are mostly on levetiracetam and lamotrigine, newer anti-epileptics. They are considered safe in pregnancy. So while on monotherapy, the background risk is 3 to 5%, but while on carbamazepine, risk is 2.2%. We have a nice websites where Terrace is one, Bump from UK is one. We can put the drug, know about the risk of malformation, and we can counsel the women. Not that all of us have to remember everything, but we need to have evidence when counseling these women. No more we use the FDA categories now. We need to have the drug, we need to have the available evidence to counsel these women. Now coming to the case 4, primary gravida, 34 years. She came to our ER at 21 weeks of gestation with shortness of breath. She had a family history of hypertension and type 2 diabetes. So she has typical cough, waking up in the night with breathlessness, better after upright for 2 hours examination. General examination, the JBP is raised 3 centimeters above the clavicle, mid-diastolic murmur in the mitral area. The provisional diagnosis is a rheumatic heart disease, mitral stenosis, and New York Heart Association class 2. Rediscovering the M in the medical examination with having all the multi-parameter monitors, we forgot to put a hand on the pulse, we forgot to auscultate. I think we should be back to our basics, inspection, percussion, palpation, auscultation, and percussion. Just not forget about our basics. And here, this lady with a cardiac problem, the 2D echo showed double valve affected, severe mitral stenosis, as well as the aortic stenosis and moderate pulmonary arterial hypertension. She's already around 24 weeks of gestation. So better ask the cardiologist, talk about, start the medications, the cardiac drugs. She was started on metoprolol, furosemide, and Penidur prophylaxis. And this is a 2D echo, which is showing the double valve getting affected, the mitral and the aortic valve. And this is a high-risk cardiac condition, isn't it? There is a low risk, medium, and the high risk, and this is a high-risk cardiac condition with a pulmonary arterial hypertension. So the combined counseling helps with the family. Sit together and counsel, evaluate the current cardiac status, and discuss the options of management and the maternal and the fetal risks. She underwent a balloon mitral valvotomy at 26 weeks, and the repeat 2D echo later showed a moderate MS with mild MR and a moderate AR and a moderate AS. Alleviation of symptoms and anemia corrected with oral iron. She continued her pregnancy. This was the fetal evaluation, the fetal growth, showing on the 10th percentile. And she went into spontaneous labor at 37 weeks, and she delivered in the ICU. It's always better to have one person monitoring this mother and allotting a ICU facility or an isolation room facility and delivering this lady. So 2.1 kg baby delivered a normal Apgar, and she required postpartum thromboprophylaxis because of the high risk. Always better to have the management plan and delivery for all the high-risk conditions. It's easy because we have a lot of turnover of the residents with a less clinical exposure, and it will be easy in the handover in the labor rooms how we monitor these mothers and deliver them. So we have this cardiac disease and pregnancy management plan and delivery. Every medical disorder have a plan and delivery so that it will be easy for the youngsters to follow. So I think it's time to place the M back into focus, the maternal mother into focus, rather than concentrating on the fetus and the neonate alone, because mother has to be looked after well. And I think we all remember the Barker hypothesis, Pedersen hypothesis, and the Frankel hypothesis. All this will affect the mother, and the maternal non-communicable diseases have been increasing nowadays. So the maternal health gets a priority. And in addition to this chronic medical conditions, we have the ACRITA, more number of cesarean sections, less exposure to the instrumental births, and these are the women actually getting more and more sections and getting into placenta ACRITA spectrum and being referred, and these are the women who have at high risk of mortality and morbidity. The risk of postpartum thromboprophylaxis, antenatal also, some women may require a thromboprophylaxis at 28 weeks, so the time has come now to place the M back into the focus. So to look at the statistics of the 2023, sorry, I couldn't update 2024, 40% of the pregnant mothers have medical disorders complicating pregnancy, and most of them are diabetes. First is hypertension, second is diabetes, then is the connective tissue disorder complicating pregnancies. And remember, we should have the near miss or the morbidity being looked at for each and every mother, and we should have the audits every month. And if you look at 2023, we have 9,777 women birthed, and potentially life-threatening conditions were in 13%, and 74 were life-threatening, and near miss was 73, and we had 1 maternal death. But in 2024, we had 5 maternal deaths being referred with a different chronic comorbid conditions where mothers have been referred. Either it is too critical stage or in a too late stage. It's always better you audit the morbidity. Mortality is coming down in India, but the morbidity still has not come down. Every institute should have a near-miss audit. And if we have a near-miss audit, and then we know how many mothers have potentially escaped near death. Multiple pregnancy, now this is increasing. So the near-miss audit last year from 2022, slowly showing increasing comorbid conditions in multiple pregnancy, especially the availability of the IVF pregnancies at every level. The near-miss multiple pregnancy contributed to 3.2%. We had 1 maternal death. This is a lady with a scleroderma, interstitial lung disease, and she had a 24 weeks fetal demise, and she had a medical ERPC followed by PPH and cardiopulmonary arrest. Unfortunately, we couldn't survive her. So putting M back in maternal fetal medicine, I think all obstetricians and gynecologists should think about the maternal condition, apart from the fetal condition, doing fetal scans and fetal treatment and more fetal assessments. Then we have to put this M back. And in 2012, the first putting the M back in maternal fetal medicine session was held in the Society of Maternal Fetal Medicine annual meeting in USA. And they also had said there are 3 urgent needs that are identified. One is education. Mandatory rotation for all the maternal fetal people, because they come after post-MD, should again continue there into the labor room delivery and ICU. And also we should have active certification ACLS, and we should have simulation-based learnings, because now hands-on has come very less. And also leadership skills. There should be a training in the leadership skills. Clinical, we should have guidelines and care bundles. Thromboprophylaxis, we have a guideline. Cardiac, we have a care bundle. So postpartum hemorrhage, we have postpartum kits. Eclampsia is reduced because we have eclampsia kits. I think there should be a need, there is a need for the guidelines and the care bundles to prevent and manage maternal morbidity. There should be an increasing support to the maternal fetal medicine subspecialists because they are specialized to understand, to read, and help the common woman with a lot of comorbid conditions and highly challenging medical problems. And critical, there is a very serious research gap. Case reports, case studies, or it is even you can do the prospective or the retrospective analysis of our own data in our country, and we should be publishing our own data. And all long-term outcomes after adverse pregnancy should be followed. We have registries. We have a cardio-obstetrics registry in India. I don't know how many of you are aware of. You can enter into that registry. So there are registries, and also the policy makers, the politicians, as well as the heads of the different institutions all should come together, and this all will help us to reduce the morbidity. And continued medical education is mandatory. We have a specialty of obstetric medicine because how much of exposure we have during our MD days to the medical disorders, and the complex medical disorders are increasing. There are dedicated fellowship programs. I think people should be encouraged to do these programs. And there is a Society of Obstetric Medicine India, SOMI. You can put your case into that and we can discuss the cases because all of us should work together. So we should have updates, obstetric medicine dedicated, how we have fetal medicine updates. We should have an obstetric medicine updates, people who are specialized in the obstetric medicine. They can share their experiences, and there is a lot of advances in the pharmacology too. Newer drugs are available in our country. These are few obstetric physicians who can be, they have updated all our knowledge about it, and we can share our knowledge by publishing our guidelines and also our booklets so that it will be shared among the people. And finally, I can only say, the bigger the dream, the more important the team. And I thank you. If everyone is moving forward together, then the success takes care of itself. Thank you so much. Thank you, chairpersons, for this opportunity.
Thank you.
Thank you very much, madam, for your elaborate discussion on the M. What is the M? We are thinking what is the M? It's nothing but maternal morbidity, mortality, and all those things. And we have been discussing all the high-risk pregnancies, and you analyzed everything. So, as an obstetrician, it is not only the obstetrician, but also the family responsibility and the social responsibility also should be included in making the program of maternal, decreasing the maternal mortality and morbidity. And I think even the government is doing a lot of work, and they are implementing so many factors, that is all the programs to decrease the maternal mortality. And even the high-risk pregnancies and all the pregnancies are being tracked by the departments, various departments. So it is not only an obstetrician's role, but also a family and the social program, social responsibility, including the politicians. So with all the cooperation, I think we can definitely decrease the maternal mortality. Thank you very much, madam, for telling the M product.
Thank you so much, ma'am, for this enlightening session. I request all chairpersons to please felicitate Dr. Tarakeshwari, ma'am. Thank you so much, everyone. Moving on to the next session, Tiny but Mighty, Comprehensive Care for Preterm Neonates with Multidisciplinary Approach. I kindly request Dr. Tripura Sundari ma'am. Ma'am is HOD and Unit Head of Obstetrics and Gynecology Department at Ashram Medical College. She is current President of Vijayawada Obstetric and Gynecology Society. Dr. Jhansi Vani ma'am. Ma'am is Professor at GGH, Senior Obstetrics and Gynecology Consultant. Dr. Aruna ma'am. Ma'am is prominent gynecologist and infertility specialist in Guntur. Speaker for this session will be Dr. Anita ma'am. Dr. Anita ma'am is Senior Consultant Pediatrics at Aster Ramesh Hospital, Guntur. Ma'am is a pediatrician and neonatology specialist with advanced training in child health and nutrition.
So good afternoon everyone. Today my topic for discussion is golden hour of preterm newborn care. Why the golden hour is important? What is golden hour? This is the first 1 hour of postnatal life. This is a critical period for stabilizing preterm and extreme low birth weight infants for minimizing complications and improving short-term and long-term outcomes. What are the short-term outcomes we come across at the preterm delivery? These are like hypothermia, hypoglycemia, and respiratory distress syndrome. Long-term complications we expect are like bronchopulmonary dysplasia, intraventricular hemorrhage, and retinopathy of prematurity. So why is golden hour critical for preterm? Because premature infants are physiologically immature and face unique challenges. These are like high susceptibility to hypothermia. Why? Because the preterm infant skin is very immature and loss of evaporative losses are more and larger surface area and lack of insulating fat. These all lead to high susceptibility to hypothermia. And immature lungs and surfactant deficiency can lead to respiratory distress syndrome in short term and bronchopulmonary dysplasia as long-term complication. Fragile capillaries and increased risk of bleeding can cause intraventricular hemorrhage. And poor energy stores can cause hypoglycemia as a short-term complication which can lead to occipital loss of vision in later life. Underdeveloped immune system can cause infections. So decision during these hours significantly impact lifelong health. So key components of golden hour management includes team approach and communication, prevention of hypothermia, effective and gentle resuscitation, delayed cord clamping, optimal respiratory support, nutritional and fluid support, prevent iatrogenesis and sepsis, and family communication. So team approach includes multidisciplinary team should be ready with 3 to 4 members, one senior neonatologist, neonatal fellow, 1 or 2 pediatricians with nurse, who should be ready for resuscitation. And each team member should know their responsibilities prior to the delivery of the preterm baby. And they should use checklist for equipment, and standardized protocols should be followed as unit protocols. And they should have, there will be coordination with the obstetric team and before and during delivery, and the parental counseling is more important. What the parental counseling includes? Parental counseling includes gestational age of the baby, approximate weight, and what is the survival chances, and what are the short-term and long-term complications they will come across. So prevention of hypothermia is more important. This should be get ready before the delivery of the preterm baby. So we have to set the delivery room temperature at 25 to 27 degrees centigrade and higher if needed for less than 32 weeks of delivery babies. And use a pre-warm radiant warmer and ensure it should be switched on just 10 minutes before delivery and with 100% heater output. Utilize the plastic bags or wraps we can use, and immediately after delivery of the preterm baby, we have to keep the baby in plastic bags without drying the baby, because to reduce the evaporative heat losses. And thermal mattresses on caps we can use to prevent to provide additional warmth for extremely preterm babies. And use transport incubators and transfer the baby from delivery room to NICU with transport incubator. So delayed cord clamping is more important thing. WHO, ACOG, AAP, and all IAP all are nowadays encouraging for delayed cord clamping. Why? Because delayed clamping has so many benefits like 30% reduction in hospital mortality, improved blood volume, better hemodynamic stability, improved stem cell and immunoglobulin transfer, reduces the risk of intraventricular hemorrhages and necrotizing enterocolitis, increases the iron stores and that decrease the need for transfusion. So anemia risk is less in premature infants and benefiting the brain development in first few months of life. Only one disadvantage with delayed clamping is jaundice, which can be treated with phototherapy. So we have to consider delayed clamping in stable babies. In unstable babies, means baby is not cried, requires resuscitation, then we have to, we should not do delayed clamping. We have to cut the clamp immediately and please hand over the baby to neonatologist for further management. And shall we do cord milking in these babies? No. We don't encourage cord milking because of the risk of intraventricular hemorrhage. So after delivery of the baby, if baby is crying and no need of resuscitation, we have to keep the baby supine and shoulder roll, and positioning is more important, and we can dry the baby if more than 32 weeks. And baby should be, if required, we have to start CPAP, or if baby is not cried and baby requires resuscitation, means we have to start resuscitation with TP's resuscitator because it provides controlled tidal volumes for preterm babies. Avoid high airway pressures. The pressure should be with PEEP of 6 to 8 centimeters of water and PEEP of 20 to 25 centimeters of water. According to that, we have to adjust, depending on the saturations and work of breathing, we have to adjust the pressures and this one. Target saturations are important. Target oxygen saturations are delivered using the blender. We have to use blender for FiO2s of required FiO2. That is, for less than 28 weeks baby, we have to give 30% oxygen. And 28 to 31 weeks, we can give up to 21% to 30%, and more than 32 weeks, we can give, we can resuscitate with room air. And if FiO2, the target saturation should be 80% by 5 minutes of age. So if baby is baby cried immediately after birth or not cried, required resuscitation. After that, we have to assess for the work of breathing and retractions by Silverman-Anderson score. If the score is more than 4, baby needs CPAP support. So initiation of delivery room CPAP is the, now we are encouraging for delivery room CPAP for those babies. And the early rescue surfactant also we are giving and administering surfactant within first 2 hours of life if needed. If FiO2 requirement is more than 30%, work of breathing is more, and X-ray ultrasound suggestive of respiratory distress syndrome features, then we have to give early rescue surfactant. And if baby is not cried, required ventilation, and we have to give gentle ventilation strategies we have to follow, like utilization of volume guarantee modes, and we can minimize lung injury by using the volume guarantee or volume target ventilatory strategies. Hyperoxia should be avoided because hyperoxia can cause retinopathy of prematurity. So we have to target the saturations between 90 to 94%, and alarm limit should be from 89 to 95%. And nowadays we are starting caffeine for all babies who born less than 32 weeks of gestation for prevention of apnea of prematurity. And along with that, all these measures, in first hour only, we have to start nutritional and fluid support for all preterm babies because they lack stores. That's why we have to start intravenous fluids like dextrose, lipids, protein, and within the first 1 hour of life. For these are high osmolality fluids, so we have to insert umbilical venous catheters. If needed, umbilical artery catheterization also we have to do if regular ABGs are necessary. Consider early enteral feeding. If the baby is stable, not requiring, means no contraindication for feeding, then we have to start minimal enteral nutrition. This we start 10 to 20 ml per kg per day. And maintain normoglycemia is more important, and regular glucose monitoring we have to do. Prevention of iatrogenesis and sepsis by use of aseptic techniques like apply strict hand hygiene and sterile procedures to prevent the infection is more important. And we have to avoid rapid boluses for the prevention of intraventricular hemorrhage and also for Hemodynamically significant PDA risk is more if we give more rapid fluid boluses in these babies. And antibiotics should be started empirically if infant is at risk for early onset sepsis, and we have to send blood culture. After that, we'll start antibiotics. And if the cultures are negative and baby is clinically stable after 48 hours, we can stop the antibiotics. So physical injury can be minimized by gently handling the baby, and gentle handling and positioning, and by developmentally supportive care include noise reduction, gentle handling, coupling procedures and skin care, and early parental participation, that is by kangaroo care. So monitoring of blood pressures, aim for normal tissue perfusion and start inotropes if necessary. We can do functional echocardiography bedside, and according to that we can start inotropes. And maintaining hemoglobin within acceptable levels is also more important. And manage jaundice with phototherapy or exchange transfusion if it is in pathological ranges. So family communication is more important. Providing information and engage with parents before and after delivery is more crucial, and keep them informed. Discuss the baby's condition, procedures and treatment plan. Timely interventions and all are helpful. Create a trusting environment. Allow families to see and touch their babies as soon as possible if the baby got stabilized. So golden hour checklist include pre-delivery, team should be assembled, radiant warmer should be ready, polythene wrap or cap and all the things for thermoregulation should be ready, and immediate post-birth, infant should be placed on warmer or transport incubator, and initial heart rate breathing should be assessed, and delayed cart clamping if stable. If baby is not stable, then we have to do early cart clamping. And respiratory support is initiated, that is delivery room CPAP. Preductal saturations should be monitored and IV access should be secured. If necessary, baby is transferred to NICU, means in incubator, we have to transport the baby to NICU under thermoneutral environment. And continuous monitoring during transport is mandatory. So this diagram depicts the golden hour management of the baby, like what we have to do: antenatal counseling and team briefing, and send required laboratory investigations after delivery, prevention of hypothermia, communication with parents, nutritional care, nosocomial infection prevention, and keep necessary records like axillary temperatures and resuscitation details. Cardiovascular system support, and give support to respiratory system by delivery room CPAP or NIV or HFNC, or required volume targeted ventilation or high frequency ventilations. Nowadays we are going towards the high frequency ventilation for extreme preterm babies, if because it delivers low target volumes and it prevents the lung injury. So we are encouraging high frequency ventilation for preterm babies. So therapeutic hypothermia. This therapeutic hypothermia is indicated in term babies who were born with birth asphyxia with moderate to severe hypoxic ischemic encephalopathy. If we start therapeutic hypothermia within 6 hours of life, and if it is continued for 72 hours, the mortality and the risk of cerebral palsy will be decreased. So we encourage therapeutic hypothermia for moderate to severe birth asphyxia babies. So as a doctors, we are trying to act to assess and diagnose, but we have to take some pause. For what? We have to listen some voice. What is that voice? The voice of the baby. If baby can speak, baby may deliver, maybe say these words: if I am going to be born preterm and small, please give my mom steroids and help me survive. Don't allow me to contaminate amniotic pool with my meconium. If so, take me out at earliest and help me survive. During labor, I am traveling through narrowest passage in my life. So I may be in trouble. Please be there fully armed to help me in case if I need it. Despite your help, if I am in trouble, help me to transport to the nearest good center. So So they cannot speak. If the baby may say these words to us. So please transport the baby by transport incubator along with the neonatologist team if necessary, or if possible transfer the baby in utero where the NICU facilities are there. That will be helpful for babies' long-term and short-term complications to overcome. So sometimes the most powerful guidance does not come from textbooks or machines, but from imagining the voice of the baby asking us for the chance of life like this. Okay. Take home summary and take home message is the golden hour is a critical evidence-based strategy for managing preterm infants. It requires a coordinated team, clear protocols, and attention to key interventions like thermoregulation, respiratory support, and nutrition. Successful implementation relies on your communication, teamwork, and adherence to best practices. Effective golden hour care can significantly improve outcomes and give high-risk neonates the best possible start. Because of, as neonatologists and obstetricians are caregivers, we hold the power to change outcomes, not with miracles, but with timely evidence-based care, that is golden hour management. Thank you.
Thank you so much, ma'am. I request all the chairpersons to please stay for the next session. Moving forward to the next session, Effective Obstetric Analgesia for a Positive Birthing Experience by Dr. Kartikeya sir. Dr. Kartikeya sir is consultant anesthesiology at Aster Ramesh Hospital, Vijayawada. Sir is an experienced anesthesiologist and intensive care physician with over 8 years of expertise in managing critically ill patients and providing perioperative anesthesia for complex surgeries.
Good evening, everyone. I think we are near to the close. Probably last but one presentation. I don't want to trouble you, make you sit too long. I'll breeze through. I don't want to go to too much detail into each of them.
Excuse me, sir, 1 second. I wanted to congratulate Dr. Anita. Your presentation was very lucid explanation of golden hour. Within that short time, you could make best use of that golden hour. And your last but one slide, that neonatal plea, that was awesome. And all your slides were fabulous. Very nice presentation, very useful. And I congratulate you on your presentation. Very nice. So sorry to interrupt you, sir. Please continue.
So the topic is obstetric analgesia for a positive birthing experience. I think when my kid was born, I tried to be as positive as I can, but that didn't help my wife. Then I realized it's not me who should be positive, the person who is actually giving the birth. So it all began in 1591, where a lady was burned for asking some pain relief in Edinburgh. Then the proverb says that in the Garden of Eden, God punished Eve for eating a forbidden fruit, and then said, "In sorrow thou shalt bring forth children." So there is a notion that for the last 300 years it's been like no pain, no baby delivery. So even WHO conducted a survey which said in the last 3 decades, people in remote areas still believe that without pain there is no labor. So that formed the basis for 1800 years in the past. John Snow in 1853, he was the first person. He's termed as father of anesthesia. He actually gave chloroform for Queen Victoria's birth in Buckingham Palace. 8th child was born using chloroform. That's the first when somebody tried to give some pain relief analgesia. Then developed the pain pathways and continuous caudal infusions and continual lumbar epidurals, which came into existence, which we still improvise and follow today. So there's two types of pain. One is the visceral pain and the somatic pain. Don't want to go into too much details. First stage, active and latent phase. Second stage, somatic pain, which is S2 to S4. So the pain intensity goes up as we go from the latent to active phase and the second stage. So in the McGill pain scores, the causalgia is 40, which is a digit amputation. So nulliparous patients and primiparous, untrained, they experience pain up to level 40, which is a digit amputation without any anesthesia. So it's as bad as that. Multiple analgesia options are there. So Going into non-pharmacological options like complementary alternate therapies in the next slide, going into pharmacological options like non-regional techniques like inhalational Entonox and Sevoflox, and regional techniques like epidural, patient-controlled epidural analgesia, and combined spinal epidural and spinal analgesia. So alternative medicine techniques, these come as a psychological things like hypnosis, breathing techniques like Lebois and Lamaze technique, relaxation therapy, yoga, homeotherapy, aromatherapy, hydrotherapy, acupuncture, massage, and transcutaneous electrical nerve stimulation. So ideal techniques doesn't interfere with the progress of the labor and delivery. It's safe for both. There are two patients at risk. One is a mother, the other one is the infant, and it provides the flexibility in changing conditions, changing nature of the labor, minimizes undesirable effects, and constant pain relief is provided throughout. Some non-pharmacological techniques like underwater delivery still followed in some of the cities like Chennai, where there's no advantage in labor outcome or reduction of the need for analgesia. Only thing which was shown was epidural analgesia. The need was delayed for 30 minutes, and most of the trials lack safety, and there are some reports of asphyxia and fetal injuries with hydrotherapy and underwater deliveries as well. A slide on TENS, which is an electroanalgesia method. It follows the great control theory of pain. It inhibits the nociception at different levels. So in the first stage of labor, where we keep the 4 pads at T10 to L1, in the second stage, S2 to S4, the pads are placed and it inhibits the nociception and the gate control theory of the pain. So some myths around the labor epidurals. In the last 2 decades, there's many impact studies have shown that there's no association between the C-section and epidural administrations. So there's a meta-analysis and 9 impact studies together formed by Siegel and colleagues, which involved 37,000 parturients where epidurals were placed. Ultimately, it showed that there is no increase in rate of cesarean section or deliveries due to cesarean section during the increased period of usage of epidural analgesia. This graph shows all the 9 studies depicting the graphs, where the epidural analgesia rate is on the x-axis and the cesarean section delivery rate is on the y-axis. There's only a marginal decrease in some studies and marginal increase. There's not even a single study which showed positivity that epidural leads to cesarean sections. In terms of evidence regarding epidurals, the incidence of cesarean section is not affected. The incidence of instrumental vaginal delivery was increased in the past, but with the amount of density and concentration of the local anesthetics used, the instrumentation deliveries have come down as well. Duration of first stage of labor, no difference, and the duration of second stage of labor with density and concentration of the local anesthetic, it's slightly prolonged. All these results are conflicting. The confounding factors being the density of neuraxial analgesia and the sensory blockade and motor blockade, which leads to decreased maternal ability to expulsive efforts with uterine contractions. So this is a slide which shows multiple studies where systemic IV opioids and epidural opioids have been given. On the right side, we see all the odds ratios shifted towards the right, where systemic opioids were used. So clear-cut slide which shows epidural analgesia and epidural opioid intake is very definitive and has a very high safety profile and less side effects. Other methods include Entonox, which is a 50% nitrous oxide and 50% oxygen that provides rapid, safe, short-term relief. It's very reliable. Whenever the woman faces the contraction, they inhale a big breath of Entonox, and it shown to decrease 40 to 48% pain relief for most of the patients. It's very simple to use, simple mask, easily administrable, patient controlled. So patient uses herself. It takes 40 to 50 seconds to get the effect, and the effect lasts for 1 minute. So every contraction it can be used. There's minimal side effect profile for this. The other one is Cevox. It's slightly more complicated because anesthetist should be involved in this. It uses a 0.8% sevoflurane. It has short onset and short offset. Best suited inhalational agent, but it needs a lot of expertise and a lot of equipment to be used in the daily patients. The other forms are patient-controlled analgesia, where a button is given to patients. PCA fentanyl is also used in many other conditions where spinals and epidurals can't be readily administered because of bleeding effects, coagulation effects, or any other side effects. There's no difference in the ABGA scores or the need for naloxone in the newborn when epidural techniques are not used, so fentanyl can be used in those kind of situations. Remifentanil is the newer one where it's widely used in the West. It's slowly coming into existence in our cities as well. It's ultra short-acting opioid, slightly different metabolism with no accumulation either in mother or in the baby. There is placental transfer, but there's extensive fetal metabolism as well. Close monitoring can be done to maintain the sedation score, respiratory rate, and SATs. Oxygen supplementation should be given throughout the remifentanil PCA. So it's very easy to administer. It's patient controlled, and whenever the patient presses button, there is some amount of psychological satisfaction along with the medicine as well. It does act as a bridge to regional anesthesia, easy to administer and safely can be given because we have a lockout interval, we have a bolus dose, and we have a time for the next dose. Couple of other blocks can be used. One is a paracervical block. The aim is to block the transmission through the paracervical ganglion. 2 injections, 8 o'clock and 4 o'clock. It does have some side effects. It's used in the first stage of labor. It doesn't work in the second stage. Some side effects include fetal bradycardia, postpartum neuropathy and infection, and systemic local anesthetic toxicity. The other one, which is slightly easier to administer, slightly easier to give, this can be given for episiotomies as well. It blocks the pudendal nerves, S2 to S4. It's a pudendal nerve block. Provides analgesia in the second stage of labor. Helps in spontaneous delivery and outlet forceps delivery as well. Slightly lesser side effects compared to the paracervical block. The ideal technique has been the epidural analgesia. So many advances in the epidural analgesia as we go into theory of Darwinism. So over the past 90 to 110 years, we started off with spinals in 1890. Then in 50 years, we evolved into continuous epidurals. Then we went to continuous spinal epidurals. And then we went into the current management and gold standard is dual puncture epidural, which is the newest and safest and most ideal form of epidural analgesia. So this shows the Darwinian adventure where we start off with epidural, then continuous spinal epidurals and dual puncture epidurals. So the epidural technique, we go into the skin ligamentum flavum and put a needle into epidural space. There we deposit some drug. Drug doses are being mentioned here. The only difference between epidural and dual punctural epidural, which is a gold standard and most advanced and high efficacy in the recent times. In the last 2-3 years, it's become into existence. We use a 16 gauge 2 needle and then a spinal needle inside that. So what we do is we go into the epidural space and we use the spinal needle to just go into the subarachnoid space and then come back. We don't administer any drug into the spinal space. That creates a rant in the spinal entry point, which is the subarachnoid space. So whatever drug we give in the epidural space, some amount of drug, around 8 to 10%, has shown to go into the spinal space. So that gives immediate and effective sacral analgesia, S2 to S4, to maintain the second stage of the labor. So this is a dual puncture epidural technique where a catheter is passed into epidural space and the needle is passed into the spinal space and taken back. So whenever dye was injected into these kind of comparison techniques like epidural, dual puncture epidural, and combined spinal epidural, there's not much side effects because in the dual puncture epidural because there is not much amount of dye leak in that. The many technique advantages with dual puncture epidural. Location can be confirmed, faster offset, faster onset, sacral spread is good, bilateral spread is good, and catheters can be tested, which is not possible with the combined spinal epidural. Other disadvantages like fetal bradycardia, which is 6 to 8%, uterine hypotonus, which is 8 to 12%, and workload in terms of continuous monitoring, the nurse going to have a look at the catheter, administering different boluses, all these things are not needed with the dual puncture epidural. Other forms of epidural analgesia, patient-controlled epidural analgesia, and continuous epidural infusion. So slightly more expensive, slightly more time-taking, and need nurse support and doctor support to give boluses at different doses. With the recent advances, virtual reality has also been added to the non-pharmacological technique, where it demonstrated that both meditation and interactive virtual reality experiences significantly decrease the NRS, which is the numeric rating scale of the pain, by 26 and 19%. It actually gives a meditation and calming nature and minimizes the physical effort. So absolutely no side effects for these kind of things. The other one is artificial intelligence. It has the potential to monitor real-time parameters, predict the pain intensity, and advanced systems like patient-controlled epidural analgesia, which can be integrated into a central monitoring system. These innovations aim to improve the safety, efficiency, efficacy, and satisfaction of the patient. So the take-home points, we avoid single-shot spinal analgesia techniques these days. Optimal analgesia during childbirth must be tailored for both two patients at stake here. One is the mother, one is the fetus. It should begin as soon as the patient enters the birth pathway. Dual punctual epidural is the most ideal and advanced technique for labor analgesia. So positive birthing experience is a basic right for every woman. So when it is easy, there is no right on us or no rule for us to deny that. So everybody should have a calm, nice, and easy birthing experience. We are not in that era of 1800s and 1900s anymore.
Thank you so much, sir. I thank all the chairpersons for mentoring the session. Moving forward to the next session, I request Dr. Shama Sultana ma'am to chair the session. Ma'am is co-founder of Hope Win Hospital. She is actively involved in programs in adolescence and sexual health and women health care. Next session, below the belt but above the expectation, vaginoplasty and women's health. Speaker for the session, Dr. Vishwanath sir. Sir is consultant plastic surgery at Ramesh Hospital. Sir comes with an international experience and is certified by Dutch Association of Facial Plastic and Reconstructive Surgery, Amsterdam. Over to you, sir.
So good evening everyone. As we come to the fag end of the day, we'll look into a new and expanding and interesting field in the gynecological practice, cosmetic gynecology and intimate wellness. This is a very young and developing subspecialty with new concepts being added and updated very frequently. Roughly, it can be defined as a aesthetic surgery performed on normal female external genitalia in order to improve the appearance subjectively and potentially provide psychological and functional improvements in sexual stimulation and satisfaction. It is performed on women within the normal range of variation of human anatomy with no underlying pathological conditions. Across the globe, we already are seeing a rising demand for these intimate wellness procedures. It's not just about appearances. The gains achieved through physical, psychological, and sexual health improvement can hardly be measured. With more and more newer minimal scarring techniques evolving, the overlap between the branches of gynecology and plastic surgery keeps on increasing. So the aesthetic precision in these procedures matters a lot. We can also add fat grafting and fillers for volume restoration, as in deflated labia majora corrections. We have energy devices like lasers, radiofrequency, and PDO threads for non-surgical tightening and skin and mucosal quality enhancement, and we can use a combination of these for better outcomes. So the next question that comes is, what changes often after childbirth that makes the individual visit the doctor for these procedures? Vaginal laxity, labial hypertrophy or asymmetry, scarring following episiotomy or trauma, pigmentation and aging changes. All these lead to confidence and intimacy issues. In Western societies, even aspects like visibility under the dresses or swimsuits and difficulty in wearing tight dresses because of the enlargement of labia minora also cause the individuals to consult a doctor. This can be understood from the fact that even teenagers come for such procedures in the West. These are the various surgical and non-surgical options available for the intimate area problems. The surgical options are labioplasty, clitoral hood reduction, vaginoplasty, monsplasty, and the non-surgical of the fillers, fat grafts, PRP, and lasers. So, gynecologists are usually the first point of contact. So, they already have a trust built in and functional expertise in assessing the laxity or tightness of the intimate areas in question. So, joint consultations with shared care is the best way forward. Counseling, like any other place, is always extremely important as the results in many cases are not instantaneous, and more so in vaginoplasty. This is because the tightening and return of sexual function after suturing and the pain often lasts for a few months. Usually it lasts from 2 to 3 months. So it's always best to under-promise and over-deliver and make sure the patients are aware of the time interval. New age treatments like PRP, the platelet-rich plasma, and growth factor concentrates are nowadays used for virtually all conditions in all fields, and intimate wellness is no exception in this. Along with the use of plasma, use of fat grafts is gradually on the rise. The biological entities of PRP and fat are supposed to have a host of growth factors as shown. These are expected to be enhancing the quality of the overlying tissues in which they are injected. This is the image of a fat harvesting wherein using a cannula under tumescent infiltration, fat is harvested from the subcutaneous planes. The fat is then processed using multiple syringe transfers and is converted into microfat and nanofat for injection. These are the various cannulas or syringe transfer connectors that can be used in the preparation of the fat. The prepared microfat and nanofat can also be used for facial rejuvenation and hair care also, along with the genital health. Apart from the female genital area changes, coming to the grossly visible changes post-pregnancy, we notice abdominal wall laxity, excess skin and stretch marks, breast sagging or asymmetry, and other fat distribution changes. All these combine to hamper the confidence and self-image of the individuals. These gross changes are dealt with usually a combination of procedures using the fancy term of mommy makeover. Mommy makeover is simply any combination of the procedures like abdominoplasty, breast lift, breast reduction or augmentation, liposuction, vaginal tightening, and so on. Breast reduction. This is one area missed out by many neurologists and orthopedics who treat shoulder and back pains. Huge breasts or gigantomastia. This is just not a cosmetic or social concern, but also a physically distressing condition. Patients keep changing doctors, getting MRI scans, nerve conduction studies, but the cause of a large breast often goes unnoticed. A simple breast reduction surgery enhances quality of life dramatically when done right. So these images depict pre and post-op pictures of mommy makeover. We can see abdominal laxity being significantly corrected. Also a slight breast lift can be appreciated in the same image. This is another image of a tummy tuck or abdominoplasty correcting the laxity of the abdominal wall. Simultaneous correction of weakened recti is often combined with this procedure. So, these are the markings done for the abdominoplasty. The second image shows the markings, whereas the first image shows the plane of the dissection. So, usually the scar lies in the pre-existing caesarean scar, and so it can be considered as almost a scarless procedure. So the umbilicus can be repositioned into a newer place, or a new umbilicus can be created if it is already lost by either umbilical hernias or because of the excess laxity. So this image shows the rectus sheath in the right half, and we tend to stay just above the rectus sheath during the dissection for abdominoplasty. A well-done abdominoplasty often automatically causes the lift of the overhanging mons also. So it can also, and monsplasty can also be done as a standalone procedure. Initial liposuction and a small elliptical excision of the excess tissue gives excellent results. And back to abdominoplasty, when we remove, drains are usually removed on this after day 3 or day 4, and minor complications are very commonly seen in abdominoplasty procedures. This is because of the excessive tension on the wound closure. So the patient is always preoperatively counseled that the complications are likely to be more in this case. A simple suture removal, minimal debridement of the margins, and twice daily dressings will heal most of the marginal necrosis in 2 weeks. So always don't keep the sutures for too long, thinking that they will hold the margins better. The fact is that sutures keep acting as foreign bodies and delay the wound healing. So whatever visible sutures are seen, remove them and do minimal debridement and get it over with. So these results are too graphical and likely AI generated, and so these such sort of results are should not be promised. And so this is a case of abdominoplasty and breast lift. A well-healed scar can be seen below the nipple area. This is very often the case, and the presence of such scar should always be conveyed to the patient before the procedure. Even breast lift also almost always will be having a similar fine scar. These images show markings for a traditional breast lift in the first image, and the second one is a periareolar breast lift. But this periareolar scar, though it is very good and almost scarless, it can cause only minor improvements. Another way of doing a breast lift is using an implant. In cases of mild to moderate ptosis with lax skin and smaller breasts, an implant gives advantage of volume and lift in one go. And the implant is often placed using a hidden inframammary scar. So coming back to intimate surgeries, labiaplasty, it is a surgery aimed to reduce the size or shape of the labia to improve appearance and addressing the discomfort with clothing, exercise, or the like. These images suggest different varieties of labiaplasty for reduction of the labia minora. Yeah, this is a wedge-shaped excision, and this is the excision of the entire edge. And the second image with an inverted V shows a clitoral hood reduction to expose the underlying clitoris. So this is a classification of indications of the edge excision or wedge excision for the labiaplasty surgeries. And this is a case of the deflated labia majora, and such cases here we can see there is a flattening of the labia majora on either side of the labia minora, and this can be better addressed with a fat grafting by injecting microfat into the deflated region. So this image shows both loosened labia majora and minora, wherein reduction of both these labia is planned. This is the immediate post-op image following labiaplasty. So coming to hymenoplasty, the indications are obviously cultural, and this procedure is best done 6 weeks before the marriage with advice of not to overstrain for the next 6 to 8 weeks. The procedure is a pretty straightforward procedure, can be done under local or short general anesthesia, and the hymenal tags are identified, the margins are freshened and sutured in layers preferably. If layered suturing is not possible and the vaginal and hymenal remnants are too thin, even a single layer closure is feasible. So avoid hymenal skin tags which are posterior to the urethra to avoid urethral injury. Coming to vaginoplasty, it is a procedure for vaginal tightening, and it is indicated for aesthetic reasons, a loose vaginal introitus, dyspareunia, or diminished sexual satisfaction. It is essentially can be roughly considered as a combination of posterior colporrhaphy and perineorrhaphy. So here we can, this is the design of the vaginoplasty, two triangles with a common base resembling a diamond shaped marking is made. The base of both triangles is at the level of hymenal skin tags, which is the widest part of the introitus. So the vaginal triangle apex is situated 4 to 6 centimeters from the posterior fornix, and the perineal triangle apex is just onto the perineal skin. So the skin and mucosal triangles are excised gently without injuring any underlying muscles or the rectal mucosa. So after the mucosa is removed, the muscles underneath are reinforced, the bulbospongiosus muscle at the hymenal ring and the superficial transverse perineal muscle in the perineum are approximated and mucosal suturing is done. So the only care that needs to be taken is not to go too deep in the midline dissection. Because of the dense scar tissue, we may go and injure the rectum or the prerectal plexus. So this is a very brief overview of the cosmetic, gynec and intimate wellness procedures. Thank you all for your time. In cases of dryness, vaginal dryness, PRP can be used along with lasers to enhance the moisture of the vaginal walls. No, not really. In such cases, laser vaginal tightening, if it's early cases, laser vaginal tightening will be more useful. If it's extremely lax, surgical is the best way. But in early cases, repetitive sittings with a laser, diode laser is very good. Yeah, PRP and nano fat can be used virtually in all conditions. They just, as I explained, they keep on improving the surfaces under which they are injected. So if you inject PRP or fat underneath anything, under your skin, under the mucosa, under your scalp, wherever you are, the layers above it tend to hydrate better, they tend to glow naturally better, even the hair is supposed to regrow better, so a lot of things. So PRP and GFC and fat are being used like everywhere, anywhere, and yeah, doesn't harm. So definitely they don't cause any negative side effect, so they obviously are pretty widely being used. HIFM chair. HIFM chair is used in stress urinary incontinence more commonly, and also in few cases of laxity also. It almost for every 30 minutes it keeps on delivering a cycle almost close to 15,000 electrical stimulations onto your perineal muscles. So that instead of like we tell patients to do Kegels exercises for all these things, urinary incontinence or for better intercourse or things like that. So instead of that, patients happily they can come sit in a chair for 30 minutes. No disadvantage. Worst case scenario, it won't function, but results are pretty promising. Even for males also, the HIFM chair is being widely used for male sexual health, for impotence or things like erectile dysfunction or ejaculatory dysfunctions. HIFM chair is being promoted very widely, and it, like based on few reports from my friends, it's having pretty good results. Like every 2 weeks they come for a 30-minute session, and it works pretty well.
Thank you, sir. That was a very informative session. You have told everything about vaginoplasty, then breast reconstruction, abdominal. Very nice, sir.
Thank you.
Very nicely dealt with it. Do you have any experience with PRP treatment, sir?
PRP for?
PRP for vaginoplasty.
No, I have seen my colleagues use PRP regularly, but they use it for stress urinary incontinence. Okay. I don't know how it works. Okay. I have seen them regularly using it for stress urinary incontinence, along with some sort of U-shaped thread. I don't know the exact this thing of it. They use it for urinary incontinence.
Laser, would it be better than
for
laser treatment?
Would
it be better for incontinence or for vaginal tightening?
No. I haven't seen them using laser for incontinence, ma'am.
For tightening, can it be used?
Yeah. For tightening, definitely laser multiple sittings, like a space between 2 to 3 weeks, at least 4 to 6 sittings will definitely helpful in mild to moderate cases. In extremely severe cases with lot of rugosities and sort of rectocele herniation minorly, we can see surgical correction is better.
Yeah, this is a newly evolving specialty, and even public awareness is increasing nowadays. We are getting women for all these plastic surgery. Thank you, sir. Thank you.
Sir, for vaginoplasty, if it is done by laser, so at what time they can repeat it?
Every 2 to 3 weeks. The guidelines are not exactly streamlined, I would say. So it varies from surgeon to surgeon. But usually it's every 2 to 3 weeks or even monthly once, depending upon how quickly the patient can come to us. At least 4 to 6 sessions are recommended. Apart from vaginal tightening, it also has the additional advantage of improving the moisture, the dryness of the thing also decreases and enhancing the overall experience.
Will it change depending upon the age? If the age is less,
Yes,
the
obviously
type-
lasers will be more useful in younger individuals because the obviously laxity will be slightly lesser side. There will be more elastin tissues which can be remodeled. Definitely
Okay.
younger.
Yes, sir. Thank you, sir.
Excellent conducting of this CME by Aster Ramesh. I congratulate the organizers for this grand event. Thank you so much. Wish you all the success.
Thank you so much, ma'am.
Coming to the end of the CME, I thank on behalf of Birth and Beyond team, the management committee, Dr. Mamta ma'am, Dr. Karthik sir, marketing team, digital marketing team, everyone who helped us in every aspect to make this program success. Thank you one and all. Food, audio visual aids, marketing, everyone.
IT department.
IT department, nursing department.
And mostly our PGs.
Mostly our PGs.
Apurva and Madhurima. Reena.
Yeah, thank you. Thank you one and all. KLU University for giving us the auditorium. Thank you.
I request our PR head also to come on to the dais for a photograph.
Sir, Vishnu sir.